and then post lunch we have nowadays stentless PCI, diffuse disease, various other subsets are being tackled by drug-eluting balloons. We'll have a session. Then we'll have some live cases coming up. Then finally we'll end up with a newer innovations session where we have first time live demonstration of TAVR valve being done for aortic regurgitation, which will be done from US, and then acute stroke interventions and renal denervation. Those are some of the other things from the newer innovation. That will be a flow of events today. And yesterday hall was full, and till late night it went on. I think 9:30 people will be joining. So with this intro, I would like to request today's chairpersons, teachers of with high regard, and they are in the hall before all of us. That's how we have to learn from them. I request Dr. Professor P. Krishnamurthy sir and Dr. Dayasagar Rao sir to come onto the dais, and they'll be chairing this session of obesity and heart failure. Please come onto the dais, sir. And other panelists, friends, Dr. Bijesh Mittal, Dr. Aman Salwan, Dr. Sai Ravi Shankar, Dr. Karthik K. and Dr. Mukesh, whoever is here, please come onto the podium, please. Some housekeeping announcement, and also for you to get your agenda, if you scan this, then you go to the agenda on your phone, and then you can also, there's a provision to go up and ask a question, then questions get displayed to save time. We have that format. So I request Dr. Krishnamurthy sir to take over and conduct this session.
Good morning to everybody. Thank you for coming on time. We hope more people will come and join. So this is going to be series of talks on obesity and heart failure. As all of you are aware, obesity has slowly crept into cardiovascular management. So now the new term cardiometabolic disorders have come. So first speaker, Dr. Johan Christopher, is going to speak to us on tackling the obesity mountain with Trident.
Morning, respected chairpersons, my teachers in the hall. Thank you, ACVS India and TCT, and thank you, Dr. Srinivas Kumar, for the kind invitation. So today I'll be talking about, I need the slide changer, it's okay. Talking about obesity, and very specifically one of the important tools to manage obesity, which is tirzepatide. So we know that obesity is no longer a lifestyle problem. It's not a cosmetic problem, but it's a chronic, progressive, relapsing, and a multifactorial disease influenced by a whole lot of things, not just overeating. So now we have realized that obesity is as big a problem and as scientific a problem as diabetes and hypertension. Now, the big news is that obesity is a problem, no doubt, but when you decrease obesity, you decrease a whole lot of problems, including cholesterol, hypertension, diabetes, and obviously the liver disorders, MASLD, and even sleep apnea gets reduced. And the good news is that the quantum of obesity reduction has a bearing on the quantum of reducing the risk factors as well. So now it has become a very important problem for us, not just the magnitude of the problem, but the whole host of cardiovascular problems that it can actually decrease. Now, tirzepatide or Urpeak is got both GIP and GLP-1 receptors. It has affinity to both receptors. The GIP is a little more than the GLP-1 compared to semaglutide, which is a pure GLP-1 receptor. Now, no dose adjustment is required for renal or hepatic impairment. And we know that the GIP activity and the GLP-1 activity is all across the body at the CNS, the adipose, the pancreas, very, very similar to GLP-1. One of the big differences is that there's decreased nausea actually. So the upper abdominal problems of GLP-1 activity are actually countered, and it has a decreased pro-inflammatory cell advantage as well. Now, the tirzepatide has come through the clinical arena through the SURMOUNT clinical trial program, just like its cousin semaglutide. And we have a whole host of SURMOUNT trials from SURMOUNT 1, 2, 3, 4, and 5. And 1 and 2 is for people with obesity, and 3 is for people who have 2 is for people with diabetes as well. And Surmount 5 is something that you'll all be interested in clinical practice because there is actually head-to-head comparison with semaglutide. So Surmount 1, what they did was a dose-ranging study right from 2.55, 7.5, 10 introduction at 72 weeks. And the doses less than that give you a similar sort of magnitude of weight reduction. Now, what is important is that 95% of people will give you the 5% weight reduction, which is mandatory for an anti-obesity molecule. And almost 25% of the people will give you more than 25% weight reduction. That means 1 in 4 people are going to get you a really significant weight reduction. This is over a 72-week period. And at every dose, you're getting good weight reduction of somewhere between 95 and 96% at even the smallest dose to the largest dose, which means you're getting benefit across the board. Now, what is more pertinent to South Asians, especially Indians, is that the waist circumference seems to be a bigger problem than BMI, and you will see that you're getting a whopping 20 centimeter reduction at the highest dose with the drug. And the other problem, it seems to be more dominant in Asian Indians, is that visceral fat seems to be a big problem. And if you look at total fat, lean mass, and visceral fat, there's a significant 40% reduction in the visceral fat. What is also pertinent here is when you prescribe the molecule, you must advise. What is also pertinent here is when you prescribe the molecule, you must advise your patients to do muscle strengthening because there is a small but appreciable decrease in the lean mass as well of about 10%. Now, the Surmount 2 trial looked at what happens if you are on the drug and you stop it after a 36-week period. So they had a dose-ranging exercise over 36 weeks, right from 2.5 to 15. And then they randomized the population into the people continuing the highest dose versus placebo. And this is interesting. The people on the URPEAK continue to lose weight. Another 7% over the 20% they already lost over 33 weeks. And this continued up to 88 weeks. But the people who stopped it then gained about 15% of weight. And this is an important story to tell the patients who are asking you how long to take, how much to take, and how long to take. So 15% you would regain if you stop the drug. What is again good in the Surmount 4 trial is almost 5 centimeter waist circumference decrease, which is very important for India. Surmount 5 trial is something interesting that, again, a lot of our clients and patients are asking which drug to take. And if you look at the dose-ranging exercise between URPEAK, which is from 2.5 to 15, and semaglutide, which is 0.25 to the 2.4 dose, they looked at them over a 72-week period. And guess what? 21% weight loss in the URPEAK group and 15% in the semaglutide group. So much better weight loss overall over a significant period of time. And if you look at the percentage of people who are losing weight of more than 25%, is almost 1 in 3. So 1 in 3 people are losing up to 25% of weight, whereas only 1 in 4 with semaglutide are losing that weight. So as a pure weight reducing molecule, I think URPEAK is much more superior, as was shown in the Surmount 5 trial. You're getting better waist circumference reduction as well. And most importantly, what we were not too sure before the Surmount 5 trial is that a host of cardiovascular benefits you're getting, including a 10 millimeter systolic drop, a 5 millimeter diastolic drop, 6 milligrams of HDL increase, an 8 milligram decrease in LDL, and most important, it's an excellent molecule for hypertriglyceridemia with obesity, 35 milligram deciliter, which is equal to some of the best drugs we have, including the fibrates, as well as the icosapent drugs. Now, what about safety? We know that the GI side effects really predominant in the GIP and the GLP-1 analogs. But here you can see in a head-to-head comparison, the upper GI side effect seems to be much ameliorated compared to semaglutide. And here there is a little more lower GI side effects overall. But all in all, both the drugs are very similar, and there's no big red flags. And most of the symptoms, again, are when you do a dose increasing, when you change the dose, and that has to be sort of countered through a very judicious use of the physician, and we'll just talk about it a slide later. What is again important is the big problems of nausea, vomiting are much lower than semaglutide. And you can counter this very well by the simple practice of eating smaller meals, avoiding eating up to the, filling the stomach completely, fatty foods to be avoided, using ginger judiciously, using apple and other fruits, and eating bland food. This is especially so when you're trying to change the dose and up-titrating the dose. Most important, obviously, is fluids. You need to be well hydrated because there is a little bit of dehydration when you start the drug or when you increase the dose. So people can get into a mild AKI kind of situation if they're not careful. Now, how do you start the drug? Yes, we have a range of doses. The initial doses or initiation starts with 2.5 a week, up to 5 milligram, and then it's up to the physician discretion because you saw the data that at every dose after 5, you're getting sizable weight reduction and abdominal visceral fat reduction and waist circumference reduction. So from 7.5, 10, 12.5, and the maximum dose is 15. We saw the data that at 15 milligrams, almost 25% weight loss happens. The important thing here is to go slow, up-titrate over a 4-week period, and at the shift time, you need to evaluate these patients, talk to them, check with them about the side effects, and if required, continue them on the same dose if they're having significant side effects. They have a pen called the Quick Pen. It has 4 fixed doses of Urpeak. It's pre-filled, and one pen has 4 doses, which is good because at the end of the 4 doses, the patient gets to come back, check with you about side effects and what progress he's making in terms of obesity and also a sugar reduction before you up-titrate the dose. So that's a safety feature. So the data from SURMOUNT is very clear that we can get now good, significant, and sustained weight reduction. We're able to achieve anywhere between 23 to 26% at the peak doses over a 88-week period, and the data is also very clear from the SURMOUNT-1 and SURMOUNT-4 from the study. It's as good, if not slightly better than semaglutide, based on what little experience is available, and more importantly, you're getting add-on benefits like blood pressure, waist circumference, triglyceride reduction, and HDL improvement. So thank you very much for your patient hearing.
Doctor, it's an elegant presentation. I've got an opportunity to use this for 4 years since when it was launched because I come from Dubai, and semaglutide for 5 years. So I can just highlight very 2 quick important points. The weight loss is certainly much more with the tirzepatide, but so does the intolerance is much higher. So if anybody who really wants to lose weight, we banged our head many times. We tried to give them semaglutide. They always came back and they said, my neighbor lost much more with the tirzepatide, which is a fact, and we have to accept. At the same time, the GI side effects are not as less as being mentioned in the trial. In the real life, they are much more, and they are more than the semaglutide. They are just my quick comments.
Yeah, some things to add, Johan. One of the things is definitely the side effects are much more. People complain of sulfur, burps. Some of them have very bad diarrhea, acute abdominal pain. So we need to caution the patients because there is a risk of pancreatitis. So whenever a patient has, intractable abdominal pain, do not take it lightly because this guy could be having pancreatitis. So education part is very important. But on the other hand, we did not scare the patients also too much because anything which has an effect should have a side effect. So if somebody is not throwing up sulfur burps, is not having loose motions when they initiate, the drug, that means he's a non-responder. I can tell you there are people who are non-responders to this drug also. Everybody doesn't respond. I have known people who have gone up to 5 milligrams, 4 doses, like 8 doses, and they didn't have a single sulfur burp. So those guys gave up on it. Other important aspect is the long-term benefits of this drug. The cardiovascular and metabolic effects don't come in 2, 3, 4 months. So it's only the long-term users who actually get those metabolic benefits and things like that. Third thing about this drug is it causes a very, very severe aversion to alcohol in many patients. So I have known patients who are like, chronic alcoholics. Those guys don't want to see alcohol once they are on this drug. So
that added good effect.
Yeah. So it has a very, aversive effect on alcohol. So that is why patients lose a lot of weight because they stop taking alcohol. They stop snacking along with the alcohol. And the protein intake has to be good. If you're just taking this drug, and you don't take your proteins properly, and when you are on this drug, you don't actually feel like eating. So it's very difficult for you to educate the patients that they need to take protein. So they need to take small, frequent meals. Diet is also a very important part of it. And patients definitely lose a lot of weight on tirzepatide as compared to semaglutide. But now the costing factor has come in. So a lot of people want to switch on, semaglutide. That's one of the issues.
Just want to make an important point that in this day and age of non-cardiac surgery in a cardiac patient, the patient is on GLP-1 receptor or tirzepatide. It does delay the gastric emptying time, and the risk of aspiration is very high. So the suggestion is that if the patient is going in for non-cardiac surgery, you better stop the drug for at least 15 days. Otherwise,
That recommendation we are doing with the anesthetist.
so otherwise you may end up in a perioperative complication, which otherwise would not have occurred.
Yes.
Johan, another one thing, if you can highlight, that some people start, they'll go to 2.5, they go up to 5. And then suddenly, due to some reason, they'll stop off for a couple of months. So when they come back, what do? You again have to start from 2.5, or you can start from 5 or 7.5.
Recommendation is always start from 2.5.
So again, they have to go. So you should tell the patient this, that if you are going to stop it midway, these 8 injections are all gone waste. So please continue, at least continue for 6 months.
So in real life, actually, non-responders number is quite high.
Yeah.
Up to 15 to 20%. We have had several patients on 15 milligram, and still they lose hardly any 5 kgs or so. So we finally stop. We say it's not working for you. So there are non-responders.
Sir, I
think
think
we'll
we have
move on because-
similar talks. We can have discussion at the end of all talks.
Okay. Thank you. Thank you once again.
Question is after the presentation, so we'll just move on.
Can I call upon the next speaker, Dr. Pankaj? He's going to speak on semaglutide in obesity and CVD, cardiovascular disease. Whether it is good, not so good, or mandatory.
Good morning, my teachers, my friends, colleagues, and thanks to ACVS and Novo for giving me the opportunity. I think we'll go to the slides. So I will be talking on innovator semaglutide. This innovator semaglutide is word used because, as you know, that now is off patent, and now we have a lot of synthetic brands available in the market. And so whatever the data I am talking, evidence is related to innovator semaglutide and not to the brands which are available in the market. So that guarantee we cannot give because they are biosimilars or synthetic brands. So the innovator semaglutide in obesity and cardiovascular disease, how they have translated evidence to the outcome. And basically, as we know that in India, obesity is very, very rampant. And I see after this molecule, I think we really started looking into the obesity now. So whenever there is some intervention or some drug, we start looking into the matter. Like we never used to do urinary albumin creatinine ratio, but when the drug got launched, then we started doing that investigation. Similarly, when there is some kind of molecule is available, then we really start looking into that matter. So before that, obesity management was only for the weight reduction. So till now, the obesity management was only for the lifestyle modification and weight reduction by using diet. So as we know that obesity has a lot of established cardiovascular disease, and here is a case of a 58-year male whose BMI is 33, had myocardial infarction 3 years ago, and I think this is a very common scenario in our country, and has struggled his weight since 40s, fatigue, leg pain on walking, anxiety on recurrence of cardiac events, occasional angina, established cardiovascular disease, dyslipidemia, hypertension, grade 2 fatty liver. He's on aspirin, clopidogrel, atorvastatin, EMPA, and some nitrates. So this is a common scenario, and is one of the very important driver for cardiovascular risk. As we know that obesity is basically a marker of cardiometabolic syndrome. So it is only one of the out presentation, and they are interlinked. And almost 70% of the deaths they are related to overweight and obesity are because of the cardiovascular disease. And while CV mortality has decreased over past 2 decades, the overweight and obesity related deaths have increased by almost threefold. Something called obesity paradox. We know about the obesity paradox, and though they look healthy and charming, but actually they have a lot of problems. That is what we call it as obesity paradox. So overweight and obesity, they impact the cardiovascular system, leading to serious consequences. And the most common problem what I see is heart failure. Is HFpEF, that is heart failure with preserved ejection fraction, is very rampant in them. Once they start coming to near 60s, the obstructive sleep apnea and refractory hypertension and HFpEF, all these problems start gaining very rampantly in them. And many of times we have done their angiograms also, and we found that there is no coronary artery disease or maybe mild coronary artery disease. But they suffer a hell of breathing problem, and that is one of the common problem. And I think they start losing their good health after that time. And there are many reasons are there, mechanisms. I think we'll not go into the details of the etiology, etiopathology of obesity in our country. And there are various genetic and socioeconomic and neurobiological and psychological factors, but they have a definite impact on the cardiovascular system. And we see that on day-to-day basis. So as I told you, atherosclerosis and heart failure, they are the important factors which I see. And the Wegovy, Ozempic, whatever the drugs they have in ASCVD, it was established in SELECT trial. And this was one of the wonderful trial where non-diabetic population was included in patients with obesity with established cardiovascular disease. And this is one of the first trial where you can give patient drug without thinking about the diabetic status of the patient. You need not do even HbA1c. If you think that patient is obese and having multiple cardiovascular risk factors, you can give this molecule without any problem. And they have shown very good reduction of the MACE events by almost 20% reduction and hazard ratio of 0.8. And wonderfully done study, and nicely demonstrated that 2.4 milligrams mediated not only by weight reduction, but there are multi-pronged, something like a pleiotropic benefits with the help of multiple reduction of LDL cholesterol, HSCRP, waist circumference, HbA1c, urinary albumin creatinine ratio, improvement in eGFR, and all these things, substantial pleiotropic effects by 2.4 milligrams. And this is 41% reduction in the primary outcome from the randomization to the first occurrence of 3-point MACE. So within 6 months of the post randomization, very nice benefits were seen. And even if the lesser doses is also, patient had very good reduction. So you need not go to 2.4 milligrams because your patient may not be able to tolerate 2.4 milligrams in every case. But we are seeing the benefits even with 0.25 and 0.5 milligram dosages also. So some of the patients may not tolerate the higher dosages, but we can stop them on the dosages which they can tolerate. So it's not necessary that every patient should be escalated to the highest possible dose. If they can tolerate, yes. Sometimes I have gone further, and if patient is not able to tolerate, we have gone back to the lower dosages which the patients were tolerating. So something like a statin, we give, some patients do not tolerate 20 milligrams or 40 milligrams of statin. What we do, we give them 10 milligrams, the lower dosages, if they are getting muscle symptoms. So similarly, in any pharmaceutical dosages, if patient cannot tolerate, better to give them an advantage rather than stopping the molecule at a lower dosages. So the MACE reduction with changes in body weight considered clinically meaningful, and sustained weight reduction was seen, and has improved the CV outcomes with a high hepatic risk In SELECT trial, they have reduced substantial liver fibrosis with obesity 1, and there is a 34% reduction and MACE reduction was seen in the fibrosis, those patients who have fatty liver. So this is a pre-specified analysis from the SELECT subgroup, and with the score of 4, there was high risk irrespective of the age. So improved the kidney outcomes also, which was in a SELECT trial, and the flow also was one of the study which was shown the benefit, and there was 22% reduction in the renal risk reduction, and we are seeing this in real a case with obesity which we saw. The key treatment objective is to support the sustained weight loss, reduce the risk of cardiovascular events, and improve cardiorenal hepatic risk profile, which ultimately will improve your cardiometabolic syndrome to the level. I think apart from this drug, which has already been proven for more than 10 years now in the market, and I think we have enough experience of using this drug, which is basically proven benefit in our patient. And I think we are well versed with these drugs and should be given benefit to our patient. Thank you.
Thank you, Pankaj. We'll have a discussion at the end of this
Thank you,
session.
sir.
Stay back. Next, Dr. Purnanand. Dr. Purnanand is going to present his work on quality of life, feel anger, and live better with ARNI. We are moving from obesity treatment to heart failure treatment. Dr. Purnanand.
Thank you, respected teachers, my mentor, and the audience. So my lecture actually, according to the plan, was heart failure with reduced rejection fraction, GDMT, and the role of ARNI and Verisuguat in management of heart failure. My slides, please. So, heart failure, as known, is an important risk factor. Is the end-stage heart disease, which many of the patients with various structural and coronary artery disease land up to. And we are all familiar with the guideline-directed medical therapy, which reduces mortality, prevents rehospitalization, and improves quality of life. And sacubitril valsartan and SGLT2 have really transformed the way we treat heart failure. It's not just life-saving impact, but the progression of the disease and the remodeling with the onset of these two drugs. Despite these benefits, GDMTs are not sufficiently implemented, basically because of so many factors related to the physician, related to the patient, hemodynamics, renal function. So the standard heart failure with reduced rejection fraction management involves ACE inhibitors or ARNI, beta blockers, SGLT2s, and MRAs. And we have some more drugs like structural interventions like tackling the mitral regurgitation, atrial fibrillation prevention and anticoagulation, and if there is LVP, there is a CRT and so other things. And the additional therapies like Verisuguat and LVADs come last in the picture. So the 4 pillars, when given in patients, they have a 61% reduction in all-cause mortality and 64% reduction in CV death. And there is an increased life expectancy of 6 years. And yet GDMT is underused in practice. So if you give all 4 pillars, there is a significant benefit on CV mortality and heart failure hospitalizations. So the expected lifetime benefit of comprehensive disease-modifying drugs in chronic heart failure is there is an additionally 8.3 years of event-free survival if you give all the 4 drugs along with the CV deaths and hospitalizations and all-cause mortality. So there is a definite need to put the patients on GDMT as early as possible and see that the patients get the major benefits related to these drugs. Coming to ARNI, it is not only has benefits on heart failure symptoms, but also it causes remodeling and it regulates biomarkers, improves quality of life, has antiarrhythmic effects, and also improves renal dysfunction. The Indian consensus also shows that there is a efficient in both in de novo heart failure, and also it is safe, and it reduces biomarkers and reduces hospitalizations, and there is an improvement in noticeable as early as 8 weeks. So it recommends that ARNI outperforms ACE inhibitors, especially in cardiac death, sudden cardiac death, and heart failure hospitalizations, and it can be safely initiated also. So switch from ARBs and ACs to ARNI is advocated, and overall it favors an early utility of sacubitril valsartan in patients with heart failure. The another important aspect is the optimization of ARNI improves outcomes. So there is a need to escalate the dose as and when the patient accepts and the hemodynamics are in favorable and the renal function is preserved. So the review HF trial has shown that patients who achieved sacubitril valsartan uptitration had a better prognosis than who did not. So uptitration should be done to improve the patient's symptoms and also the quality of life. And patient needs to be monitored for blood pressure and also worsening renal events. So uptitration is one important thing which is need to be taken care of. So it is a progressive disease, we all know, with mortality and significant hospitalization and poor quality of life. While clinical outcomes, we really take point in all HF trials, quality of life is increasingly recognized as an important measure of therapeutic efficiency. Just not prolonging the life, but it is also the improving the quality of life that is very important. So it has been shown that in Alberta Heart trial, which shows there is a 1.5% increase in risk of death and heart failure, rehospitalization, who has lesser quality of life. So quality of life is an indicator that these patients are at high risk of developing more hospitalizations and risk of death. So sacubitril valsartan has shown that there is a better decrease in overall mortality, and also there is a significant improvement in the quality of life when compared to ACE inhibitor or angiotensin receptor blockers. So improving the quality of life is an important aspect of managing the heart failure patients with reduced ejection fraction. So there is another question: does the ARNI, when you put the patients very early, does it reduce the need for CRT or ICD? There is no definite evidence, but patients who have symptomatic heart failure when they are started early definitely has symptomatic improvement and improvement in mortality and morbidity. But in patients with LBBP and prolonged QRS, they need to undergo CRT for a better quality of life. Even after a patient has reduced ejection fraction after the CRT, then addition of ARNI will definitely make the patient symptomatically better. So if the patient is not improving with the quadruple therapy, what is the approach? So first one is you rapidly titrate 4 pillars, and if not, patient is improving after 6 weeks to 8 weeks, then you have to look at other therapies. In this, when the patient is also having low blood pressure or intolerance of GDMT, or if the patient has CKD and rising creatinine, and there is a recurring risk of hyperkalemia, you need to consider versuguat. And if the patient has persistent tachycardia and you are not able to put them on beta blockers, the ivabradine is a choice. So versuguat is a different kind of drug which acts on a pathway like cyclic GMP pathway and improves the cyclic GMP levels, whereby there is a relaxation of the vascular smooth muscle, and on heart it has anti-inflammatory effects and antihypertensive effects and anti-cardiac remodeling effects, and also improves the cardiac function. So you are looking at the standard cardiac function, and you are also adding the therapies which can improve the cardiac function in a better way with a different pathway. So the proposed selection of these patients is patients continues to have ejection fraction less than 40%, and the NT-proBNP levels are around 6,000 picograms per ml, and patient is symptomatic. So this is a subset where versuguat has shown there is a significant symptomatic benefit and also reduced hospitalizations and probable decrease in cardiac mortality. And in some patients, you can use the combination of hydralazine plus ISDN and ivabradine in patients who have sinus tachycardia. And still, digoxin and digitoxin has a role in improving the patient's condition.
So the present clinical positioning for Versuguat is consider GMT if EF is less than 40 and residual risk is there, and if the patient is not tolerating GDMT because of BP, potassium or renal function, and if the BNP is more than 6,000, then it is a drug which has to be used. In the stage of heart failure, stage C is where you place Versuguat when the patient is not improving. And if you add Versuguat to already existing GDMT, there is a significant benefit in symptomatic improvement and tolerance also. And the patient feels a lot better if he is unable to tolerate very high doses of RNA, but you are adding Versuguat for this patient. So Versuguat is being considered as the fifth pillar of heart failure when these drugs are not giving adequate, the four pillars are not giving adequate symptomatic benefit. So the combined Victor and Victoria trials have found that the mechanism of action in 11,155 patients, it has to be the foundation therapy in patients who have heart failure. Though Victor has not shown significant clinical benefit, but the combination of Victoria and Victor trial has shown that there is a definite benefit in these patients in reducing hospitalization and mortality and CV mortality and morbidity. So there is one trial which is a Verina study which has been done in Indian patients. It has shown benefits in reducing cardiovascular related complications, and overall 91% achieved the target dose of Versuguat, and there is a 50% patients are on ARNI, and the safety is well established, and there is a symptomatic benefit in these patients. It is not just a vanity, but it is a vindication that the familiar four pillars may soon give way to five building blocks with Versuguat firmly established as a part of foundation therapy in the ongoing debate for the evidence. So when to consider worsening heart failure, hemodynamic barriers, renal electrolyte barriers, and therapeutic gap. So this is the clinical algorithm. Start heart failure patients on quadruple therapy, 3 months reassessment. If the patient has high mortality and BNP high mortality lane, you go for Versuguat. And if the patient is hospitalized, symptomatic, and you think about ivabradine antijoxin. Thanks for a patient hearing.
We'll move on to the next topic. Dr. Johan Christopher. Adult immunization in patients with cardiovascular disease and heart failure.
Respected chairpersons, fellow colleagues, and my teachers in the hall, once again, thank you for the invitation. Can I have the slides, please? So vaccination is something that is really not talked about when we look at cardiovascular armamentarium in our outpatients. We feel it's just the pediatrician's job to do that. But as you will see, especially in the area of heart failure, that a lot of the admissions are primarily because of an infectious event which has happened, and then the patient gets into the hospital because of that. And so a lot of this can be prevented if you have a frank talk with the patient, and then you're able to initiate these vaccinations early on in the period of the patient's history. So immune function, yes, it's something that really starts growing from the neonate, and it reaches a peak at around 20 to 25. But at the age of around 55, 60, there is a gradual waning off, and this is called immunosenescence. So where all the childhood vaccines sort of wane away and your immune response goes down. And that's the reason we want to focus these vaccines just about at the 45 to 50 age group, because they're so effective in promoting the big six, which is influenza, pneumonia, shingles, hepatitis, and tetanus, reduces transmission, and more importantly, decreases serious infection and hospitalization, which is a big economic load for the patient and for the country. Now, there are a number of barriers, as you can see, and our coverage in India is really negligible. This is data from two big authors in this field. And one of the important things is that we don't talk about it in the outpatient. There is a cost issue involved, and there is no clear guidelines. Now, when they looked at a situation where a doctor would initiate this, and this was a study done over a 1-year period in an outpatient, they found that 71% patients got vaccinated when it was initiated by the physician. Now, if you look at the schedule, this is a little crowded, but basically you will see that there are certain vaccines which are just one dose, especially the pneumococcal one, just a single dose lifetime. And there are vaccines which are exclusive for the younger age, which is especially HPV, especially for girls and young women. And there are vaccines which are almost exclusively for after 50, and I'm going to talk about that a little more, which is the zoster. Now, if you look at medical conditions, now the medical conditions which are the highest risk are there, which is immunocompromised patients, HIV, and here we draw a distinction between the CD4 count. So if you have a CD4 count of more than 200, you get to use the vaccines like varicella and measles, which are actually contraindicated in patients with immunocompromised state because they're live viruses. Otherwise, all the vaccines are generally acceptable. The one I'm going to talk about, the pneumococcal, the zoster, and influenza is applicable to all these patients. Now, what about influenza? So a lot of influenza cases happens, and you'll be surprised that there are almost 3 lakh deaths globally each year. And it's not only the respiratory death, but it has a big bearing on the cardiovascular events and worsening of chronic conditions, especially ESRD, long-standing diabetes, and more importantly, something pertaining to us, which is heart failure. What is even more interesting is vascular events start happening within the first 4 weeks of the infection and then slowly wane away. So you are very, very sort of sensitive in that first 4 weeks of the infection, and that's a vulnerable period. So therefore, influenza is something that needs to be tackled. And the good news is that we have a vaccine freely available. It's a yearly vaccine based on that strain, which is looked at. And they generally come from the Pune Virology Institute. And it's supposed to be given somewhere in the months of July, August, before the flu season starts. And the effectivity is very, very effective. Now, the recommendation is global. The CDC and the WHO recommend this. The American College, again, gives it a class 1B recommendation, and the Europeans have a slightly lower class 2B level C. And our Indian consensus guidelines is out, and we are recommending very strongly anybody above 50 years to take it annually. So the recommendations are out from all the big bodies, and the effectiveness is about up to 60%, with a small amount of local complication, which is there in any kind of vaccination or injectable. Now, moving on to Streptococcus pneumonia, again, it's a very big cause, or rather the leading cause for morbidity and mortality in patients with pneumonias, accounts for the largest community-acquired pneumonia in our country and also globally. And 80% of people in India are vulnerable because they've not had it. And again, something more pertinent to us is that if you're vaccinated, because of the phosphatidylcholine lipid antigen link with the oxidized LDL, the antibodies bind to oxidized LDL and prevent them from going into the macrophages and then prevent them from going to the plaque. So actually, there is a role in preventing plaque rupture if you're vaccinated against Streptococcus pneumonia. Now, we have had previous editions of pneumococcal vaccine, that is a 1323. They all had their issues. They had to be given, 2 of them had to be given 1 year later, things like that. But right now, we are lucky because we have the PCV20, and it's just a single vaccine to be given lifetime. It has the 13 strains of PCV13 and 7 strains of PCV20, and therefore comes in a pre-filled syringe, and it's a one-time dose. Now, the global recommendation, again, from CDC is anybody above 50 years can have it. The American College follows this. The European Society, again, has this for patients with CVD and heart failure. And again, we have Indian consensus guidelines that everybody above 50 should be vaccinated. It's a one-time vaccine. Now, the efficacy is anywhere between 45% to up to 60% in most studies. You have the usual problems, the local site problems, and some systemic problems like fever and arthralgia, but they're usually very self-limiting. Now, more pertinent, and this is something that we have not really talked about much, is varicella zoster. And you will find that a lot of us have had chickenpox in the past, and we usually deal with it well because of good immunity. But what happens is that the virus goes into the ganglion and stays there and remains there and gets activated anytime during the life period of the patient, especially when there's a drop in host immunity, and causes that very significant, very characteristic dermatomal vesicular pustular rash, which should be recognized and sometimes is a very important cause of chest pain. We don't see the patient's chest and we start prescribing anti-anginas. Now, the big problem with the varicella is the host of complications that it comes with. There's post-hepatic neuralgia, there's vascular complications, again, pertaining to our field, cutaneous, ocular, you can have even loss of vision in some cases, and the neurological typical Hunt-Ramsay syndrome, which is there in these patients. Now, global data is 3,000 up to 5,000 person years, and the risk of developing complications is up to 30%. And if you have it once, it does not mean you're going to not have it. There's a 6% recurrence. And we have good data from India, closer home, and up to 80% of patients above 50 years, the incidence is there, right from 15%, and the post-hepatic neuralgia is there in almost 50%. 1 in 2 patients have it. And people who have comorbidities are more affected. Now, if you look at the age versus the herpes zoster, you will see that as you cross the 45 age mark, globally, there's a rise. And this is all because of immunosenescence, which is there. And if you look at the patients who have cardiovascular disease and CKD, those are the kind of patients we treat, there's a marked increase, almost 12 times more than somebody who did not have these problems. So people at a higher age, people with comorbidities are more affected. Now, if you have more than one comorbidity, there is a 1.5 times increase in the incidence of the herpes zoster and also in the complications. And once you cross 65, the same complications again go up by a significant margin. Now, what is interesting is this bidirectional relationship between the virus and the chronic condition. So if you have a chronic condition, you're at a high risk of getting this virus. And if you have the herpes zoster, there's a high chance of you getting a vascular event. This is all because of the huge inflammation that is there throughout the system during this time. And what is also pertinent, and this is data globally and from the US data, large number of patients, a large number of studies showing that the first 2 weeks post-virus infection, you are at the highest risk for vascular events, especially stroke and myocardial infarction. And then it gradually wanes off after a year period. So patients who have had the infection need to be taken care of very carefully because the vascular events goes up. The same thing happens in the MI space. And this is again global and American data that the first 3 months are very, very vulnerable and your risk of getting a vascular event is very, very high. Now, this is a non-live G subunit vaccine and it uses an adjuvant system, which is very important because the adjuvant system gives you a much longer period of the vaccine. It's given at 0, 2, at 2 months, but the second dose can be delayed up to 6 months in case you default on the second month. The good news is that after these 2 vaccines, you're getting almost 95% efficacy and not contraindicated in patients who are immunocompromised, post-liver, post-cardiac transplant, etc. And it's indicated specifically for people above 50 years of age. Now, the good news is that it has an antigen in 1 bottle and the adjuvant. So it comes as actually 2 bottles. So you need to be careful and tell your nurse that both the bottles have to be mixed because the antigen and adjuvant system work together. And you can see there, it gives a much stronger and broader immunological response. Now, they've looked at people around the 50 age group and they've followed people above 70. And these are trials that have been done globally, North America and Asia. And they found very, very good efficacy of almost 97% in the 50 age group and almost 91% in the 70 age group. There are adverse events, and these are usually small. They're local most of the time, and they're there with all the other vaccines, and no major systemic effects are seen. Now, when they look at the 11-year data of follow-up, after giving the vaccine, they found that almost 80% at the end of year 6 is the efficacy, and almost 88% when you look at the entire event from giving the vaccine to about year 6. So that is the high level of efficacy that the vaccine maintains. We have India data, which is a small number, 288 patients, phase 3 study, and they found that they got an 85% efficacy for the vaccine. Now, the recommendations are global across, and we have our own Indian consensus guidelines. Talking about giving the vaccine more than 50 years of age, which is what is there in the Western world. So in conclusion, the American College is giving a very strong recommendation for influenza vaccination once yearly, pneumococcal vaccine with the new PCV20 once in a lifetime, the COVID vaccine, of course, this was up to 2025 for people who are exposed, and the zoster vaccine, 2 doses, 02 or 06 for anybody above 50 years of age. The same strong recommendation comes from the European Society as well, and we follow the European Society, and we are recommending all 3 vaccinations. Thank you very much for your patient hearing.
Five minutes for discussion. So any questions from the chair?
The question is that these are in the guidelines and especially the influenza vaccine, but how much is it implemented? Let's say in our own practice, for example, your practice. So are you routinely doing for all patients? Are you subjecting them to influenza vaccine yearly? Are you emphasizing all of us? I mean, we are not doing it. This is what I believe. There's a big gap.
Yeah, over the last 5 years, good question, sir, because as you can see, the Indian data is actually negligible in terms of adult vaccination. But what we have done as a group is that at least I've taken August 15th as a very important day. And we are trying to make sure that at least influenza vaccine is given to all our patients. The reason we have taken August 15th is by end of July, we get the new strain from the Pune Virology Institute by end of July. So by 15th, most of the old stocks are taken away. And 15th, of course, is the Independence Day. So I make it a very important point to tell all my patients, and not only the patients, their family members. I said, use August 15th as a good opportunity to vaccinate your whole family. And that's going to give you not only good health, but a lot of economic benefits because you don't get admitted. Specifically, obviously, we're focusing on our pretty large heart failure population who are really vulnerable. But yes, anybody with, we are trying to make it universal for most of our patients. We have not been very successful with herpes zoster, but that's just because of our awareness. But now we're trying to push that as well. But there is a cost involved in that. It's almost 22,000 rupees for both the vaccines, so it becomes a little expensive. The influenza vaccine is about 2,500.
See, the data is a little bit not very clear because the heart failure study with influenza vaccine was negative. And in the US, the data comes, majority of the data, whatever we're talking about, comes from the US. Any patient who dies from a respiratory illness, if the cause is unknown, it's listed as a flu vaccine death. So there is a little bit of nuance on trying to believe that it is truly related to flu or not. In the flu season, if any patient dies in the hospital, it is listed as, that's why the data shows, as you know, Mike, 60,000 deaths per year, much more than what COVID has ever done to United States. Is probably flu has been listed as that. So physicians, I don't know whether Mike, your place, we lose our license to practice if you don't get a flu vaccine every year. It is a mandate. You are fired on ground immediately. In the beginning, there used to be religion, my belief, and all that was allowed. Now they don't allow anything. You're outrightly they give you a 3-month window period to get the vaccine. If you don't get the vaccine, your job is gone. You're fired on spot. No, you just leave. Because physicians, it's mandated. But for the general public, I mean, what we don't do is we tell them to take vaccine, but we don't tell them to wear a mask. We know the mask is much easier to wear if you can, and especially when we are coming close. And during COVID, we wore it, and the number of flu deaths were much lower. And now we stopped wearing it. It's going up again, you know.
Thank you. Thank you.
My own practice is all patients above the age of 6 months. I've been doing it for 20 years now, except when there is egg allergy. Because flu vaccine is out of chick embryo. But in US, they have a vaccine coming out of cell cultures that you could still use. So vaccine allergy, egg allergy, contraindication, but otherwise everybody.
So my question is to Pankaj. Pankaj, are there any newer drugs coming in for after semaglutide and tirispide? Any newer drugs coming in for in that gamut? Because we hear that glucagon inhibitors and some kind of drugs coming which will not make you lose your muscle mass and only act on the fat.
lot of new drugs are there pipeline. Now we have a drug which will acting on GLP, GIP, and glucagon like peptide also. So there are many new drugs are there. I think those new drugs will definitely, oral tablets are also coming.
Yeah.
So all these things will highlight are in pipeline.
So retatrutide is the one which is available, is still off-label, although it is not been launched by the original company, but it is available. It is 111 and supposed to be better.
Is it available in UAE?
It's available,
Oh.
yes. And one comment is about Arni, because I realized that Arni is not yet approved here as antihypertensive, but it is properly been approved by FDA for more than 1 year to be used as antihypertensive, 200 milligram once a day to start with, and can go up to 400 milligram once a day. It is a once a dose as antihypertensive, while for heart failure, it is twice a day dose. Thank you.
Is Arni approved for hypertension
Yes,
in
sir.
India?
No, sir. I'm surprised it was not, because we are using it as
The
antihypertensive.
talk is there pre-lunch, sir. This about the new drug, it is there pre-lunch, the talk. Thank you.
Thank you.
Yeah, I think after that interesting discussion about obesity and heart failure, thank you, Chairperson. And now we'll go on to the Tower session. It's interesting that you have none other than Dr. Eberhard Grube, who is originator of concept for this, and it's very fortunate to have him, and we'll have his sharing experiences. Other important thing, who unfortunately because of health reason, because of his schedules, he couldn't be here, Dr. Samir Kapadia, but still in spite of his night, he agreed to stay with us. We'll be there online. And then I've requested Dr. Ramesh Dagupati, and I request Dr. Manoj Agarwal, my colleague in hospital, great support and very enthusiastic and very honest, knowledgeable cardiology practitioner, also well versed with Tower. Please, Manoj, come onto the podium. Other panelists, Michael Bench, Karthik, Sumanta, Rutuparna Barua, Jayanti, Ravikant, whoever is here, Kamal Sharma, please join onto the podium. The flow will be, we'll have initial talk by Samir Kapadia, then we'll have the live cases coming up, then again we'll have live case learnings. That will be the flow. With this, I request Eberhard Grube to initial comments, and can you correct and make Samir also project onto the screen? And then over to you, Dr. Grube, sir. He'll come the slide. Thank you, Dr. Samir, sir, for your sparing time, and it's night in there, and still you agreed to be there with us. Again, wholehearted thanks for the continued support. Thank you, sir.
Thank you. I'm so sorry that I could not join in person. As you know, every year I've joined in person, and this is a big loss for me, but I just could not do it this year for some personal reasons. And thanks for inviting me online. And thanks, Ramesh, Dr. Grube, and all the panelists there. So if it's okay, I can start the presentation. Can you see my slides?
Yes, we can see, Samir. Thank you very much for joining. Yeah.
Of course, my pleasure. So I think in next 10 or 15 minutes, I'm going to talk to you about the Tower, that how things are, and what we need to, what we are doing in 2026. So I just want to put a historical slide here. So you see here that, Leonardo da Vinci started the concept that the aortic valve exists in 1512. Then it took 150 years to get the first time that the aortic valve can get stenosed. And then it took 300 more years for the first time for, Dr. Starr Edwards' valve by Dr. Harkin to be placed. And then, so you can imagine that how many different generations have to pass by before the aortic stenosis was recognized, and how long it took to treat it first time. And now just in 30 more years, so we are talking 30 more years, Henning Anderson came up with the patent for valve replacement without opening the chest, and this was the SST, then became the PVT, and then Cribier developed and implanted the first valve in 2002 in a bicuspid aortic valve patient. So remember, the first TAVR was done with the bicuspid aortic valve, antegrade, and actually the patient did well. I just want to remember Dr. Cribier for his wonderful contribution. And then, first, this is also interesting to note that when we started talking about aortic stenosis, this Dr. Braunwald, who also passed away, depicted this particular graph to say that, as soon as you start developing symptoms, either angina, syncope, or heart failure, your survival is terrible. So they said that, it was 3 years, depending on whether 1 year, 3 or 5 years, depending on what symptoms you had. But the interesting part is that it was only 12 patients with hemodynamic data and 53 patients with necropsy study. So just that small number led to this kind of a publication in 1968, just by the time we were probably born. And then you look at here that we tried to do the study in the United States, and this was the Partner 1 trial, and we published the 5-year data. But the interesting part of this was that FDA asked us to randomize patients, despite knowing this information, but again, small number of patients, to say that we should try to treat them with whatever medical treatment we have. We, of course, used the aortic valvuloplasty, which did not work. And interestingly enough, 179 patients were randomized in the control group, and only 1 patient was alive at 5 years without AVR. So it's a very terrible experiment. I personally also enrolled so many patients, and this was a terrible experiment to do, but that led to the first time approval of the TAVR valve. The average age was 84, and still 49 patients were alive in the treatment arm, with 42 with NYHA class 1 and 2. So amazing data that led to the approval of TAVR. And the question is, now it is a standard of care, and why did this happen? Again, the main reason why all these things happen is because there are very important and exciting trials, one after the other, all published in very reputable journals, to say that how the TAVR was comparable to the gold standard of surgery. And now all the patients are being reported in the TVT registry. This may change, but currently all the patients in the United States are reported in the TVT registry. So we can actually see the data that what is happening. If you look at this graph, it is very interesting to say that, mean driving time to get a TAVR in the United States is only 60 minutes. And SAVR is still 44 minutes, a little bit less than TAVR, but still very, very comparable. And if you look in the middle of the nation, the driving distance may be a little bit more, but in the coasts where there's a large population of patients, the driving distance is really, really short. When we started, this is also important to know that in Cleveland Clinic, when we started, our surgeons suggested that, when we have the first death, we will talk. And we could do in Cleveland Clinic, this is the data we published, to say that first 262 patients we did from 2006 to 11 or so, we had 1 death, we had 2% stroke rate, we had 10% vascular complication, and major bleeding of 5%. It was still a little bit better than most other places at that time. However, this was the beginning. And typical access in 2012, I have one picture from 2012. So there's a very large sheath. We put a venous sheath, we put a crossover catheter and a crossover sheath. We even put another venous sheath to say that in case we need to go and pump. So a very involved procedure that was happening. And now, where are we today? So today, of course, there is a room, which is in Cleveland Clinic. We're still doing in the hybrid room, but there's nobody there. We have only 1 groin access, 1 radial sheath, which we put the Sentinel device. We are doing 700 TAVRs currently, and there are about 2 or 3 times that a year that we need to use some unfortunate event happens and we need to go on a cardiopulmonary bypass. So that's why the cardiopulmonary bypass is available. And we are deploying with a conscious sedation without any Foley, any other catheters or anything like that. The valve, we analyze the valve, and then we discharge the patient same day. So the same day discharge, this is 2020, that we were, or the first time we started doing it in 2020, we were discharging 22% of the patient the same day and another 60% next day. This includes all the patients, so patients who are already admitted to the hospital and things like that. So there are some patients that we keep them in the hospital for a few more days. These are all valves also. Nowadays, we are, for the same day, we are about 50%, and the next day another 30%. So this graph has become more of this for the same day and this for the next day. So the change is real, that we are no longer the sternotomy versus TAVR has really happened, that people are treating aortic stenosis with transcatheter valve systems. I just put this to put it in perspective that there are several different hurdles and still exist, some of them, and still important to know that what are the important hurdles, including complications, economics, and then durability. All of them are important hurdles for TAVR. And if you look at the paravalvular leak, of course, the paravalvular leak has decreased with all kinds of valves and all better valves plus better PVL guard. And if you look at the most recent data, that it comes out to be 2%. But still, this is important to recognize that we got to be very careful how we report it. Many people do not do completion aortogram. There are many centers where even the echocardiogram is only available when absolutely necessary. So this is a little bit of a challenge, because if you're going to do a procedure, we want to do it in such a way that we assess the aortic regurgitation well during the procedure. Also, as you see, the aortogram allows you to know whether the second valve is going to be possible, where the first valve is, or how well it is expanded. And we do it in a biplane so that we can see the expansion in the IO and the LAO view and the relationship to the coronary arteries, STJ, etc. Hemodynamics is very important. So again, hemodynamic assessment should be done to say that this is a simple idea to do an AR index. You also look at the dicrotic notch. There are a lot of different ways of doing the AR index where you can utilize the heart rate, etc., to correct for the diastolic pressure versus the LV and diastolic pressure. I myself also like to, of course, do the echo, but with the echo, you can also decrease the aliasing velocity. Sometimes you can use injection of the saline to see that if there is mild AR or not, because many times, especially the self-expanding valves, the AR is difficult to assess because the velocities do not drop suddenly because there is a long area of apposition of the valve in the self-expanding valves. So, as I said, the PVL quantification still is a challenge. If you look at the stroke outcomes, so stroke also has decreased considerably. The P3 was 0.6, low risk core valve was 0.6. If you look at the sentinel control group, it was 2.9, TVT was 1.4. And then if you look at the, compared to SAVR, we have reached it in the sense that the TAVR strokes are less than SAVR strokes, especially the major strokes. If you look at this is the analysis that we did, including all the partner trials. However, as you know, that the two trials of emboli protection, the US trial, and this is the trial from London, England, the BHF TAVI trial, both were primary endpoints were negative. However, in both, there was decrease in the disabling stroke, statistically significant in the protected TAVR, not so in this BHF TAVI trial. However, when we look at the US population alone in the protected TAVR, the trial was positive of primary as well as disabling stroke, all strokes as well as disabling. Outside of US, it was not. We couldn't figure it out why it's happening. If you look at Cleveland Clinic experience, we saw similar 3,000 patients. Again, in the 3,000 patients, if you look at that, there was 15 patients with stroke, 1.4%, 8 patients with stroke, 0.4% when we use Sentinel device. And the 4 patients that had the stroke with the Sentinel device, nobody died, whereas 15 patients who had stroke without CEP, 4 patients died. And this is just to put in perspective that, as I said, we are doing roughly 700 patients a year. These are 5,000 patients over the last 8 years. And if you look at this, the mortality has been 0.4, stroke is 0.3, AR is 0.3, and new pacemaker rate is 3.4. This is all different types of valves that we use. So again, outstanding procedural outcomes are possible to be attained. For the heart block, because I said that the pacemaker rate is low, I think there are several papers now coming out to say that why there is a different ways that we deploy the valve. Bottom line is that we have to deploy the valve high. Again, when you put it very high, you have to make sure that you can put valve in the future. This is an interesting analysis to say that how the non-coronary cusp and left coronary cusp are, the commissural line is aligned to the interatrial septum. So if it is a clockwise rotation or a counterclockwise rotation, and it is interesting to note that when there is a clockwise rotation, it is possible that we can have a left bundle branch block easier than otherwise. So high deployment is very important, at least for in our situation. We could decrease the pacemaker rate from 13% to 5%. This was an old study. And nowadays, we are even better than this, as I showed you in the other slide. And it is true for both kinds of valves. I also like to do this thing that to put a pacemaker, pull it out from the apex and put it in the RA, and then pace in the RA 90, 100, 110, 120 beats per minute gradually. And if they can conduct 1-to-1 in the ventricle, then we can discharge the patient, at least for the balloon expandable valve, on the same day. So this is another important thing that we have learned. And we published this, Amar Krishnaswamy from our group published this with the Italian group. The vascular complications have definitely decreased. And I also like to do single access in the sense that we put the first access at the high common femoral artery. And then the second access is placed just about 1.5 centimeters below the primary access. Again, with either ultrasound or fluoro. And so it looks like this. So this is the access where we will use with one per close. And then this is the access through which we'll inject. And this is the pacemaker. And this is the sentinel device. And unilateral access, we published this, is very safe. If you have a problem in the unilateral access, it's very easy from the bottom sheath, just dilate the top part. So it takes very little time. And it is almost better. Single per close is also good because at the end of the procedure, you can put a second angiosil device. So per close plus angiosil works very well for the minor bleed. And then the last is the coronary occlusion. We reported this case that we saw very, very earlier on to say that how the coronary occlusion can happen. We could perforate the leaflet and save the patient. Patient did well, but we came up with the same ideas that are now available to say the small sinuses, middle of the cusp, low left main, and large amount of calcium. These are difficult. A lot of different methods to do basilica or we can do the unicorn procedure. If you look at the economical hurdle, this is a very important. I don't have a solution for this. So if you look at the SAVR, the device cost is $4,000 to $5,000. So hospital reimbursement is large. And if you look at the TAVR, the device cost is very high. The reimbursement for both are very similar. So the margin for the SAVR is very high. Margin for the TAVR is very low. This is the situation in the United States. So this is where now the hospitals are struggling, where the SAVR volume is decreasing and the TAVR volume is increasing. And finally, I want to say durability data. So there is a lot of data for the durability, but the challenge with the durability until we had the randomized trial is to say that what are the different ways we judge the durability. There is FDA had approved different valves with 11 different definitions. These are all FDA definitions. And so when you look at the valve durability, as you see with all the approved valves, there's all different follow-ups, all different age groups, and all different SVDs depending on the definitions that they used. So we concluded that you got to have a single definition. So now we are using the valve 3 definitions. Some people think that this is also not 100% foolproof in the sense that it is a little bit stringent. So it is necessary to have a standardized definition. And I think currently we should use VARS 3. Is it similar for both the trials? As you know, in the partner 3 trial, the endpoints are similar, but as you see, the curves are getting close at 7 years. The gradients were very comparable at 7 years. In evolute data, there was a little scare raised there because it's 6 years and it's 7 years. There was a little bit more incidence of TAVR valve, structural valve deterioration, and this was thought to be related to the post-dilation, aggressive post-dilation of the valve. Redo TAVR is a very important thing to learn, that what will be the neoskirt, how high you want to put the valve, what will be the leaflet overhang, what will be the hemodynamics. If you look at the first valve versus the second valve, the outcomes are very, very similar. Hemodynamics does show that the gradients is a little bit higher. And then we are studying a lot of new areas. So this, as you know, the early TAVR trial was positive. But again, whether in asymptomatic severe AS, all patients should be treated early or not is still a class 2A indication, and mainly related to the fact that how we determine the symptoms and how asymptomatic the patients are. But more and more people are being treated earlier for severe asymptomatic AS. The only criticism of the trial was that patient knew that they are severe AS and they were being followed. As you know, the bicuspid aortic valve, there are a lot of low-risk trials that are ongoing now. So the Navigate trial has started. The Believers trial also has started. These are the 2 trials. Both of them are all over the world, and they are randomizing patients against surgery. As you know, there are 4 different valves being tested in the United States right now. So the Seagull valve is the valve that is a 8 French valve that is going through the groin, and it has the different alloy that allows you to see the rhenium. The valve is very radio-opaque, and it is very strong, so it becomes circular. It's a porcine pericardium valve, and it has now been studied against the commercially available valve. DuraVar is also a very exciting valve because it has a single leaflet fashioned in a way that there's a laminar flow, and the valve has good, excellent hemodynamics. So it's also being tested, and also has a commissioner alignment. Both valves do, and so this is also being tested against the commercial valves. SAPIEN X4, as you know, the data are not published. And then for the pure aortic regurgitation, now we have an approval of the Jena valve in the United States. As you know, the data are promising. Now we are also doing a low-risk trial for the aortic regurgitation against surgery in the United States. So a lot of excitement is happening. I also put this for the Cleveland Clinic side that, it was for me, it has been a great journey because of a lot of colleagues that are sitting there in the panel, a lot of nurses, fellows, and also training young people. So Grant Reid, Amar, Rishi, all of them are now our new TAVR group. So every year we have been able to publish close to 40 to 50 papers in, if you just search Cleveland Clinic and TAVR, this is the number I get. So this also is a great achievement that we are able to build on the initial passion of TAVR. So there I'll stop, and then we can take questions.
Good morning or good evening, Samir. We're missing you here. And for the audience, hi. For the audience, I have to say, my well-being, I really, in a great part, owe to Samir because he gave me some tips on what to do and not to do in life. Many things are important, some are less important. So my well-being, I owe to you, Samir. Thanks very much. You gave a very, I'm still following your advice. I don't tell the audience what, but I still follow your advice. Having said that, you gave a very thoughtful and very comprehensive talk about our challenges. And I'm glad you didn't give my talk, because in 30 minutes I have to also talk about challenges, but thank God, I focus on something different. Let me ask you two things. Obviously, and you brought it up, cerebral protection, many things we can resolve with randomized trials. And I have to say, I'm still angry that whoever started it, whether it was Boston Scientific or some trialists, needed the answer for embolic protection. And basically, if we look at it a little bit more carefully, they basically killed these devices. Many of those have to close down because lack of financing. We have still one that's being used. And don't you think that some of our issues, mainly cerebral protection, we will not be able to resolve with a randomized trial for various reasons, which we don't need to talk about now, but it's very unfortunate because even your number, and I looked at it, your stroke rate is 0.3%, very, very low. But for the one that has it, it destroys the life. And therefore, I'm still a big advocate of what you taught us about using those devices, regardless of indication, regardless of anatomy. Now we have to select due to prices. Would you be so kind and allude to that a little bit more?
Sure. So very good point. So you are absolutely right that the randomized trials really hurt this field. The question is that I'm working, and Raj Kharbanda is working to come up with something called as a Sentinel score to say that which patients we can use the device and that it will be beneficial. And so we are coming up with the score and testing it in each other's population to say that if the score is valid or not. So very soon we will find in the literature some kind of a guidance to say that from these randomized trials, what are the patients? And these patients could be, whatever way we select, is it the amount of calcium, bicuspid valves, some kind of, self-expanding, balloon expandables, whatever the different things are. But we will come up with some nice algorithm for different people to use if they cannot use it in all patients. I personally still use it in all patients. We are paying for it because the US government, as you know, is not currently reimbursing for the device. So financially, this is a challenge everywhere. But this is, I agree with you that this is a sad situation because we should be able to see newer devices, newer valves. And if you look at this, we have 10,000 patient randomized trials that we didn't even do for approval for the TAVR valves. Yeah. Now we are trying to do 10,000 patient trial for a Sentinel device. This is just a sad situation. But again, everything has a good side. So hopefully we'll come up with something nice.
Yeah, thank you very much. I don't want to dominate the discussion, Samir, but one quick word about AR. Obviously now with the valve available now in the United States, do you think that the market, basically AR was undertreated for various reasons, not only surgically, but also particularly in TAVR. Do you think that the market actually will grow having a device that works well in AR?
This is also a tough question. In our situation, we are seeing this, about 5% of our patients. So it's not 20% of our patients. So this is where total TAVR volume to the AR volume. Of course, AS plus AR different. I'm just showing pure AR. So it will grow hopefully. But as you know, the device is outstanding, works very well. But the size of the annulus, size of the aorta, size of the length of the ascending aorta, all these are still has to meet the criteria. So many patients who have AR also have aortopathy and also have dilated annuli. So this becomes a little bit of a challenge. but I'm not so sure that how much this is going to increase. I'm also thoughtful and watching our patterns, but we are not finding a very large number of patients referred. So maybe the awareness still is not there, or so we have not yet seen it. Hopefully, very soon we will see some more awareness and more patients, but still it remains about 5, at the most 10% of the patients that we see for TAVR evaluation.
One more thing, Samir. You know, the other person that you give advice to do something good for his life is Sushil Kodali, as you know, one of the co-directors. You know, he needs a little bit more rest because he's overworked the 2 days ago and yesterday, so a little bit more rest. But I'm not sure whether he follows your advices because he's not that strong that we thought he would be. So thanks for your advice as far as my health is concerned, and thanks for appearing here. So any other points from the panels?
No, I think we are good. No, you have time. Thank you very much, Samir, for this fantastic presentation. So
we miss and love you.
Yeah, love you too. Thank you. Bye-bye.
Thank you. Thank you.
Yeah, so we'll move on to the live cases. We have 4 live cases, 3 live cases and 1 live in box. So let's go ahead and start with Dr. Amit Chaurasia at Artemis Hospital in Gurugram. Amit, can you hear us?
Hello.
We have Dr.
Yeah, I can hear you, Ramesh. How are you?
Yeah.
Morning, Ramesh. How are you?
Yeah, very good morning, and thank you for showing a live case. We have Dr. Sushil Kodali, Dr. Manoj Agarwal, Dr. Michael Benz, and Dr. Eberhard Grube here. So Dr. Eberhard will be the man who will be speaking up for, he's showing a self-expandable Evolute the Pro Plus valve. Go ahead, please introduce your team and case.
Good morning, everyone, and welcome to live case by Artemis Hospital. We'll be doing Evolute Pro FX valve today. With me, I have my team, Dr. Nikita. She has been with me for almost 8 months now. Then there's Deepak. There is my nursing staff of a year. I have my echocardiographer, Dr. Mehrotra, who has been, I think, running around the circuit in structural heart throughout India for showing his echo skill. Then we have our anesthetist, Dr. Asis, who will be assisting us. And I have Agam Jain, who will be loading the valve from the Medtronic side. So directly, let's go on to the case. The case is an old male who is a diabetic, had inferior MI in May 2025, underwent PTA2 circumflex. At that time, he was detected to have severe aortic stenosis with good LV function. He was told to have AVR, but the patient was not willing to undergo any kind of surgery, and he was kept on medical follow-up. Slowly, he had this progressive dyspnea, and right now, last week, he was admitted with the LVF in our hospital. He was stabilized, and we gave an offer for both surgery as well as TAVR to him. He chose TAVR for his condition. Next. So you can see the ECG. The ECG basically it shows LVH with a strength pattern with some RBB, incomplete RBB like ECG. Next. The gradient is pretty high with a mean gradient of 71 and the peak of almost 100, more than 100. You can also see that he doesn't have any kind of MR. There is some trivial AR in this patient, and the EF is good, very hypertrophic ventricle. You can also see the septum is severely hypertrophic in this case. The angiogram was essentially normal with the patent stent in the LCX, and LED was flowing pretty well. The right was pretty good. Large artery, no problem in that artery. We did a MHCT analysis. Next slide. And you can see that the perimeter-derived diameter is 23.5 with a minimum diameter of 19.8 and a maximum of, I think, 26. Very difficult to read from a long distance, but anyway, from whatever I can remember. The sinus of vessel wall is above, previous slide. all above 30 millimeter in diameter. You can see that one of the cusp is almost fused. It looks like it is a type 1 bicuspid aortic valve. LVOT is elliptical in shape. Again, the diameter is 23.5. The minimum is 16 and the maximum is, I think, 27, 28 in this case. You can see there is some calcium on the STJ. Can I go to next slide, please? You can see the intercommissural distance is 22.3 or 4. At 4 millimeter, the valve size is again about 23, but at 8 millimeter, it is around 21, and it is a heavily calcified valve, as you can see. Can you go to the next slide? The left coronary height is 13.5. The right coronary height is 21.2. You can see there is chunk of calcium on the left leaflet as well as on the right leaflet. There is a chunk of calcium that runs from the cusp into the STJ on the NCC side. You can, previous slide, you can also see there is a huge septal hypertrophy that you can see in that right coronary segment. There you can see that the septal hypertrophy is very, very large in this case. Next slide, please. Both the femorals are okay, but the femoral in the right side has a high bifurcation. It's quite tortuous, and just at the bifurcation, the size is slightly small, though it looks like 6, 7, but there is some kind of ulceration at that part. On the left side, there are a few calcium here and there, but then the size looks quite good. And if you look at the tortuosity, it looks better to go from the left side in this case. So I'll stop at this point and allow the panel to have a few discussions regarding the size of valves and what should be the size in this case. So Dhruve, hi Dhruve, morning, how are you?
Can you hear us okay?
Yeah.
Yeah, I can hear you.
He's asking.
So
I listened very carefully, and thanks. I just didn't want to interrupt your introduction. Sorry.
So I guess, Ramesh, go ahead.
Yeah, so I mean, I think in summary, it is a 67-year-old gentleman with severe aortic stenosis, heavily calcified. Why surgery? Why not surgery? And what type of valve? These are the two questions. Obviously, we say that in the US, anyone above 65 can be sent to TAVR, but there's still a lot of things where the patient is low risk and intermediate and high risk. So low-risk patients are enrolling we can enroll them in an Envision trial, which is with the Abbott 10-year data we are trying to collect. But in any of these patients above 65 years of age, they can be seen by both cardiac surgeon as a heart team and decide what is the best for the patient. So then the next thing would be the valve type.
Yeah, no, I think the issue, I think you said in the slides that patient was advised for surgery, but refused. So I think that's an important component. I mean, I guess the real challenge is to explain to the patient pros and cons, but I think if there's an adequate discussion, then I think it's reasonable. But I mean, I agree with this type of calcium in a 67-year-old because of lifetime management things. We'd often agree with surgery. In terms of the type of valve, as you're saying, Ramesh, we had this discussion last night during a live case. The anatomy is calcified but suitable for multiple different valve types. And so, I mean, I think you could argue to do any one of them. My strong feeling is I often do this first valve as a balloon expandable because then I think it facilitates the second valve. And I think that's that's just mainly not because of the result from this first case. It's when this, in 10 years when he's 77 or maybe longer, hopefully, but the valve fails, it'll be easier to do a valve and valve, at least based on the technology we have with doing a balloon expandable first. Now, the sinuses are big and the coronaries are high enough. There's a good chance that you can still do a valve and valve, even if you do self-expanding. But at the same time, if you're going to do this strategy, I think this is where I worry about doing a zero implant, because then you make your valve and valve options limited. So if you do a self-expanding first, in these type of cases, I strive for 3, 4, even ideally around 3 for implant, because I think facilitating the next valve. But that's sort of my own bias.
Yeah, I think, Sushil, I agree. Like always, I agree with you, and I think looking at younger patient and 67 for TAVR is supposed to be young. Don't forget, we do have durability data, or let's say 10-year data, but those cohorts were older patients. So in young patients, we really don't have much to justify TAVR without any discussion. And the discussion point you pointed out correctly, I think the valve-in-valve situation, this patient probably needs, regardless of surgery or TAVR, needs a second valve. And I think it is important that we consider these aspects. It's different from an 80 or 75-year-old or 80-year-old. He probably will die before the valve deteriorates. But on a 60-year-old patient, I think that's a very valid discussion point that you brought up.
So one question for Manoj is that I know we always say Indians live shorter, like their longevity is less than American by 10 years, or Western population by 10 years. So this patient is considered 75 instead of 60, 77 instead of 67. I find it difficult to just take it by people just saying that, okay, our longevity is less. Probably because people who are dying probably are dying from infectious diseases, who are below the poverty line, and those kind of patients. People who can afford valves are not BPL patients. So
it depends on the socioeconomic condition of the patient. It depends on the socioeconomic condition of the patient. Those patients who are coming for TAVR are not going to die younger. They can afford cancer treatment. They can afford all kind of infection treatment. In this particular patient, he showed an ECG which shows RBB. RBB in a low risk patient, I'll prefer a balloon expandable stent where we can come back and do TAVR in TAVR later.
Yeah, excellent point. This is the reason I asked what valve type, because the patient is young. I also love supra-annular. 50% of my practice is supra-annular, but they're all older patients. 67, we don't do any. So younger patient less than 75, we prefer either balloon expandable valve or intra-annular valve. So we started using a little bit more Navitor in intermediate and high risk patients. So that's why I brought up all these 3 points that you need to decide on pacemaker. This will be probably the moment you balloon, you will realize in this patient, you might go into complete heart block. You will know that. And I would quote a slightly higher percentage of pacemaker in this patient with underlying right bundle branch block and the amount of calcium that the patient has.
So we'll let you get going because we have about 20 minutes left. And so,
okay.
Oh, yeah.
So I do agree with that. 67 years is a young patient for TAVR. I think we had, as in this case, 1 year back he was advised surgical AVR, but we had refused it. And this time he came back in LVF. Again, we had tried to convince him. He did not want AVR. So we are doing TAVR for this patient. But as far as self-expandable and balloon expandable, I totally agree with the discussion that went on. But in this case, this gentleman, though he is 67 years old, he looks something like 75 years old from the European perspective, if you look at it. So I feel even a self-expandable valve is going to do quite good in this case. Also, the femoral on the right side as well on the left side, they're not that great. It's 5.5 at some places, something like that. So if you look at all these points, self-expandable valve with a low profile would be I think would be a better one. Yeah. So let me just show you what I have done until now.
Yeah, go ahead. Yeah, please.
You can see I have put a right femoral artery, a right femoral vein. Through the femoral artery, I have put a pigtail in the non-coronary cusp. I have done a temporary pacemaker from the right femoral vein. I chose the right left femoral artery as the main one because the tortuosity was more aligned, as well as if you see, the size was better on this side. The bifurcation was lower on this side. So we have put a 14.6 from the left side with one pro glider only, and then can you click? We did forward. And then we crossed the valve. We have now crossed the valve, and it was not so difficult to cross the valve, but once after crossing, the whole wire jumped out. The second time we had to be quite careful in placing the wire. We did the hemodynamic, and you can see how high the gradient is. The peak to peak is almost 100, more than 100 in fact. So this patient, we can tell is pretty sick patient, gone into LBF. Yesterday night even we had to stabilize him by giving diuretic, as well as we have to nebulize and all those kind of stuff. Can I have the balloon? So we plan to balloon this valve with a 20 millimeter balloon, pre-dilatation. And we're doing it a GMET balloon.
What's the perimeter derived diameter, Amit?
The perimeter derived diameter is 23.5.
Yeah.
The minimum diameter is 19.
Yeah. So I usually like to go like almost close to perimeter derived diameter, especially in bicuspid valves or heavily calcified leaflets, because I don't want to come back and do post dilatation in self-expanding valves. And so I would choose here, I mean, in my practice I'm talking about, I would choose in this patient a 22 millimeter balloon or a 23 millimeter balloon if you have that. But I know in India, majority of them choose a little smaller. That's okay. I don't think it is. But in bicuspids, always try to be a little bit aggressive with the BAV.
Yeah, that's, I agree with you. And what I do is in a bicuspid aortic valve, I always go twice. I don't know if okay. Can you say, Sine? Can you face at 180, please? Oh, that's a very tight valve. Slipping in, so I'll just pull out the balloon slightly. Okay. Okay. Face at 180. Sine?
Good. There's 20 millimeter balloon. And there's still small
There's
waste.
there's still a waste on that left side that you saw. Yeah.
Yeah. So that's because I think at 8 millimeter, the perimeter derived diameter is still 21 point something. So I'll again go once just to see how I have, what kind of job I have done. Okay. Face at 180, please.
Amit, what is the size of the balloon?
20.
20?
20 millimeter. Facing off. Okay, I think it was a pretty good pre-dilatation. I plan to, in case if I have to post-dilate this valve, I plan to post-dilate with a 22 millimeter balloon. So let's see how it goes.
It is good that the rhythm, the PR stays the same and the QRS hasn't changed. So that's good. I think one thing when you pre-dilate these bicuspid valves, I think you have to be ready to go quickly sometimes.
Yes.
I think you're at higher risk for getting acute AR and getting ready to get a valve in quickly.
Yeah.
If you do get acute AR, I think that's where you just got to use pressors, pace a little faster maybe to decrease the diastolic time, but don't panic, don't lose wire, don't panic. You just got to get a valve in.
Yeah, give some phenylephrine and actually make sure the valve is prepped. And obviously, when we do the aggressive balloon inflations, as I said, that everything is ready to go. And after only one inflation, aggressively take everything out, including the sheath, and we move maybe in 10 seconds, the valve is being loaded after the BAV, so fast we have to remove. Whereas with the Sushil balloon expandable valve, he would have been done by now.
Ramesh, what's your practice? If the femorals are good, will you go for a 18 French sheath or a 14 French sheath? If you take 18 French sheath, exchanges are less, heavy and acute AR is there, you can get the valve in quickly.
Right. I mean, I think if the femorals are good, that's a very important question. If you are going to spend some time, and this is your early on practice of self-expandable valves, if the femorals are good, use the larger sheath so that you don't have to take out the sheath, and you can just push the inline sheath through the 18 French sheath.
So you can see I have kept the flush port at 3 o'clock position. The hat marker is on the outer surface. So we will be commissarily aligned in this case. Okay, look.
Social for a younger patient with FX plus because he's only 67.
Yeah, I mean, I think in the U.S. we pretty much every patient is FX plus. So, and the FX plus has these large windows which make the coronary access easier. So
I think cost is probably an issue here.
cost is here.
I think in the
So
US
this is
they're
unfortunate.
price now.
Yeah, what you see here is the challenge of a bicuspid and angles and the wire.
Yeah,
So
we didn't.
sometimes releasing a little tension here and
Right.
coming back helps as well. Yeah.
Yeah, we didn't ask about aortic root angle in this patient actually. So we have a checklist. In that checklist, one of them is actually aortic root angle. If it is more than
I'm very
45,
sorry about that. I usually tell
we
that.
start thinking about should we use balloon expandable valve versus a self-expandable valve. I mean, I think we have done even 60, 64 recently, but be careful.
So I would just be cautious with that wire position because I think we lost a little bit of the wire position. So just be careful with that. But I think it looks okay. It's in the sort of mid cavity.
So the angle in this case is 50. It's quite horizontal. I agree to that. And last week I did a case where the angle was 75. And in that case, I had what is called as snare ready in case I wanted it to be done with a snare. Okay, can you just decrease? Yeah, can decrease?
Yeah, in this view, you want to make that ring of the valve in
As a straight
maybe
line.
a little bit more caudal. Yeah, that looks good.
Okay, so you can see the marker on the valve. You can see on the pigtail, but it doesn't go down till the cusp. That's because there is a chunk of calcium over there. Okay, so shall we take the first injection and see? Until now, I have not given any kind of.
You think I would push the pigtail down? I mean, you have to get a little bit further in with the valve.
I agree with you, but you see, there is a chunk of calcium over there, and that's not allowing me to go down completely. I have been trying to push a lot. You see,
And if that gets stuck, sometimes your blood pressure is okay, so you can take a stiff wire or take a wire.
what I'll do is I will pull back and again. That will help me at least to disentangle the pigtail from the valve.
Yeah, and sometimes if you can't get down, then you get a reference point with the calcium and get a sense of where you are as well.
Yeah, exactly. Right. And in this case, I will keep that calcium as the reference point because in the CT, I told you that there is a chunk of calcium that goes from the cusp until the STJ on the NCC side.
So you have to push your valve in and your diastolic pressures are low, so you're pinning the leaflets again. So there may be some AI. I would move a little bit sooner here.
Okay.
Faster.
Okay. Can you go, Sine? Ready for injection? Inject, please. Okay, that's the pigtail is pretty low. So,
may have to use the wire.
let's see.
Yeah. Do you use that, what Samir uses for single access? What does he, not multi-purpose catheter, similar to it, but a little bit stiffer?
So, I mean, again, I would probably err on deploying an REO caudal for your cusp overlap here. You see more LAO, but because I think your wire is holding you funny position. So you might need to come back and try to reposition the wire if you can. If not, then, but I would try to go forward because here your nose cone is going. Sorry, go ahead.
It's a sigmoid kind of valve, and I think they're at a pretty good position right now. Let's take an injection again.
Yeah.
Can you manage?
Is this your cusp overlap?
No, this is LAO.
No, I have modified it because in the cusp overlap angle, what they gave us, the ring was not coming in a single line. So I've just modified it slightly, but it is almost a cusp overlap. Okay, Sine, inject. Okay. I think a pretty good position to start because this is a FX. So you can see we are starting with the ring just at the tip of the pigtail. If it was a Pro Plus, I would have started from the middle. The FX hardly doesn't move so much. So what I'm going to do is I'm going to open it till the third node and we'll take another injection and see how the patient is doing. Okay, ready?
I would consider pacing at like 120 or something just to get some stability.
Ready for injection? Inject. Okay, looks pretty good. Okay, pace at 140, please.
That's very good, like 3 millimeter or 2 millimeter placement.
Okay, let's bring down the pacing.
But look at the waist. There is still that calcium that is pinging on the pigtail. Yeah.
And I think it's important, and I think Dr. Grube made the point yesterday. In these anatomies, especially this much calcium, it's important to go RAO and see that you don't have an infold and that the valve is really open. So on fluoro, if you go from this LAO view to an RAO view, that will be important.
Yeah.
Yeah, that is what I'm going to show you now. Okay, this let's take a scene so that we have a reference point over here. It's exactly a 3 millimeter if you see. Let's go to RAO, please. RAO 30 or something like that. Usually in RAO,
and maybe caudal. No, don't go more caudal.
Okay.
Caudal. Caudal. Yeah. You're gonna have to go pretty caudal, more caudal, just to square it off.
Cusp overlap is usually.
The valve is pretty well opened in this, and it's an extreme caudal position. So
Eberhard, what do you think? It looks reasonably expanded. What do you think?
No, I agree.
Okay, let's go to LAO and check that again.
So this is that bulky calcium in the sinuses that's preventing it from expanding, right? Yeah.
Okay, this is extreme LAO, and you can see again that it's constrained in the LAO position. So definitely we will have to post-dilate this valve with a 22 millimeter balloon. Can you come to this position, please?
But I think it's important that the stent doesn't have radial force till it's fully deployed. So some of this will open as the valve deploys, right? Yeah. This is still constrained at this point and doesn't have the full radial force.
Probably, I think they should take another angio so that we can see on the left side.
Yeah. So you're going to do an injection here to show us position?
Right now. Yeah. I'm going to just take an injection to show you the position of the valve. Okay, Tina, inject. So how do you feel?
Yeah, looks good.
I would take it because I think it will come up a little bit on the left, right? Eberhard, what do you think?
Yeah, but I think, it is a little bit, but the valve will tilt a little bit, so that sound will come up. And as you said, don't deploy too high because if you...
I wouldn't go any higher. No.
Yeah. It's 3.
I think in this case, nowadays I have left deploying at 0 to 3 position. I go always 3 to 5 position because I want to have that neo-sinus vessel exactly below the coronaries so that it is easier to actually cannulate the coronaries on the later date if required. Also, this will also help us if we have to go TAVR on a later date. The old days, like in 1920s, when we were doing this high deployment, I have faced a lot of patients who have come back with this kind of problem.
So we have about 5 minutes left, so I want to keep that in mind. So we keep moving along.
You want to go ahead and deploy it? Yeah.
Yeah, I'll pull back the wire slightly. 140, please.
Probably we should place.
Just don't pull.
Yeah, I'm not going to pull, just the same position. Slide forward you can give. Slide forward. Okay, that's perfectly fine. Leave this. Okay. You can see the patient's rhythm is still.
Yeah, the narrow QRS, blood pressure recovered.
Okay. So let's recapture the nose cone.
See, I told you, did I tell you that, Sushil, I started using Savvy wire almost 100% just because I don't have to take now the inline sheet, put a 14-French sheet to get hemodynamics, and I was always worried about not getting hemodynamics, and Savvy wire solved that problem. Actually, it's very good to get the hemodynamics before and after, gives you an AR index as well. And that's when I would, based on that, I will decide whether I need to post-dilate. The next point is that bulky calcium, when I think they are nidus for thrombus formation. So in younger people, at least normally we would do dual antiplatelet therapy. But in this patient, I might even err on giving for 3 months anticoagulation. So because of we have seen clots forming on this and pushing the leaflet, there'll be halt or ham, and after 2 months, they actually recheck your gradients on echo again.
So I would probably though post dilate here just with the 20 because it's a pretty small waste. There was a waste with that 20 balloon. These are the ones where risk for root injury. You already did it. So I would probably just start with the 20 and see what kind of result you get. I don't know. What do others do?
Yeah.
20
Do we have an injection already?
Not yet. Not yet.
You mean aortic ramp?
No, I have not taken. I plan to actually first balloon it up because I can see some waste on that, and from even a durability point of view, if you think like that, then it is better to optimize it and this valve rather than leave it because the patient is a pretty young patient. If you don't optimize that,
The only thing is just be careful as you cross because your wire is a little bit
I agree with
on
that.
inner curve.
Yeah.
So
Just connect it.
Centralize your wire while you're
push the
crossing.
wire. If it doesn't centralize, that means it's caught on that tab. So.
Yeah.
Okay. Let's go. AP, please.
This is ZMed 2, right?
Yeah, this is GMAT. We are
2 or ZMed?
just a plain GMAT. Another GMAT. Leave it. Store the bar. Hold the bar, please.
Okay, then T is in.
So, and I like to pace through withdrawal of the balloon because I think you can dislodge the valve here. I think it's unlikely there's so much calcium, but it's just as a habit, I always very careful.
Okay,
Your wire there is, be careful with your wire there though, I would just say.
I just pulled it back because I don't want to. Okay. Let's go at 180, please. See?
No, that's awesome. He's fine.
See that? Very nicely done. Oh,
So
no, actually, what happened? I'll just tell you. My syringe actually broke off.
Yeah, and the balloon expanded quite well, but when
Actually, you can see the syringe actually it broke off at the place. So as soon as I went total full off, it just broke off, and that was the problem.
So
it looks quite expanded.
I think it's fine. I don't think I wouldn't recross to get hemodynamics. There's no need.
Yeah.
I would do an aortogram and be done.
Our Dr. Rahul will just show you the echo so that you have a good idea about the hemodynamics by the echo.
Yeah.
Okay, can we have that echo? Okay. Nicely positioned. No AI. And that's the gradient.
Yeah, good. Gradient looks below 10, and you want to show circular short axis of the aortic valve, and
Short axis, yeah.
if you can.
So what would make you want to post dilate again here? What are you looking for?
Well, as I said yesterday, in order to avoid a serious complication is to be reminded that you look for things and not, look at something that appears to be obvious. Here, the fold in this case is unlikely, but keep in mind that it can happen. So it's good to remind the operator to look at it, whether it's good or not. The other thing is, with a bulky calcium in this type of valve, you would expect a little bit of PVL. I wouldn't be too aggressive now to post dilate. Whether that's enough depends on the amount. But it looks, I think the position actually is quite good. I think they did a very good job. As you can see here, also the valve tilted a little bit, so the left side came up a bit. It's a little bit more aligned. and I wouldn't go any higher. You have to keep in mind, with calcium, don't go too high. Then the valve might actually slip.
There's mild AI on iotogram. So thank you very much, Amit. I think fantastic demonstration.
Thank you. Fantastic job. Thanks a lot.
Thank you so much, Everett. I'm sorry I could not meet you this time.
We'll go to Dr. Anantharaman for a live in box.
Thank you, everyone, and thank you, my team, for this quiz. And thank you, my technical team, Dr. Rahul, Dr. Ashish. The mean gradient is 8. And Dr. Bipin, Deepak for this excellent support. And at last, thank you, the hospital, for giving this opportunity. Thank you, ACVS, and Dr. Srinivas for this opportunity. Thank you, everyone.
Take care. Thank you.
Thank you. Can we switch to Kaveri? Hey, good morning, Dr. Anantharaman. Ramesh here. We have Dr. Eberhard Grube, Dr. Sushil Kodali, Dr. Manoj Agarwal, and Dr. Michael Benz as panelists. Yeah.
Good morning, Ramesh, and greetings to Eberhard and Sushil and Manoj and all the other chairperson panelists. Firstly, sincere apologies to Dr. Srinivas Kumar that I couldn't be there. And secondly, obviously, the patients were not willing for live case on Sunday. So unfortunately, I couldn't do a live case. But I'm going to show a live in box on a balloon expandable in a small annulus and the myth versus reality in terms of the data we have. So I'll share the screen, I'll show the live box, and we'll have some discussion after that. And so thanks to again our organizers for this opportunity. I think the host needs to enable me to share screen. Ujwal, can you allow me to share screen?
Can you allow him to share screen, please? The technical team, can you guys hear us? Because on Zoom he has to.
Want to log out and Anant, do you want to log out and log back? Yeah. Okay. Now we can see your screen somewhere. It is coming up. Oh, yeah, we can see your slides. Go ahead, please. Thank you. We can't hear you now. You might have muted.
We can't hear you. Oh.
The company or there as well. And firstly, sincere thanks to the Kaveri Hospital management as well for giving a fantastic cath lab as well as the support always. So next slide, please. So patient is a 78-year-old. The body surface area is about 1.55. Hypertension, diabetes, dyslipidemia, critical stenosis, valve area is. Can you hear me?
We can't see the slides, Anant.
Max and more than 65 mean.
Ramesh, can you hear me? We can hear you, but we can't see your slides.
Sinus rhythm with narrow complexes. Next, please. Slightly prolonged PR interval.
He's sharing.
Now, this for her age, there is literally very low calcium. Only the non-coronary cusp has got. So myself,
can you share again?
Yeah, I'll share it again. I think there's some issue with this sharing.
Yeah, now it's coming up. But can you unmute first? I think you're muted on that. Yeah. Unmute and then share your slides again. Good.
Is it okay now?
Yeah, we can hear you.
Just start the PowerPoint. I think it should work. Can you start playing your PowerPoint?
Yeah.
Okay, just play now. Yep.
Good. Wonderful.
You have to hit play there. Or the volume on your PowerPoint.
Low calcium. This
There we go. Perfect.
Can you say it later?
Good.
Hypertension, diabetes, dyslipidemia, critical stenosis, valve area is 0.7, good LV function, gradients more than 100 max and more than 65 mean, and the normal renal function. Next, please. ECG sinus rhythm with narrow complexes. Next, please. Slightly prolonged PR interval. Now, this for her age, there is literally very low calcium. Only the non-coronary cusp has got a minimal calcium. The right and left more of fibrotic. Now, this is a group of patients we are increasingly seeing now. fibrotic aortic stenosis in elderly patients with low calcium. This also I will discuss in the discussion part later. Coming to the annulus part, this annulus is around sort of 290, less than 300. When the trials talk about small annulus, it is about less than 430. But the reality in India is there's quite a lot of these patients, around 300 to 400, which conventionally would have had a surgical valve of 19. And again, the small annulus, as per the literature, is anything surgical valve less than 21. So there's quite a lot of variability in the trial discussions and the reality in India. So for this particular patient, the annulus is around sort of 290, and the LVOT is looking slightly smaller. That is because of the basal septal hypertrophy. The only time you should use a diastolic phase for annulus assessment is when there is a significant basal septal hypertrophy, like a Holcomb-like picture. So next, please. Coronary heights are reasonably satisfactory, more than 15 on both sides. Sinus diameters is around sort of 25, less than 30. So overall, this annulus can take a self-expanding platform of 23 or a balloon expanding platform of 20. So we selected Edwards Ultra Resilia 20 plus 1 ml, which will make it a 12% oversize. Next, please. Numbers are good, both sides more than 7 mm. So we'll be using the left side for a pigtail contralateral and the right side for the main access with one single set of Menta access closure device. Next, please. Next. So the heart team discussion was to go with the 20 mm plus 1 ml for this particular patient. Again, I will discuss the logistics of why we chose that in the final discussion part. Next, please. So anesthesia is conscious sedation. Again, most of the time, the decision between conscious sedation and GA, we leave it to our cardiothoracic anesthetists who are extremely experienced. So we don't interfere with that. And our center uses maybe around 60-70% conscious sedation and 30% general anesthesia. So as I said, left femoral contralateral, right femoral main access, and we are using a balloon tip wire. So routine, it will be right internal jugular, so that in case if we have mobilized the patient, afterwards it will be easier. And we're going to use the Edwards Resilia 20 plus 1 ml, which is 12% oversize. It will be a direct implant given the lack of calcium. The guide wire of choice for more than 95% of the cases nowadays is Safari Extra Small. Next, please.
Maybe it's worth stopping here, just because we don't have a lot of time. We can maybe skip to the interesting parts of the case later, but should we have a discussion about sizing and all of that now? And then maybe we can get to just to the valve portion and then have another discussion at the end. What do you think is best? Because I just want to cognizant time.
Sounds good. Yeah, sounds good.
So maybe you want to comment a little bit your decision making about balloon expandable versus self-expanding, and I think this sort of question about hemodynamics is an important topic. And do you want to talk a little bit about that right now?
Yeah, sure. Now, firstly, obviously, as I said, the literature small annulus, and the small annulus here is something called very small annulus. That is a 19 mm surgical valves or 20 balloon expandable or 23. Now, there are two groups of patients. There are elderly patients with a very small anatomy, like small annulus, small STJ, and also low coronary height. This is a group of patients where I feel comfortable to put an Edwards because the frame height is very small. It's 15.5, and if I put a 1 ml extra, I get like 15. So it's almost like a surgical valve. It will sit below the coronaries, and it gives adequate hemodynamics for that patient to mobilize around. If the patient is young, small annulus with all the other parameters are satisfactory, like the coronary height, sinus, other things are satisfactory, then I do tend to give self-expanding because the patient is active, so he needs a proper. So it's a decision has to be made based on the patient and the anatomy rather than just saying small annulus self-expanding. So that is one of the important sort of point we want to get it across in this one. And the second thing is the durability data. We have seen enough now because the hemodynamics is not reflecting into the durability. And we are seeing even the larger valves degenerating because of aggressive post-dilatation in the self-expanding platform. And the smaller valves seems to be staying good in the ocean dive registry. So there is a lot of literature sort of understanding we need to have as well. So there's a logic behind in this very small patients, small anatomies, started using the sort of 20 Edwards valve. We have a series of about 10 patients now. All of them are doing exceptionally well. So there's a logic behind that, Sushil.
No, I think it's reasonable. I missed the beginning, the presentation. How old is the patient and how big is the patient?
Patient is 78, and the body surface area is about 1.5, 1.6.
So small patient, 1.5 BSA and 78. So Eberhard.
Everything small.
Or other comments. So the SMART trial, there's a lot of conversation and, some of it noise, some of it reality. What are your thoughts about?
SMART trial was done in Europeans and Americans who are quite big size. Indian, mostly women, they are very small in size. The body surface area is 1.5, 1.56 or so. And most of them are underweight, 56, 60 kg. I think we can't qualify for 430 for small NLS in 90% of our patients. Most of our NLS will be smaller than 430. So we probably need to redefine small NLS for our country, and something like a value of 340, 350, I think is more reasonable rather than saying 430 for.
And I think the ability of our coronary access and other things is a reality as well. So go ahead.
I mean, if we look at the SMART trial, it was well thought of, and obviously there was some hope that supraannular designs would be superior to intraannular. But if we're honest, I think it doesn't convey into any long-term data difference. So I have to say, not necessarily by hemodynamics, but I think if you do a balloon expandable valve, I don't know how Sushil or anybody else feels about it, but once you get into 21 millimeter balloon expandable, or even in some cases of 23, depending on age, I think that is something that you should be very careful about, because then hemodynamics really kick in. If you have a younger patient, or I should say an active patient that is still exercising regardless of age, I think you should be very careful. Then hemodynamics become important, or more important than in a 80-year-old who will not run marathon anymore. So I'm a little bit skeptical that SMART answered all the points, and I don't think it was a little bit of a hype about this, looking at degeneration, but outcomes hasn't been any different.
Yeah, that will be like if you look at the partner 3 low risk 7-year outcome, like a lot of patients with smaller annulus, they did okay.
Yeah.
Yeah. No, I think it's important. So we have, just a little over 5 minutes. I don't know if it's worth getting to the interesting parts of the case, and then maybe we'll have a.
Sure. I think Eberhard has nailed it as it is. Younger patients, more active. It's better to give better hemodynamics. Otherwise, choose on the patients. So this, I will show the sort of 2 important aspects for this case. One is a single closure Manta device. There's a lot of hype in Europe about the failure rates. I think some of the failure rates because of the inexperience. All my cases, I'm using the Manta as long as it's suitable. Obviously, it's been good. And the second thing is the comfort of reaccessing the coronaries, as well as the precise implant and the pacemaker rate is another important aspect for these patients. Because with self-expanding, we do get a higher pacing rate. So the important aspect for this presentation is, one, it has to be ultrasound guided. I'm showing this ultrasound guided, both fluoro ultrasound guided. Get the anterior puncture at 12 o'clock. Then you put your closure device. I'll just go to the.
I think if you
and then you check with your micropuncture, make sure your access is good. Yeah. No, I'm just showing the frames of important. Otherwise, it will be a lot of time.
Got it.
Yeah. So ultrasound, fluoroscopy, get the micropuncture, go in the right place. Then you put your sheath. Once you get your spend at least 10-15 minutes to get this access. Once you get your access, then it is easier. Manta closure device, the depth assessment is crucial in the beginning. You get it right. And in terms of crossing, you do park the Amplatz catheter on top of the jet before you start pushing the wires. The catheter will move nicely, and then you can easily cross, especially with bicuspids and crossing in the view, because it becomes too cusped. It makes it easier to cross. So that's one aspect of this. Now, this is another important aspect. When you do exchange, please do exchange in a pigtail. Don't be in a rush to push a stiff wire through an Amplatz. Just take another 30 seconds, exchange it through the pigtail. Get a good wire position in the apex. As a for extra small, you can easily move within the LV. That's important aspect to show in this now at this time.
It's injured with gravity. Now you see it's fallen over on the other pigtail. That means you have crossed in the orifice, but you are in the commitments aligned within the valve. Next, now you go to is good.
Now, one of the other important aspects.
It's easy to push through the expansive sheath, especially if it's more than 6 to 6.5. The valve, there are 3 or 4 components you can see. There is the sheath there, the pusher.
Just to highlight, because about a lot of people use my valve in India. It's very important of understanding of loading and unloading the valve, and do practice it on bench before you do that. And tell your assistant to remind you when you are in the annulus that we are using Edwards, so the pusher has to come back. Otherwise, if you inflate the valve, then you will kind of cause embolization. So that's what I'm showing here. The valve is loaded, the parallax is checked, and then.
So you are around 30. So when you are crossing, unless it is advantage to keep the valve coax.
Now, this retroflex system is the best retroflex system because it will flex even more than 180. So around 50 to 60 degrees you flex when you come around the arch. When you are in the annulus, use the retroflex for your advantage to make it coaxial. That's what I'm trying to show here. This is an horizontal aorta.
It's brought back.
So this is the most important thing with the Edwards. You bring the pusher back and make sure it's around the second marker, which is different to the my valve. So people practicing should understand.
Push so that I can get coaxial on the opposite. Next, please. So we have tested it. Here there is AR is there because it's a mild calcified, but it is more fibrotic. As the valve was crossing, probably now the AR is appearing because the fibrotic cord is ruptured. So the marker is at the sort of middle to bottom of the pigtail. So I probably want it a little bit down so that then I can adjust it. It's easier to adjust that way. Next, please. So here I applied a little bit flexion, made it coaxial, and adjusted it. Next, please. And one more test. This position was good enough. So we're going to implant it under aortogram here. Next, please. So the rapid pacing was on around 180. Wait for the pressure to drop below 50. Slow deployment. Now I'm seeing with the aortogram. I'm quite satisfied with the depth. I'm giving a little bit of forward push so that I can get coaxial on the opposite side as well. So this improves the hemorrhage. So it's causing severe AR. Next one, please. So when the wire is in the center, the leaflet is partly systolic pressure was.
So another aspect. This is immediately post implant. The aortogram shows there is severe AR. That's because your wire is on the outer. One of the leaflets is open.
Center. You see how it happens. There is no AR now. So the reason was show the previous picture. So when the wire was in the outer curl, one of the leaflets was completely open. So it's causing severe AR. Next one, please. So when the wire is in the center, the leaflet is coaxial properly. And you can confirm that in the precise implant when you do this,
So we can see this is like a surgical-like implant with no AR, no gradient, no conduction abnormality, as well as coronary access becomes much easier. So we have avoided pacemaker in this elderly patient, and we have got a reasonable good hemodynamics on the table with a zero gradient, with zero AR. I think in the preciseness of the implant, I will not get it with any other platform. So that is the final sort of position of the valve, and closure was done with the one Manta closure device. That's a Manta. I'll just show the picture of the post closure of the Manta for just one sort of learning aspect. Now this picture shows.
The wheel stay permanently, which helps us in terms of regaining access. So as a single vessel piece, the bifurcation is very close to the skin. This piece, the bifurcation.
People who are using Manta, this marker will show where the puncture was or where the device is, so you can go above that or below that for future access. And one device will take care of the closure.
There on top of the vessel. And second thing is, if you want avoidance of pacemaker.
Oh, this slide, I will leave it as a final slide to sort of clarify. I think we have discussed all this in detail, especially Eberhard made it very clear. If I come to the right bottom, that's where it is. If you want hemodynamics in an active young patient, yes, please do consider a self-expanding in a small annulus. If you want a precise implant to avoid pacemaker, as well as to avoid paravalvular leak and to get coronary access, then Tony sort of is okay for an elderly patient who are less active. So that slide summarizes the whole kind of thing. And we have not shown the hemodynamics, especially in the SMART, which is a 26 self-expanding versus a 23 balloon expanding. There was no difference in terms of the long-term mortality. I'll stop there, Sushil. I think I have just covered the important aspects of what I need to convey the message. Thank you.
No, I think that's you highlighted the points that it is the decision making is not one factor, and I think part of the challenge, and maybe we have 30 seconds each for comment, and is the noise gets a lot when some of this stuff happens, and your bottom right corner is an important component. It is there's a lot of things that go into decision making in pacemaker rates, coronary access, lifetime management, patient prosthesis mismatch, hemodynamics, and you have to factor that in the context of the patient. I think that's the message here, right? And the hemodynamics don't have a mortality signal. So when we don't, because we can't extrapolate. There's this stuff where in surgical valves, you get patient prosthesis mismatch, there is a mortality signal, but that's not what we're measuring here. And we have not seen mortality signals with PPM or what we're calling PPM based on the way we're assessing it. And we haven't seen that in individual trials. When you look at the partner series, you haven't seen moderate PPM lead a mortality signal. Second, in the SMART trial, we haven't seen differences. So don't make a decision based on one thing where it's not mortality. I don't know. Eberhard, you wanted to say something. Looks like
No, I agree, and I don't want to repeat what you just said. I think it's a very important thing. But first of all, I wanted to congratulate the team. It was an excellent deployment. It was a very, very good procedure, very insightful. But I think the point here is that this is multifactorial, and particularly small annuli. It is important that you weigh in various factors, the ones that Sushil mentioned. And I think that's the key message that we will have to bring out. SMART trial, as much as maybe not we, but some were hoping for, really didn't answer that question that one valve is better than the other. And I think, now with extreme or very, very small valves, it might still be different. I do not have a bias, to be honest, in regular annuli. When it gets really small, as I said before, in a younger patient, I do have my thoughts. But again, it is a decision on various factors that would eventually decide which valve to do.
Yeah, I agree. And I agree. Great presentation, great case.
Very nice.
Very nice. Thank you so much.
Thank you so much.
And, we're going to move on to our next case. Thanks again. I'm sorry we didn't see you this time. Next year. Okay.
No, I'll catch up.
Okay. Thank you.
If we're still alive.
Okay. Don't say things like that. Okay. So we're going to Dr. Ravinder Rao in Jaipur. Ravinder, can you hear us? We can see you.
Yeah, I can hear you, Sushil. How are you?
Good. How are you? Thank you for joining us on a Sunday.
Good morning.
Thank you so much. Thank you for having us. Good morning to all the panelists, Professor Grube and everybody sitting there. We were having we were listening to the discussion from the previous case, and I think our case is going to fit in aptly to take that discussion further. So my name is Ravinder. On my right is Kailash. We have Dr. Priyanshu, Dr. Prashant, Dr. Kevin, Dr. Prachi, and entire staff. And thank you guys for coming on Sunday morning. And thank you, TCT, for this opportunity. So we're going to go straight with the case. So we have an elderly patient. So he's a 77-year-old male, symptomatic aortic stenosis, hypertension, no diabetes. He was diagnosed with severe aortic stenosis. Patient also had a tricuspidal AV block, significant sinus cause, underwent a pacemaker prior to the TAVR procedure. Nothing significant in the hematology, all normal. Mean gradient was 41, peak gradient of 71, aortic valve area of 0.9, dimensionless index of 0.2. Next one. This is the EKG now. You can see the pace rhythm, A pace and V sense. Next one. Now, the CT scan. The CT scan annulus area is 384. Minimum diameter is 20 millimeter. Maximum 24.7. Average is 22.6. Perimeter is 70.2. Sinus of valsalva diameter 26, 28, 28. LVOT again you can see the minimum is 20. Average is 23. Perimeter is 72.3. Next one. You can see a heavily calcified sinotubular junction. The sinotubular diameter is 21 millimeter. The sinotubular junction height is 23.4. the ascending aorta normal side, and you can see the aortic root, how effaced, the sinuses are effaced, and there is a lot of calcium in the root. Next one. The left coronary artery height is 10.3. The right coronary artery height is 11.5. We calculate the VTC of the native artery. The VTC on the left side is 2.9. These are the angles, the cusp overlap view as well as the three cusp view. Next one. Femoral vessel bifurcation are a little high, nothing unusual because groin vessel size is good enough. Next one. So this is an important slide which, I just want to summarize on this slide. So here we have a small anatomy, number one. Number two, we have narrow sinuses, a calcified STJ, borderline coronary arteries, and we have selected a 26 millimeter. We can discuss that, but I'm going to just complete this presentation. We selected a 26 millimeter Evolute FX Plus valve. The challenge in implanting this valve is, if you look at the dimensions of the anatomy, the STJ borderline, the sinus of valsalva borderline, on the left side are the dimensions of the patient, on the right side are dimensions of the valve. Now, a 26 millimeter valve has a waist of 22 millimeter. This is what we have to keep in mind, and that the VTC which we have calculated based on the circle of 22 millimeter. So borderline STJ, borderline coronary height, we can discuss about sinus sequestration. Next one. So our plan here is, Sushil, should I complete the plan and then you can discuss?
Yeah.
So we'll do a conscious sedation TAVR.
Yeah, go ahead.
Do you want me to stop here? Or
No, please go ahead. Let's go through the plan and then,
So our plan is transfemoral TAVR. We're going to do a pre-dilatation with 20 mm balloon. 20 mm is the apt size because of the calcified STJ. We're going to do a coronary protection. We'll discuss how we'll do. We're not planning any sort of native basilica in this plan. We're going to use a self-expandable valve. We can discuss that balloon versus self in such a calcified route. And we can discuss about post-dilatation SOS. Next one. So we'll also show what all we have done so that we can, because we just have 30 minutes and we have to do 2 minute things. The groin axis was standard. Let's go to the groin. We have 2 6 French arterial.
We're not seeing the angio. We're still seeing the slide. Okay, now we see the angio. Thank you.
So we have 2 6 French arterial axis on the left side. Both were taken ultrasound guidance. We take all ultrasound guidance and a 7 French vein with a temporary pacemaker in place. On the right side, we have deployed 1 ProGlide, same another ultrasound guided axis. And we have put in a 14 French sheath. Now, we have also, let's show the aortogram, please, the root shot. And you can see the heavily calcified root in this. Can you appreciate that? The calcium is starting from the leaflets, root, and goes all the way to the STJ. This angiogram also shows the effaced sinuses. Means the sinus of valvular diameter is not wide enough, and you can see a calcified STJ. Some coronary artery disease in the circumflex, which we are not planning to address in this patient. And our aim in this patient is to do a pre-dilatation, go with a self-expandable valve, protect the coronary with a wire, a guide liner, and a stent, and after deploying 80% of the valve, assess what happens to the coronary arteries. So the challenge is a small calcified root.
Balloon expandable valve in this patient.
So maybe Eberhard wants me to go first. So Ravinder, I agree with you. This is the worst anatomies. And I think the first thing for the audience to recognize is this is you need to recognize what are high-risk cases. And this is a high-risk anatomy. And this is the anatomies that I worry about the most. Effaced sinus, calcified STJ, and where you're at risk for sealing the coronary, sealing the sinus, all of these things that you worry about, and aortic root injury. And there's multiple ways to do this. And I think the risk of an acute occlusion is maybe a little higher with balloon expandable because the waist maybe protects you a little bit. But that calcified STJ gives me pause for self-expanding, and I worry a bit about it because I don't know that you'll be able to really fully open. But I think, so I would, my bias would be to go towards a balloon expandable because I think it's easier to protect the coronaries. But the downside of the balloon expandable that I would really worry about here is the STJ is 21, and the 23 balloon is going to interact and you got to be very careful and coaxial as you deploy because it may push you down. But so I think there's pros and cons with each approach. But Eberhard, what do you think?
First of all, Ravinda, it's very good to see you and your team online. Thank you very much.
Thank you, Professor Grube.
This is a very, very interesting case, obviously, and actually, I'm glad we're sitting here and not in your place. This is, as Sushil said, a very high-risk case. All the odds are against you. The thing that that I would be careful about with balloon expandable, he mentioned it, and I probably would also do the self-expanding here. The only thing, if you do post-dilate, remember the 7-year data, what it showed, if you're overly aggressive post-dilatation, you might tear the leaflets, and then be careful because the waste is not the inflow. We learned this. It's stupid that we learned it after 7 years, but unfortunately, that's the way it is. But we have to be very careful. Everything is tough here, particularly, as you said, the sinus sequestration is of big concern. The question then is coronary protection. I would also do protect. The question is how to protect, wire only or stent in place. So that would be interesting what your perspectives are. And again, congratulations showing this case to us. It's very, very challenging.
So how will you protect? So maybe, yeah.
So, Sushil, what we have decided, a balloon expandable in this particular anatomy, as you pointed out, because of that calcified STJ, is going to be come up with a lot of challenges. Now, this coronary is borderline. This is just 10.2 with effaced sinuses. We might get away without a stent, but such a coronary anatomy, we have to protect with a stent in place. You cannot advance a stent once the coronary gets occluded in this crowded place. It is easier to pull back the stent and deploy than advancing a stent once the coronary is occluded. But then how do we protect in such a sequestered anatomy? We're gonna protect with the guideliner and we're gonna protect with the stent. But the idea is, what do we do after 80% deployment? Should we pull it out, or should we remove the guideliner once we have deployed the valve? The challenges of removing a jailed guideliner. So we're gonna discuss all those things. So what do we go, and the pre-dilatation. So go up. We're ready for injection also. Okay, pace at 180, please.
Still, this patient is a pacemaker. If you implant the valve deep, does it provide extra protection for coronaries?
Yeah, and I think we're going to talk about that, because if I did a balloon expandable, I would.
That's great that you inject.
Yeah.
Yes. Toro save. Just for the audience, as you can discuss, this is a 20 millimeter balloon. But remember, the waist of Evolute is 22. If we have to really assess the coronary occlusion, it has to be a 22 mm balloon pre-dilatation. But you can see with the 20 mm itself, we're going to play that shot for you. Let's just remove this thing. With the 20 mm balloon itself, it occupied the whole of root. Play that shot again, please.
I think what you do is, maybe most people don't recognize this, but I think that's very, very good that you inject it while you deploy, because you have an idea on how the leaflets are behaving. If you have a certain leaflet length that might actually be coming close to the ostium, you know whether it seals or not. So I think that's a very good choice that you did that injection.
And I think if you do a still frame here, you see the leaflet, you see the white line.
Correct.
Pause.
Very good.
It's just below the cornea or right at
just
it.
Below.
Yeah.
Sushil, you rightly pointed out that negative white shadow. We're going to freeze this image for you guys to discuss for a little bit, and then we're going to go ahead.
Yeah, no, you see that white line of the leaflet, and it's just at the bottom of the left main. This is a 20 millimeter balloon, and as Ravinder pointed out, it may get pushed a little bit more. So I do think it's reasonable to protect. And I would also, the comment was made, which I agree with, I would implant low. Patient already has a pacer. You want those windows to be where you have access. So I would sort of err implanting a little low. And I think your point about protecting with a stent and a guideliner is key. And I will say this only because I've made this mistake early on. I don't know how many years ago, it was maybe 10 years ago. We protected with an Evolute. We decided we needed to deploy the stent. It was a calcified aorta like this. And as we pulled the stent out, it got stripped off the balloon and pinned against the aorta. So what I've been doing, and this is sort of up to personal preference, I protect with a guideliner and a stent. I don't take it out at 80%. I deploy the valve fully. I have my guide liner there, so if I need to pull out, I can pull out the stent. But what I tend to do is in anatomy I'm concerned about, I deploy fully, I take the system out, I go back with the guide through that same the 14 French side, re-engage through the if I can through the evolute leaflets through the frame, and then take the other one out, and so I have protection.
Yeah, that's yeah.
Okay.
Yeah.
Okay. Let's
How
go.
is Navitar in this kind of case?
I think the
Yeah, we'll discuss.
the sinuses are probably a little. Actually, maybe it would be okay. I'm not sure. I don't have a lot of experience with sizing with Navitor, but I think it would be a lower. But I think the leaflets are still long enough that you're going to be above the coronaries. You're going to have to deploy really low because of the sizing.
You can see Ravinda, Sushil is fired up. That's the stuff that he likes to do.
Yes, so we're going to do exactly what Sushil wants. We have a guideliner in place which has come up in the guide, and we're going to park the stent. The other thing which I want to highlight is we have to park the stent or the guideliner in the left main or LED when we are ready to deploy the valve. Because if you park it for too long, that causes some sort of coronary spasm, stenosis, dissections and thrombus formation. So once a valve is ready, this is the time we're going to go ahead and park the stent. And the idea is don't advance the guideliner without a stent. So we're going to park the selection of the stent size. See, this is a left main which is little longer. So we have to snorkel if it is required. So we need a stent which is going to come from the mid left main, and then some part has to hang in the ascending aorta. So never take a smaller stent. Maybe Sushil, Professor Grube, you want to put some highlights on it. So now a guideliner and stent are parked, and we're going to come up with the valve. So Kailash is going to explain about commercial alignment. Kailash, you want to go ahead and talk about commercial alignment?
Here,
and why is this important in this particular patient?
Here, the patient has coronary artery disease, and commissural alignment is very important here. So initially, what we did, we put our plus port at 3 o'clock, and then the head marker at arter curve, we have to rotate it little bit, and then in the AP view, and then LO2, it is on the outer curve here, and then we are going down.
Yep. So you see the hat marker nicely on the outer curve.
How the hat marker is there on the outer curve. Let's put the clutch pole lap view. And the curve. Go ahead, Kailash. You want to tell how does it look like in the clutch pole lap view?
The head marker should point towards center front.
You want to push the wire a little?
Yeah.
So that's what he meant. Yeah, go ahead.
So the head marker is center front.
Yep. Looks good.
Push the wire a little so that we go to the apex.
Yeah.
And we're going to deploy a little deeper as we already discussed here.
Perfect.
Go ahead. Good. So let's take one picture.
Yeah.
Inject.
You see, for the audience, the marker is at the pigtail end. I mean, the marker bend.
Yeah. Yeah, I think we're going a little bit deeper. Yeah.
Yeah, because usually you place it in the middle of the pigtail.
Pacemaker is there already.
Yeah, so pacemaker, it gives us additional comfort. We don't want to be too deep as just for the audience, because that can be cause some paravalvular leak and mitral tear interact with the mitral valve. So I think we'll take a picture here. This looks good to us.
Yeah, goal is like 3, like you said. I think that'd be ideal.
Yeah, it is good.
Yeah.
But
Sushil and everybody, you guys are happy with this position?
You guys are happy? Eberhard, you happy?
No, I think don't go deeper.
Don't go deeper. I think this is right around 3.
Okay.
Yeah.
Yeah, this is good. Okay. So pace at 140, please. Okay, go ahead. Open a little bit. Yeah, go.
So he's pacing, right?
Yeah, I think so. No, maybe not the last capture.
Go a little faster. You can go. 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 Good. One more turn. One more turn. Good. Ready. Let's take an injection now. Inject. Okay. We're going to take one coronary shot here. Go LAO. Shan, stop pacing. I think that's too deep. What do you think? Or we accept it?
It looks deep to me. It looked like it was like 4 or 5, and I think you want a couple millimeters up on the non.
Yeah. So recapture. So remove the parallax.
I mean, you can do a shot here if you want to check. I don't know what the renal function
is. Let's take a
picture. Yeah.
Inject. I think we're okay. Sushil, we are. See, you look, the pixel is a little higher. Freeze that. So I think we are just 5 to 6 millimeters.
Yeah, it just looks a little deep on the left is the only concern I have. But I mean, what do you, Eberhard or others, what do you guys?
Yeah, I mean, I honestly don't look so much at the left. I look at the non-coronary because that's a determining factor. And on the left side, on the non-coronary side, I think it's good. And let the valve on the left side away.
Yeah. Can you play the previous shot again, Ravinder?
Play the previous picture. You know, our picture is way high up. You can see now.
The previous one. The previous one, the cusp overlap view.
Yeah, cusp overlap. Go minor.
The sinuses are filled with leaflets.
So in a non-native, it would have definitely come up a lot. But here, I think we're gonna go ahead and maybe we'll come. Yeah, pacemaker is already there. We want to do a coronary access. This patient has a coronary artery disease. We can easily come up a little, but I think this is okay.
Okay. Yeah, and if you're going to deploy here, what are you going to do with your catheter?
Yeah, so we're going to discuss that. You know, we're going to go put this catheter on the left side and take one more injection. Let's see. Yeah, ready for injection there? Inject. Now show us iliocranial, please. Go iliocranial. We're going to see better in an iliocranial how this coronary is occluding. My idea is, you know, I'm going to pull back the guide, leave the guideliner and stent in place, and deploy the valve. Okay, ready for one more injection? Inject.
Ravinder, if you are too deep, you will lose the advantage of Resindol. You lose the vest and probably...
Come to the ariocaudal, please. Again, let's go to the cusp overlap. We're going to recapture a little here.
Yeah, I think I would come up a little. It looks a little deep there.
Come back. Yeah. Recapture. This looks a little deeper, so we're going to recapture.
I think that's an important point that if you end up a little bit too deep, you lose that coronary window.
Go ahead, deploy now. No, you're fine. Go ahead, deploy. Good. One more turn. This looks much better now. Let's take one picture. Inject. Fine. So we're going to go ahead and deploy. Go to iliocranial.
What do you think?
Yeah, I think that's, if you could
go
keep that's
Just
perfect.
go plain ilio. Remove the parallax. Good. So I'm going to pull back the guide, leave the guideliner in place.
Yeah, it's okay. It's better than before.
Okay, go ahead. Slowly. Go ahead, deploy. Wait, slowly. Yeah, go ahead. Slow. Wait now. Slow. Wait. Okay. Yeah. So see how the lie is on the outer side. So at this point, we're going to remove the pigtail because everything is too crowded in that space.
Also, I like what you're doing. Go slowly, you know.
Yeah, go ahead. Deploy now.
What?
My pigtail is a little jammed. I'm not able to take it out, but I'm going to show how to do that again. Yeah. Go ahead.
So your STJ calcium is going to protect your coronaries probably.
Yeah, in some ways it might. Yeah.
Least. Both the tapes.
Good. So both the tabs are out.
And beyond certain.
Do you release the nose coronary?
Yeah.
Why? 0.14.
Okay.
Whoa.
Fine. Now we're going to look at the coronary. Let's see. So the idea is we pull back the guide way in the ascending aorta. We'll look at the coronary artery now. Let's ready for an injection. So I'm going to pull back the guideliner till the level of the left main there, not out of the stent. Ready for injection? No, here, coronary injection.
So that's an important point. He didn't want to pull the guideliner beyond the SDJ because that's what's going to protect you if you take that stent out. So he pulled it just to the left main because you don't want to inject with it in the left main. So essentially it's like a catheter.
I think we should be fine. So
now, Ravinder, can I ask you a question? One thing that we discussed before, one of the things I've done in case like this, I don't know if you have to go because the hemodynamics, please go ahead, but is to engage, take your evolute system out, put a 14 French sheath, and then engage the coronary through that before you take the other one out so that you know you're protected.
100%. We're going to show that also.
Okay.
So you can see how the borderline the vessels were, and we are happy we can. So we haven't pulled out the guideliner, but the reason is you don't want to jail a guide behind that strut. So now we're gonna pull the stent back into the guideliner. You can see. So I'm gonna take one more picture. Let's say sometimes the stent shaft can protect the coronary. So let's take one more picture here. We are fine. The coronary ostium is way away from the coronary, but the reason you are not getting a picture is
some cranial will be better.
Yeah, LAO you were saying, but yeah. Yeah. Because I've not seen the left main fill well there. That's the only concern I have.
Yeah, go LAO. So I've engaged more closely with the guideliner. We'll take a picture now. Inject. So let me try to push the guideline a little more.
Because it does look, I don't know, I guess I'm having a hard time hitting the screen.
See how easy the guideliner makes our life. I advance the stent, and on the stent, I'm going to advance my guideliner a little into the coronary, and I'll pull back the stent, and we'll take a picture now. Ready? So coronary flow is good. What I'm going to do is I'll pull back the guideliner a little more back, and then we'll take one more picture. Ready?
Yeah, pull it
Take a
back up
picture.
to the stent frame, yeah, and then now you can inject.
So I think we can see the coronary ostia very well. We'll engage through the guide. It is getting, so let me remove this, the stent, and then you take a proper picture. It's difficult for us to get that picture because the stent and the guideliner. Let's take a picture now. Good. So I think we are happy. The coronary is nicely flowing. Now we're going to remove the wire as well.
Yeah.
And see, now the problem is now what I see is my guideliner is behind the valve frame, but I think we are right at the STJ. I can pull it out without a wire. So I'm going to pull this guideliner out, and there it comes out. So this is done. Now we're going to remove this jailed pigtail. So sometimes what happens is this jailed pigtail can form a sling. So we're going to show you how to remove this jailed pigtail with a wire. So we're going to take the normal 035 wire, and instead of pulling the pigtail, just keep pushing on the wire. So when you keep pushing on the wire, and now let the pigtail come out passively. And now we'll pull out the wire. So this we are done. Bring the pigtail back on top of the valve. Give us a JL3, please.
JL3.
So post-dilatation versus no post-dilatation, and then doing a coronary angiogram. So
I would not post-dilate. If you look at all these hemodynamics, I think this anatomy I wouldn't post-dilate.
I'm not going to post-dilate at all in this particular constrained anatomy, but I'm going to engage the coronary. Let's remove this, prepare the 14 French sheath. Retrieve all these.
The left, leaving the wire.
So Ravinder, one thing I was saying is in cases even if I think I'm going to need to stent the coronary and it's not acute, I like to engage I keep the stent in and the guideliner in, and then I re-engage through the middle, and then I stent through the middle, because that, at least in the future, you'll have easier access to the left main if needed.
Otherwise, it'll be like a chimney stent.
Yeah.
Give us a
you're crushing the stent. Maybe that's better to do what Sushil said. Keep the wire guideliner stent in that. Take another catheter, remove the pigtail, use that access to get a proper guide into that. So like almost like a ping pong technique which we use.
Yeah.
So. But the stent, the stent is for that hemodynamic compromise. Sometimes that this VT, VF, and the coronary gets occluded. So put the stent, and then as Sushil said, come back again through the stent and realign it to the aorta or the inside the valve. So we're going to do hemodynamics. We'll be guided by hemodynamics about the need to do a post-dilatation or not, but we're not going to do a post-dilatation. He's a 77-year-old patient. We might expect a mild, but actually I'm not expecting any paravalvular leak also. We have a good depth of deployment. Our diastolic pressure is 73, and we're going to show you the hemodynamics right away. Okay, I think let's zero both. Flush, please. Good. Okay. Zero. We have some time, right? Do you want to engage the coronary and show it to you?
Yeah, I know. I mean, I want to do what you would normally do. I don't want you to go outside of your routine.
So no, we do that. We do that for all our self-expandable. Can you see the hemodynamics there?
Yes, we can see
that. Looks very good. Actually.
Very good.
I think that's again, this was a small anatomy, calcified anatomy, constrained sinuses. We're gonna do an aortogram. Let's do an angiogram. Go to the ileocranial so that we can see the valve and the coronary arteries both.
Yeah, after the aortogram, probably we'll go to the other side center, and because
we'll just take a few seconds to engage the coronary artery. Dr. Ramesh, ready for injection?
Sure.
Okay, inject.
Sure, Dr. Ravinder.
Plus.
And look at the coronary. Look at the calcium distribution.
Right.
Put the wire, please. Push the wire. Come to the APQ.
Can you just make the screen bigger on fluoro screen, please? Just one screen. for us, and Dr. Ravinder's picture can be made smaller. No need for hemodynamics now and ultrasound.
Yeah. So we're going to go inside the valve with a normal wire and use a smaller catheter and then just go LAO, make the valve into a straight line.
Can you make the fluoro big?
Yeah.
And take everything else off?
Back up.
The most important part
Yeah,
is
that's great.
Perfect. Thank
Very
you.
good.
That's the coronary.
That's it.
So
And we'll show you how to, because the important thing is how do you disengage this catheter. Give me the back end of the wire. That's the coronary artery.
Excellent.
Back end of the wire, please. So the way to remove this catheter is not to pull it out. Just use a back end of the 035 wire and you would see a passive disengagement. I'm just going to come with the straight portion, there it disengages and then take it out.
Yeah.
This is a great example. I think those are important components. Those are small tricks. Ravinder, I wanted to, first of all, thank you and your team on a Sunday for really a high-risk case, a great demonstration. You know, a lot of useful little tips and tricks that I think people can take back, and I think that's very valuable. So thank you again.
Very, very much so.
Thank you, Sushil, Professor Grube, Ramesh, and everybody. And thank you for making us do this case smoothly and swiftly. Thank you so much, guys.
Thank you very much.
Thank you so much.
Great job.
Great. One thing, though, I would like to point out, you know, the coronary, it's just at the height of the waist.
Yeah.
So this is something, I mean, he's made so many right things.
Yeah.
Just keep in mind when you have the waist that you don't explode with your balloon. And
Correct.
Thank you.
Yeah. Okay, so we can move to our Calicut. Yes. Dr. Ashish, can we move to the next slide, please? Thank you. Dr. Ashish, can you hear us?
Good morning. Good morning. Good morning. Is it
Good morning.
You?
Yeah, so I'm here.
Good morning,
with,
Dr. Sushil, Srinivas, and
good morning.
Good morning. I think, you just witnessed a wonderful case from Jaipur, Dr. Rao. And first of all, thank you to the organizers, Dr. Srinivas Kumar, for giving us this opportunity. And shall I introduce my team?
Yes,
my
please.
first doctor is actually Dr. Ashraf Hussain. We have Dr. Shajuddin, because we expect certain coronary, So there are three of us on the case. Dr. Smera is a cardiac anesthesiologist. We are doing this under conscious sedation. Scrub nurse is Mr. Habish and Mr. Nandulal, our technologists. Dr. Shahul and Arjun, and all the staff nurses on, Dr. Along with Smera, we have Dheeraj, we have Ramya, Anita, and Anusha. And we have Dr. Sajid looking at the echocardiogram for us. So, shall I give you the case details?
Please, go ahead. Yes.
Yeah. Now, this is a 72-year-old gentleman, morbid obesity, BMI is 47.6. Recurrent pulmonary edema, severe calcific aortic stenosis, mean gradient of 33 and an aortic valve area of 0.7. In the setting of moderate LV dysfunction, EF is 34%. Mild to moderate MR, mild PAH. Baseline left bundle branch block with a QRS duration of 195 milliseconds. The PR interval is 208 milliseconds. He has coronary artery disease, has undergone a PCR to the right coronary artery in 2015. And because he was going for recurrent pulmonary edema, a couple of months ago, an angiogram was done which showed one vessel disease with a patent stent in the right coronary artery and about 50% stenosis just distal to the stent. Added to that, he has stage 3A CKD. The eGFR is about 52 ml per minute and has had a recent worsening because of diuretics, but presently reasonably stable renal function. Next slide. You could see the ECG for yourself. Next. That is a gradient 60/34. Global hyperkinesia. And now this acquisition is predominantly diastolic, but the aortic diameter is 24. The LVOT is about 25 millimeters. The left coronary height is only about 7.7. The sinuses are roughly about 30 millimeters. Next. Now, the sinus of Valsalva height is only about 9.2. There is a bit of calcification on the annulus, but not much. But fluoroscopically, we felt it is much more. Now, the left leaflet length is about 12 millimeters and left coronary height of about 7.7 millimeters. Next. Now, for the ascending aorta, the STJ per se is free of calcification. Bit of calcification on the arch. about 50 degrees of aortic angle, and calcification analysis, it's about close to about 700.
Can I ask a favor?
Right.
Can I ask a favor?
Yeah, please.
Can you go back 3 slides? Because I think this is important learning stuff. So one more slide.
One more slide back?
Maybe one more back, please.
One more back?
Yeah, where you showed the sinuses.
Yes.
So maybe it was one back. I saw, if you go one more back.
Yes.
The left sinus is shorter. And you mentioned that that sinus height is small and that leaflet is around 11 to 12. I think these are the ones that, you have asymmetric sinus, you have a short sinus, you're getting a low left main. These are concerning features. And when you look at a sinus height, looking at that asymmetry is an important component. And as you go forward a few slides, or maybe it's one slide, you saw that on the left as well. And I think that's an important sort of teaching point, because these are things I didn't appreciate early on. And these do add to the risk of the procedure. And when you showed that left main in the axial view, go forward a couple slides.
Forward.
Where you showed the left main, I think. This one, you still see leaflet in the picture where you see the left main.
Yes.
And so, this is something I would be cautious about. If this was a bicuspid with right non-fusion, this would be very high risk for sealing the left sinus. And I think that's an important component. If it's because you're going to be pushed to the left. If it's a tricuspid valve, you may get away with it, but these are things to think about and highlight. But sorry, keep going. I just wanted to point that out before we lost you.
Sure.
And do you also look at the height of the length of the leaflet in this?
Yeah.
So that's the other point. Low sinuses, low coronary height. Look at the length of the leaflet, bulkiness of the leaflet. All those will indicate coronary protection. Thank you very much, Dr. Ashish. Please go ahead.
Yeah. Previous one. Go previous. Yeah. So now the other challenges that we have had is, it's morbidly obese, abdomen, it looks a little hostile, the groins, and the commissional alignment requires a 257. Next. There is a bit of calcification, slightly smaller right femoral axis. Next. So the challenges in a nutshell: morbid obesity with a hostile femoral axis, LV dysfunction, CKD, baseline LVBB, a PR which is slightly prolonged, low LCA height, and a leaflet length of about 12, with a sinus height on the left side of about 9.2 millimeters. Next. So the plan is transfemoral, primary axis is the left. Because he's obese, we thought we'll have 2 proglides. And gently we thought we might, and that is why it's been a practice, you keep a safety wire, slightly lower puncture, micropuncture wire. But here we felt, it was not as bad as we expected. We use an AR2. Most of the operators prefer an AL1. I prefer an AR2 because I think Indian patients slightly smaller aorta. And because of those facts, which Dr. Sushil, talked about, we felt it makes sense to at least attempt, have a coronary protection on the left with a Judkins left catheter because of the short sinus, short coronary height, and asymmetric sinuses. We thought we'll predilate with the 20, even though it's a tricuspid. It will just give us an idea whether the coronaries are likely to get affected. And the choice of the valve, I think it's a balloon expandable valve here. I know it's going to attract a lot of attention, discussion. 24.5 is what we decided on with 3 cc volume extra, which works out roughly about 8 to 9% oversizing. Other option was a 26 millimeter valve, and the VTC there was about 4.5, and that will be close to about 14% oversizing. The bailout option, we have a Manta and the surgical standby. So the choice of valves would, when we looked at, we thought will go ahead with the 26, but when we looked at the fluoroscopy, we felt that there is a lot of calcium in the annulus, which was probably not as made out on the CT. Do you agree with the plan?
Yeah, no, I think you raised all the important issues. We don't have intermediate sizing, so for us it would be a 26. And again, I don't think getting hemodynamics or work. This patient's whatever you put by definition is going to post patient prosthesis mismatch. You can't match to a BMI of 46, right?
Yeah.
So so I wouldn't chase hemodynamics in a case like this. You have deep access. You want to do the safest, most controlled procedure possible. And I think it's people may have one preference or another, but I think the plan you outlined is very reasonable. And I would protect the question. We didn't discuss in the last case the role of leaflet modification if you had an easy device. Right now it's Basilica. The role of leaflet modification in a scenario like this. Ramesh, would you do a Basilica or something here?
I think my gut feeling is we can get away without, because the sinuses are pretty roomy, and because it's a balloon expandable valve with at a height of the frame about 18.75. My gut feeling is you can get away without a coronary protection, but then it's always makes sense to actually protect it up front.
And I think it's a really reason why. The one thing with when you're BAVing with the guide in, the guideliner may help protect. I always tend to pull the guide back. I'm worried about dissecting the left main or something. I'm worried about pushing things further in, so I just be cautious with that.
Yeah, definitely.
Yeah. I think very good point.
What we're supposed to do is that, we thought after the balloon dilatation, we'll see, and then if required, we're not put a stent in, because most probably we should be able to get away.
Yeah, go ahead, Dr. Ashish. Meanwhile, I'll just answer this question. I think in an ideal world, how can surgery and TAVR be equal? By actually taking the leaflets out.
Yeah.
Okay. If the procedure is simple, cost is very not economically expensive, then I think a Basilica or some type of leaflet modification probably will be in the future. In 10 years from now, I think especially in younger people, this will be the way of therapy in the future. That's at least what I think.
I agree. I mean, if we had a better device, it would be easier to do.
Yeah.
So, I mean, there you injected, again, it's a 20 balloon, so it's hard to say how much because we're doing a 24.5, which is probably being deployed a little bit bigger than that.
Exactly. But then if you, I can play you, play this video back to you, the angio.
Yeah. Let me ask both of you. In the US, we don't have intermediate sizes. 26 minus 2 or 23 plus whatever 5 cc?
I think at 460, I would have to do a 26.
26, right.
I would do, yeah.
Right. How about you, Dr. Manoj?
I will also do 24.5 plus 2-3 cc extra because the sinuses of Valsalva is 30. And chances if you use a 24.5 will get away without doing anything to the coronaries.
Yes, the two things that came from this thing was that with the 26 virtual valve, the VTC was about 4.5. When you have a 24.5, it is about 4.8. That is one. And
So I think what also reassures me is, and I only share all this stuff for mistakes made and lessons learned. When he inflated that balloon, it stayed on the other side. It didn't go towards the left, right? Because the balloon, and so the valve is going to not deploy
towards the left.
Okay. The valve's not going to deploy towards the left because I did this in a bicuspid, that memory sticks with me because that was very traumatic, but it's a non-right fusion. And in retrospect, when I look at the balloon, it was pushed that way on the BAV. I didn't notice it. And the valve deployed that way and it was an asymmetric sinus and I occluded the sinus.
Yeah. Now, would you have considered a self-expanding or, from way of discussion, would anybody have preferred a self-expanding in this case?
Yeah, I don't know.
With left bundle branch block and PR 200 plus, I think balloon expandable is the best choice.
Yeah, I think he's likely going to end up with a pacer at some point anyway. So, but yeah.
Yeah.
So there was a discussion about. So you're not putting a stent in this case because you're not.
We are. Yeah, I think it's safer because I know most probably we may get away without requiring coronary protection, but since we have it, you just end up sacrificing a stent. So
I mean, the only concern that we're raising here is that the guide is a little deep, and I would probably pull the guide back before you deploy the valve and just leave the guide liner.
It's a very short left main. It's a very short left main. So what you'll do is just get a stent in. We'll pull it back once the stent is in, and that should be fine. Yeah.
So you are going to put a stent to protect beforehand?
I'll be happier.
You'll be happier? Yeah. No, I think that's,
Yes.
I mean, in general, that's what I tend to do. Obviously, it's a waste, it's a cost issue, but yeah. But if I'm
Then
worried,
you're spending on
if I'm worried enough that I'm
on a valve.
protecting, I usually put the stent.
Yeah, I mean, but now the stent prices is $150 in the US, and so
Yeah, not worried as much.
before it was 2,000.
With a $30,000 valve,
Yeah,
$50 doesn't seem like a lot.
Yeah.
Especially in India, cardiologists who are doing towers and organizing such meetings, they can't complain about 40,000 rupees.
Yeah.
So now the guide is coming back, and we will see whether we can get away with a shallow deployment. We'd like to come out without a pacemaker if possible. Huh?
And here your STJ is big enough, which is, I think, important because you are going to be probably hitting the STJ with this valve because it's so short, right?
Right. Okay. So just one injection. Not yet. Cine. One shot injection. The ACT is 350 now. Yeah. Okay. So he's a little restless. Yeah. I think seems pretty okay to me. We'll try for a relatively shallow implant, 3 millimeters, 2 millimeters is what we are aiming at. We'll see.
The positioning is very good. Yeah.
No, not required. Yeah. We can try. No, this is perfect. Okay, so we are going for deployment. ACT is 350.
Sure. It'll be almost like zero implant, I think, with this
Yes,
position.
hopefully. Yeah. Right.
But in low coronary height, you want to put it in a little deeper, Manoj?
Little over down. I agree.
Surprisingly, Ramesh, these intermediate sizes don't force out in too much.
Yeah. So that's a very valid point because in case he requires a pacemaker also, that is still okay. We can come out without a stent in the coronary and that to jetting out. Okay. So pacing at 160, madam.
Doesn't look coplanar.
Yes.
Yeah, it's not coplanar.
Yeah. Go. See. Yeah.
It also is.
Go up slowly. Yeah. Just gone in. Yeah. Yeah. It's time to go. Inject. Yeah, I think we'll take this. Yeah. Go. Yeah.
Pacing is smooth.
Off pacing. Yeah, deflate. Off pacing. Floor off. Now the rhythm is still stable. He's in sinus. LBBB. The pressures are okay.
Yeah. Sushil, are you doing any EP studies, the AH interval prior to, because in the US actually pacemaker implantation is a complication. Report card.
So we used to do EP studies and we found them unhelpful. Every time they did an EP study, they put a pacer anyway, so it didn't matter.
60.
See, this patient has LBB with prolonged PR. Don't you think we should put a pacemaker and send him home rather than sending him?
I mean, that's sort of my bias. I think I have a very low threshold in a patient like this. The PR is 240, has a left bundle. The last thing you want is get a good procedure and then have an asystolic arrest at home.
Right. See, my problem is actually, number one, we are going to create TR and then use tri-clip afterwards with the pacemaker if you go cheap. And the cost of Micra in the United States is $18,000. They'll give you a rebate of $3,000 if you use. So
I mean, I think the one thing I would do, even if you're not putting a pacer, this is someone I would not send home the next day.
No.
I would watch, 48 hours to make sure. In the U.S., we have this EPCOT, which is real-time monitoring. So I usually, if they look stable in 48 hours, I send them home with EPCOT monitoring.
What we started doing, Sushil, is we are pacing the same pacemaker. We put it in the atria and pace. The conduction is up to more than 120. We are reasonably confident that they won't go into stage.
Very, very good.
Yeah.
What we thought was, in case the LV function does not improve, we can probably go for a bundle branch pacing, Cine. A septal, a bundle branch pacing, so the LV function improves as well. Now, the coronary seem to be unobstructed. The diastolic pressure is about 90, so it does not have significant aortic regurgitation.
Sushil, said the valve tilted to the right, I think.
Push inside.
The VTC maintained.
Yeah. Push inside bedliner.
So what Dr. Srinivas Kumar was saying is exactly what Samir does, and in their center, Amar Krishna Swami has shown right atrial pacing and seeing actually if the patient develops a Wenke Bach and or a second degree AV block, then they'll go for pacemaker.
Fluoro, Ashraf? Fluoro? Yeah. Ready? Stent inside? Yeah, I mean, stent is okay. I think we can take out the stent now because it seems to be pretty okay. We'll take a picture. Yeah. Alignment proper. Alignment proper. Okay. Fluoro, Ashraf, fluoro, please. Fluoro.
Yeah. So you can remove the guideliner and everything. I think.
Guideliner as well. Yeah. The guideliner back a little.
Yeah.
Back. Yeah. Just a while there.
Yeah.
Back.
Right. That's good.
Yeah. Ready for the injection? Ready. Injection.
Yeah. There's still good coronary flow. So
Yeah,
excellent. No AI, nothing much we can see. I think Dr. Ashish, fantastic demonstration. In view of time, is it okay if we go to the?
Definitely. Do you think we should do anything? I mean, would anyone consider doing anything for the PVL? We have already, done a double tap and 24.5 with 3cc extra volume. So should be okay?
Yeah, I think it's very good. You have diastolic pressures of nearly
84, 90. Yeah. And the access to the coronaries is very well preserved. So basically the intermediate sizes helped us in this regard. And I think there's an acceptable result. Would you all agree?
Yeah, I think the recommendation, normally we should remove the stiff wire and take the iotogram. You can have a pigtail catheter, but even then, even with the wire, it is very mild. It is going to be only less than that. So thank you very much, Dr. Ashish, for fantastic demonstration.
Thank you all of you. Thank you all of you from our team. Thank you and bye-bye. Have a great learning today. Thank you.
Thank you, Ashish, and all your team. Even in Calcutta, Calicut, and other places, the tower has picked up so much. That's why you purposefully chose this, and you've proven it right and did a great job. Thank you again.
Thank you, Dr. Srinivas. Thank you. Thanks so much.
Now we move on from the live cases. I hope all of you enjoy these live cases. Now we have 2-3 important lectures concerned with this, and we have Eberhard Gruber with us. I wanted to listen from him. What are the challenges he thinks in today's era for TAVI, and then how to unresolved issues and the solutions. And then I'll be here, and along with other panelists who is here, Miraji, Sampath, Sheshikir Rao, Raidu, and other colleagues, Tripathi, Jyotirmay Das, you can join me. And then what we'll have in this is two very important talks of Eberhard. One is on the tricuspid valve, what is happening there, and then the challenges and solutions of TAVR. Sushil will be speaking exclusively on TAVR position in aortic regurgitation, though we have a live case coming up later. So, and with this, I request Dr. Eberhard Gruber sir to come over. Can we have Dr. Eberhard slides here and deliver his talk? Please come, sir.
Thank you. So all the other panelists, Dr. Miraji Rao, Dr. Sampath Kumar, Dr. Seshagir Rao, Dr. Raidu, and Dr. Mohanty, Dr. Jyotirmay Dash, Dr. Sunil Kumar Tripathi, Dr. Vikas Majumdar, if you're here, please join us. And the chairpersons are actually Dr. Shailendra Singh, Dr. Devdatta Bhattacharya, I don't see him. And
perfect. Yeah, thank you very much. And I can't start without thanking the team, Srinivas, Sushil, and Ramesh for organizing this. I'm happy to be back in India to partner with all of my friends here. It's a great honor. And I'm very pleased that he gave me 2 talks that I really have to think about. These are not out of the box, and I hope you will enjoy those. Challenges in TAVR, and I will propose some of the solutions. So TAVR has revolutionized the treatment of patients with aortic stenosis, no question about that. Several randomized controlled trials across the surgical risk spectrum established TAVR as a non-inferior or even superior alternative to open heart surgery. This ever-growing backbone of clinical data has also provided us with multiple learnings regarding the technical abilities of the devices tested in those trials. I do believe that most modern TAVR devices have matured, addressing many of the challenges that arose with this new therapy. But there are still some unresolved issues present that require new and innovative solutions to further optimize TAVR procedures and outcomes. This talk aims to explore how we may rethink key aspects of TAVR, from vascular access over procedural execution to long-term device function. The presentation focuses on device-related solutions and not on long-term outcome studies answering possibly some open questions such as aortic regurgitation, asymptomatic moderate aortic stenosis, and others. So let's start with access profile. Also, unresolved issue, access profile. Also, with advanced delivery system and dedicated closure devices, relevant access site complications remain prevalent, about 15%, and are associated with an increased mortality, as shown. Thinking of the advancements achieved in coronary care, when we're going from femoral to radial in order to further streamline and minimize TAVR procedures, reducing the access profile and its associated complications remains a key gatekeeper. Solution to access profile. Leveraging the engineering ingenuity of a whole new alloy, stent strap profile can be substantially reduced while maintaining similar radial force. An example I'll show you here, the Ziegler MyRIS THV. On the left side, you see the platform design, the new alloy, a balloon expandable valve, and on the right, rhenium superalloy, very strong, well known in orthopedics. Reduced strut profile allows for delivery crimped on the balloon through an 8 French expandable sheath, significantly downsizing access profile. Given the properties of the novel alloy, even with reduced profile, a circular and cylindrical and short deployment can reliably be achieved. Alignment. With growing TAVR experience, more detailed procedural understanding, we appreciated that THVs were randomly aligned with respect to native commissures, as we all know. While in recent practice, alignment was a nice to have, helping with coronary access, its potential implications reach far beyond that in younger patients. You can see on the left side, commissure alignment, important for coronary access, redo TAV durability, near native flow and leaflet stress, coronary filling and flow, and reduced frame distortion. Solution number 2, dedicated innovation and device iterations will help us to achieve reliable commissure alignment across different platforms. Here, latest generation Evolut FX, Navitor Vision, and the Sapien X4. Coronary access. Unresolved issue, how to preserve coronary access has been identified as a key issue of TAVR in narrow anatomies and especially in many TAF and SAF and TAF and TAF scenarios. Coronary access depends on the multiple parameters such as design of the first and second device, the implant depth, and leaflet overhang and functional neoskirt. Those are new definitions that we have to understand when we talk about TAF and TAF and TAF and SAF procedures in younger patients. In many cases, a risk for coronary obstruction, chimney stenting, has been introduced and widely adopted as a simple countermeasure. But while preserving flow with an easy-to-use off-the-shelf trick in patients more than 80 might be sufficient, it is not good enough in younger patients likely needing PCI and repeat procedures. In many cases, these stents will be crushed, and while flow is preserved, access is virtually impossible. So, potential solution, only using advanced techniques to modify leaflets, easy coronary access can be preserved. For broader applicability, dedicated devices are needed and are in the pipeline. Shortcut, Telltale, Bonaparte, and others. So, preventing acute coronary obstruction during the procedure using off-the-shelf measures was a sufficient solution in elderly, high-risk patients, but as a lasting and true solution, preservation of coronary flow needs to be upgraded to reliable coronary access. Advanced techniques will have to be integrated into the interventional portfolio to achieve this goal. Only with the help of dedicated devices, such highly relevant but technically challenging techniques can be made widely available and democratized. Need for new pacemaker. Unresolved issue. TVT registry analysis shows new PPI post-TAVR across device technologies, still balloon expandable valves, 9.3%, even with the new gen that has been approved, and self-expanding valves, 15.6%, also after new gen approved. So it is an unresolved issue. But predicting new onset conduction problems after TAVR remains challenging. Pacemakers are a permanent solution for what is often a temporary problem. New onset conduction disorders after TAVR increase length of hospital stay, and implantation of unphysiologic right ventricular pacers increases mid to longer term mortality altogether, creating irrelevant clinical as well as economic burden. Solution: smart valve system, real-time, on-demand sensing and pacing. You can see the implant clipped to any valve that you choose, the wearable device, and then the physician control unit. So this truly novel solution may tackle several of the current challenges associated with implantation of permanent pacemakers after TAVR. As we still struggle to predict who might need a PM and whom to keep in the hospital, smart valves can monitor the peri-procedural phase in every single patient with a THV. A hospital stay often is prolonged due to the unclear rhythm. Smart valves enables rapid discharge with not only a passive, but a reliable, active, potentially pacing safety net. As an unphysiologic right ventricular pacing associated with increased longer-term mortality often is not required beyond the peri-procedural phase, smart valves bridges exactly this period. Leaflet degeneration. A continuum of randomized trials of different TAVR devices against surgery delivered us the encouraging message: long-term outcomes are equal between therapies. Here, partner 3 low risk, partner 2 intermediate risk, and Notion 10 years with core valve. But also with TAVR, failure of bioprosthetic leaflets was observed at similar rates as seen in surgical bioprosthesis. Also looking at partner 3 low risk and Motion 10 years. Novel, out-of-the-box frame designs and leaflet technologies aim to create a more durable environment for the bioprosthetic valve material. Durava THV, as a first in class of next-generation balloon expandable valves, has anti-calcific, anti-fibrotic adapt tissue and long coaptation to reduce leaflet stress. Very interesting new valve. Also, as a first class of next-generation balloon expandable valves, more physiologic design proves restoration of laminar flow and normalization of left ventricular mass. TAVR repeatability. Potential scenarios of repeat TAVR likely unavoidable in younger patients with bioprosthetic material prone to degenerate face several challenges. Redo results in smaller and smaller THVs, questionable EOAs and PPMs. THV frames get more constrained, likely limiting valve function, and even if achievable, coronary access remains challenging. To solve many of the potential issues caused by the spacious and constraining degenerated leaflet THV material, their actual removal might be needed. This may allow to rethink redo in a more modular and thus optimized way. To enable a circular site for optimal TAF and TAF deployment and expansion, dedicated devices aim to grasping, resection, and removal of THV leaflets, such as the Trisect, as shown here, removal of the leaflets. While this may reduce issues such as coronary access, PVL, or PPM, it may also allow for redo, upsizing, and an increased orifice area, as shown here in 23 and 23 without resection, and a 23 and 23 with resection. Bicuspid anatomy. Bicuspid anatomies still represent the most prominent anatomical challenge for application of a straightforward TAVR procedure. Constraint of the THV frame by the calcified raphe may lead to elliptical underexpansion, as shown here. Such eccentricity is known to be associated with halt, pinwheeling, and THV degeneration. Leaflet laceration, ideally using dedicated devices, allows for aortic root tricuspidization, ART, or ART, and may enable tricuspid-like results. As shown here, you cut along the raphe and you get a broader and more circular shape. Leaflet laceration, full circular expansion. Denny DeVere published just recently a first-in-human cohort of 7 ART cases splitting bicuspids to tricuspidize the anatomy, proved technical feasibility and reliability of the approach, and pre-procedural identification of optimal split in CVS 1, adjacent to the raphe, ideally at a less calcified spot, and in CVS 0, center of the dominant cusp. Leaflet traversal and laceration to perform aortic root tricuspidization. Post-procedural CTs proved good circular expansion, no underexpansion or eccentricity, 0 cases of halt. So, bicuspid aortic valve leaflet modification prior to actual THV implantation, ideally using dedicated devices, could represent a new paradigm, potentially enabling to achieve tricuspid-like clinical outcomes, also in challenging, high-risk bicuspid anatomies. So, unresolved issues and their solutions, TAVR 2026. Access profile, innovative alloys may allow for a whole new profile of THV stent frames. Alignment, added commissural markers of latest generation THVs ensure implantation with optimized rotational alignment. Coronary access, dedicated devices may enable broader use of advanced techniques modifying leaflets for reliable coronary access. New PPM, introduction of smart THVs, could enable continued monitoring as well as active pacing after discharge if so needed. Durability, novel frame designs and leaflet technologies could further enhance durability of THV leaflets. Repeatability, redo techniques may include actual removal of degenerated leaflets, allowing for optimized modular THV and THV. And finally, bicuspids, leaflet modification for aortic root tricuspidization, ART, has been introduced and may facilitate tricuspid-like results. So finally, considering the tremendous advancements that have been achieved with this truly novel TRV technology in the last 20 years, TAVR in 2026 may still face some unresolved issues, but their solutions are already on the horizon. I do hope that you leave this talk assured, or at least excited, for the next phase of the TAVR journey to come. With that, I would like to thank you all for your attention.
So I think, Eberhard, you really summed up the field and the space. I mean, so when you look at when you look at your slides, it makes you wonder how TAVR works at all. But we've done, there's been over 1 million done probably, right? So there's a lot of forgivability is what we're saying at TAVR. I think one point that you hit that highlights, and I think it's important in India, is the patients we're doing TAVR now, the durability piece, the bicuspid piece, the repeatability piece, is becoming an issue because we just never, at least in the U.S., never did those patients before. And here we're seeing, we saw the cases today. People, I think 3 of the 4 cases were people in their 60s, right? If I remember correctly. And so how are we going to get the data? Like the Duravar, the MRI, all that. I mean, I'm a proponent. I'm involved with them. It looks good. But like, do we just say, okay, we have Sapien data for 10 years. Do we go with that? How do we choose? Because no one device is going to have all of this, right?
Yeah. Well, I mean, obviously, those are very relevant questions, and I don't have a final answer. The only thing that I can say, though, is a very simple thing. You can claim everything, particularly now that you talk about durability. You can claim anything that you change will effectively convey into better durability. You can claim it, you can say it, but at the end of the day, only durability will be proven by durability. Very simple, very stupid, but it is what it is. The second thing is we have to be very careful that we don't fall into the trap because we're dealing with ourselves. You remember when we talked about durability in surgical valves, Sushil, we said redo surgery is responsible for durability. That is simply not true. When we talk about numbers now, redo cases and say we only have, for example, 20 or 15% redo cases, so durability is very good. That is very dangerous because that is something that we said surgeons cannot do, so we cannot do it either. Remember, when we talk about the 10-year, 12-year data set, those were older patients. This is a totally different risk and age group than the age group that we're treating today. So unfortunately, we have to wait. Remember when there was the fierce battle between balloon expanding and self-expanding valves, what we got trashed and bashed. We're not, this is unphysiologic, this is crimped, this is thin, this is bovine and not porcine or not bovine, everything that will fall to pieces, it will not work. Well, guess what? After 10 years, both valves work quite well and with not much difference. So an answer to your question, I don't know. I can say, and that's what I say in these talks, you can claim, and I believe they have reasons to do it with these, for example, new valves. But whether or not that conveys into real better durability or even real durability remains to be seen. Sorry, I don't have a better answer.
I think it's important to this thing doesn't work. I think it's important to acknowledge what we don't know. So, Ramesh, you want to make a comment?
No, yeah. So I know we're talking about towers, as you just see in this room. It's completely full, talking about how many people are interested in learning tower, and we talked about in younger people as well. So my question to you is about in younger people with aortic stenosis, without going to tower or which is a definitive therapy. Are there any other things that you're thinking of? Like we had conversations with Shockwave. They're going to come up with a balloon. And actually one of my patient who's a CEO was the first one from US who went to France and got his aortic valve treated with something called ValvoSoft. The ultrasound delivery.
Upstream therapy for moderate aortic stenosis before it becomes severe.
No, these are severe too, yeah.
Other than severe.
Yeah, I'm really glad that Dr. Leonard's not sitting here in the audience because he has a very strong opinion about younger patients and he clearly favors TAVR. I am not so sure that we have good reasons to do this. And I think the case that we saw, was it today, the 67-year-old with high risk. As I said, we cannot compare the age group that we treated 10, 15 years ago with high or extreme risk elderly patient with a younger patient population, maybe with even more bicuspid anatomies, and say, well, we have good results in that age group, so we can justify treatment in younger patients. I think, very honestly, I'd be very careful. And let us be reminded, surgeons are not our enemies. They are our partners, and I think it is very important that we discuss these questionable cases together with the surgeons. What in individual cases is the best treatment option?
I think that's what I wanted to ask, because in India we have pertinent younger population, we already told. Now at this point of time, we see you very young, and we pray to God that you'll be still more younger and deliver such lectures, helping us to develop some new technologies to solve all these problems. So thank you, Dr. Grube. Big round of applause to Grube. And then now we have interesting lecture by Sushil, because now we are moving to the era where we are doing TAVR for aortic regurgitation. So he'll be delivering a talk on what is the status of this in aortic regurgitation. Over to you, Sushil.
Thank you so much. So, I want to start with a case. And again, we talked about young patients. In the US, we have a lot of older patients. So it's an 89-year-old gentleman with a lot of comorbidities, diabetes, hypertension, CKD with the creatinine in the 3 to 4 plus range, EGFR 15. That's his major comorbidity. He has mildly reduced LV function due to non-ischemic cardiomyopathy, and he had known moderate AR with a dilated root, but he had several recent admissions to the hospital, and his EF had dropped, his LV had dilated, and he had severe AR and mild to moderate MR. Because of his renal function, his creatinine, again, his GFR was 15, we couldn't do a CTA. We got a non-con CT. And, I always emphasize this, there is value in a non-con CT. So we get a gated non-con. And what you see here is, you get it gated so you don't have a lot of cardiac motion, but we don't see calcium. And so we're trying to understand calcium. We're trying to understand that you can understand the root geometry. You can see how big the sinuses are. You can see the ascending aorta. You can see the left main. You can see calcium patterns, bicuspid, tricuspid, all without doing a CTA. You can't size it, but you can get the rest of the information that you need. And so he had a TEE, and you see some prolapse of a leaflet, and on color you see, severe AR, and it's the entire length. Sorry. Again, another view, and you see that one cusp is really sort of degenerated, and you're getting severe AR. We do a lot of TEE measurements, the same thing you do on CTA, you can do on TEE. And you see here, you can get a mitral valve, aortic valve annulus area. Using the mitral package, it comes to 528 area. Same as on CT, and we've done studies and we've matched it, and this correlates very well to the CTA measurement. So we have an annual area based of 530 based on the 3D TE, which is comparable to what we see on CTA. So we've given zero contrast. And these are the measurements that you see, 528, as I said. So what do we do here? So we don't have a dedicated device. This is before we had JenaValve approved. This was about a couple years ago. We have no calcium. And so in AR, there's a lot of challenges. There's anatomic challenges. Oftentimes these annuli are quite big because the annulus is dilated. That's the mechanism of AR. You also concomitant disease with ascending aortic, and you don't have calcium, and you can't anchor some of these devices. And from a procedure standpoint, your fluoroscopic visualization is difficult, especially in a patient like this with severe renal dysfunction where you can't give a lot of contrast. How do you size it? And so when you don't have AR, the real challenge is how does the valve anchor? When you don't have calcium, how does the valve anchor? And the risk for migration embolization is quite high as well. And so, but it doesn't mean it can't be done. And these were a lot of early case reports. People used TAVI off-label in these patients with aortic regurgitation. But this is probably the most robust registry, the Pantheon registry, looking at the use of approved TAVI devices, self-expanding or balloon expandable in severe AR without AS. It was 201 patients. The technical success was around 84%. But what you see here is a 12.4% incidence of valve embolization or migration. There's no difference in balloon expandable or sapien in this. And again, this is obviously a registry and all the caveats of a registry. But that 12% of migration is quite significant. In this patient, the bailout from migration is typically surgery, because oftentimes these migrate into the LV and they don't anchor, especially balloon expandable. So it's not trivial. And so when we look at these patients, again, if you have a patient with severe AR, the only reason to do an off-label transcatheter valve is if they're very high risk, right? If this patient is low risk, intermediate risk, they should just have surgery. the procedural rates and events are not great with these patients. So you need to understand that. So you can do the MyValve, Sapien, Evolut, all of the different valves, but there are real issues. But there are several dedicated systems, and now in the U.S., the EnaValve, which we're going to talk about later today, is an approved device, and the J-Valve is also in clinical trials right now. So, I think we talked about this already. So let's talk a little bit about the dedicated devices, because I think they will be here. And there are other devices out of China, and I'm sure there'll be devices from India as well that will look at this. And these are the two. There are other ones that are out there, but they're just earlier on. So I'm just going to focus on the EnaValve and the J-Valve. So the EnaValve, I would think of it as a paper clip. It has a frame that basically clips onto the leaflets. And I don't know if I can. There's no pointer here, but the top left, as you unsheath the initial component, you see the bottom left fluoroscopy. What happens is these feelers come out. You can rotate those feelers, these anchors, and you rotate, and then you advance down so it's in the base of the cusp. And so in that middle panel, you see that we're at the base of the cusp. Here we've looked at it on TE, but it can be done just as a fluoroscopic guided procedure. You rotate and you align and you push these down to the cusp, and then you simply release the valve. And so the inner frame goes to the outer frame, and the leaflets are clipped in between, and it can't go below. And the clinical trial was the Align AR study done in patients who were felt to be high risk. It was not a randomized trial. It was compared to a pre-specified performance goal, and it was a primary safety at 30 days and efficacy at 1 year. And so compared to the primary safety event with the pre-specified safety margin, it met its goal. And the safety events were a composite of mortality, stroke, major bleeding, major vascular complications, AKI, valve intervention, and permanent pacemaker, and moderate AR. So it was a big composite. That's the only way to do it, to reduce the numbers needed to treat. But that was the primary safety, all clinically relevant endpoints. The primary efficacy, again, met its non-inferiority margin, and based on this, the device was approved in the U.S. But we have a much more robust data set. That was just, a couple hundred patients. In the Align AR, and then we continued access, we had over 700 patients. And in this analysis, we had at most 500 at 1 year and 360 at 2 years. So a lot of longer-term data and a more robust data set. And so you look at that primary safety composite, it was similar. It was 24%, really driven by pacemakers. You see there in this analysis, the pacemaker rate was 22%. And I think we've seen this in surgical valves as well. When you do surgery for aortic regurgitation, the pacemaker rates are higher. Is there calcium? Is it something about the patient anatomy, or is it just the pressure on the membranous septum? Maybe the thing. But major life-threatening bleeding, 2.7%. The surgery related to the device was 3%. But it's important to understand that this was the first trial, and there's a lot of learning that goes on the trial. So if you start looking at tertiles, right, as you gain more experience, patient selection, procedural refinement, things start to get better. So if you look at that third tertile, you look at events such as vascular, less than 2%, bleeding, less than 2%, pacemaker rates now down to 16%. And the primary composite went from 28% in the first tertile to 17%. So with experience and patient selection and things, the outcomes are getting better. So when you look at that first cohort, it's really an early experience and early analysis. And this valve has excellent hemodynamics. The mean gradients you see here were less than 5 at 1 and 2 years. The valve areas were around 2.8, very large. The majority, 85%, non-trace. The rest of it was really mild. So the procedural results are good, and they seem stable, at least at early follow-up out to 2 years. Now, the other device is the J-valve. Again, it's not yet approved in the U.S. It's a slightly different concept. It has these 3 U-rings, so you don't rotate, which these 3 rings are attached to the frame, but they're not part of the frame. They're attached by suture, so they're separate components. So on that left, as you unsheath, the rings come out. You just advance them straight down. Because they're shaped like a U, they sort of rotate and they'll get to the base of the cusp. And then you verify you're at the base of the cusp, and then you simply, it's a short self-expanding. You in the middle panel, you see, you rotate and the 2 catheters separate. And so then The rings are on the outside, the valve is on the inside, same concept, it anchors onto the leaflets. And you see here, again, a very good result. This is early on. The EFS was only 25 patients. The initial experience was good. There's obviously some events, early learning, but the pivotal trial is enrolling in the U.S. right now, and hopefully in the next year or two, this trial will complete enrollment, and we'll see what the results are. Maybe we'll get the device approved. There are several other devices that are in EFS that are in first in human. And that will proceed. So we are going to have more devices because the issue is AR is an entity that we need to be able to address. But let's go back to our patient. This was a couple of years ago. He was not a candidate for the Yena-valve study, even though we're enrolling because his renal function, his creatinine, exclude him for the study. And so we initially said there's not options. He kept getting readmitted. He was a pretty robust, he's 89, but he lived independently and robust. So we had a risk-benefit conversation with him about going ahead or not. And the surgeon said if it embolized, we would try to pull it back in the aorta, but he was not a candidate for bailout surgery. Patient understood, we understood. We had a lot of conversations with the son as well and elected to go forward. So one thing I do want to say, we need to really minimize contrast. This aortogram done here is with 5 cc's of contrast. You can do very low dose TAVI. You can do almost zero. We could have put position on TE alone, but we had some concerns, so we did 5 cc's. The way you do this is, and we do all these patients with renal dysfunction asleep. So this patient was intubated. You do a breath hold. You do rapid pacing, because then you can do DSA because you don't have lung motion. So you can do a breath, and your aorta is stable. So you do breath hold, rapid pacing, and a DSA shot, and you can do less than 5 cc's, and you can see the outline very well. We got our initial view by putting a wire in the different cusps, outlining the cusp with the soft J wire and a pigtail in the right. And so you can do a lot before you even inject contrast. So I would say that all these patients that you're doing with creatinine of 2.5 and 3, do techniques to really minimize. You can do things like this and really do with almost no contrast. So we had our view. We knew based on the pacer where we wanted to anchor. We had the TE. So we deployed with no contrast. And we oversized. So this was an annulus of 528. We put a 29. And I watched until I saw a waist. And what you can see here is there is a waist on one side, but you have to oversize in these patients. And you can see here on deployment as well, we're looking on echo, and you can see how you can see the position really well, especially as the valve starts to expand. You see the frame, you can position entirely on TE. When you're doing off-label sapien or even evolute, you're going to deploy low. You start roughly 50-50 because you're going to need to anchor in the LVOT. You need more components of friction. If you try to go for a zero implant, you're going to embolize. You're going to accept a pacemaker rate. There are trade-offs, but you want to deploy low. And you can see here in that top left image, we're roughly 50-50 as we start to go up because we want to anchor more. And again, oversized here in this patient. And this is the final result. It anchored well, looked really quite good. It is a low implant, as you see, but again, no leak in this patient. And we got away with it. His EF was 40-45%, and he somehow did not end up with a pacemaker. So, TAVI can be done in AR, but there are real risks of valve embolization, and it really should be done in someone that's not a surgical candidate at all. You got to really go with caution. The only bailout is surgery or saying that there's no option for this patient. You got to be really different about the procedure. You're going to position low. You're going to do things that are different than you normally do in aortic stenosis. But I think these dedicated systems, Yena, we've done 100 plus now. We've only had one major event. That device works really quite well. We've done it in really sick people. So these dedicated devices are really going to change the landscape. So hopefully we'll have access to those soon. So I'll stop there and maybe we can have a couple minutes discussion. Thank you.
Thank you, Sushil, for sharing your thoughts about aortic leakage. Initially, we used to think that CHB rates are higher with these devices. Now they are under control. Complete out blocks after the procedure?
Yeah, and I think there's a component of anatomy because I think there's less fibrosis. I'm not quite sure. But when you look at the surgical literature, The pacemaker rates after surgical AVR are higher than after AS. So there is a component that is separate. I think the pacemaker rates, the best we can hope for, in my opinion, is in that 10% range, maybe, but if we can with refinements, but we'll see. But I think that's a trade-off. Again, I don't think,
Yeah. What type of AR lesions are not suitable for these valves?
Bicuspid valves, I think, is the one thing. Right now, these devices haven't been tested in bicuspid valves. So I think it comes and goes. So they haven't been tested in bicuspid valves, so we don't have but the way that they anchor, they're not with the 3 feelers. We've done some bicuspids, but you really have to be cautious with it.
And how about aortic aneurysms, ascending aortic size?
In the trial, it was an exclusion of around 5 centimeters. And so you risk aortic injury, like if you push an evolute across, but you go with a long sheath that I think is, if you're careful, you can manage aneurysms.
Freestyle?
I'm sorry?
Freestyle
valves. It's an interesting question. We have not done it in the trials. I know in J-valve they've done some, and there have been challenges and issues. These freestyle routes, I don't think it's the valve itself. I think it's the aortic attachment. Oftentimes when these freestyles, where they sew in at the ascending aorta, there may be a kink, and some of these, they interact with that, and that has led to problems. So I would proceed with real caution in freestyles. I actually think sapien valves work really well in freestyles. We actually published our series. We've done a bunch of freestyle and other routes because that sewing ring, I think, provides anchoring.
If you remember, 2 years back, Marty and you were sitting this side. One Italian operator did same sapien 30% oversizing, a case of severe AR, and procedure went well.
Yep. Question from the audience, please.
First, I want to congratulate Dr. Srinivas to have brought it, all of you, the experts in the field, for exposure to our young cardiologists and our senior cardiologists also, the latest technology. Now, my query is too small. Is there, like we have got Mitra clip and we have got tricuspid clips now, is there any innovation or something, studies going on for a non-surgical repair of aortic valve? Is there any, something on the spectrum?
So there is a device called, I think it's Cusper, where they clip, in AR, they clip a spacer onto one of the leaflets. The idea would be a coaptation surface. I don't know how far along. There's a lot of challenges. It would be very anatomic dependent. For example, if there was a history of endocarditis and the leaflet was torn, it wouldn't work. So I think there are real challenges with those type of technologies. It's not a true repair.
But they're still in the pipeline.
They're still in the pipeline, but nothing that's really further along. I think the anatomies of aortic regurgitation are great. The surgical repairs are really, bringing the annulus in, the root, things like that. So I don't know that we'll have a good repair.
Is there some concept or something in pipeline about robotic repair of the aortic valve by the surgeons, not by the cardiologist?
Yeah, I think
it's
definitely been done. Yes, absolutely. The surgeon,
is something happening?
Yeah, our surgeons do. We have a robust robotic cardiac surgery program. They do repair. I think they do the repairs primarily in younger patients because and I think it's a very technical procedure. So when you look at data, like if you look at Tyrone David, when you look at those stuff, the data looks very good. Right? Because it's someone that's done thousands of cases. The challenge is, I think the reliability of a repair across people that don't do a lot, I think the outcomes may be quite variable. But there isn't anything else that I know of.
Is there any data in India by the robotic repair or surgical repair aortic valve?
I'll have to ask Srinivas. He's asking the question.
Srinivas, is there any Indian data or Indian experiment with the surgical robotic repair of the aortic valve?
Anyone doing robotic surgery?
Yeah. The surgeons are actively trying, but they've not gone to the stage of repair with only robotics. They're quite comfortable with open repair. Pericardial also they're doing it.
So if anybody is interested, come to our center. We are the first in the world to do robotic aortic valve replacements and published a lot of data.
He's asking repair.
Repair as well. So Dr. Vinay Badwar is the STS president currently. Dr. Gokhale from Apollo had come and he had observed preserved for about a week or two at our center as well. So please, I hope
that is a good information. Thank you.
Thank you, sir. I think now we'll go to another new type of valve.
Oh, one more last question. Sorry.
Yeah.
What is the percentage of oversizing for non-dedicated AR devices you do?
So there is no direct number. I like to oversize at least 20%. But if you're doing a balloon expandable in pure AR. Okay, so I think we're going to go on to the next speaker. Yeah.
I think another new type now, many of you know that these valves need to be prepared in the lab and then donate. Now, another advancement which is happening is dry tissue valves where you take directly and you can take it and implant it without wastage of time in the lab. And it's also supposed to have advantages of leaflet preservation and lasting longer. One that dry tissue valve is one of the Indian company, Relisys, is doing it. I think Ramesh has done one live in a box case. So requested him to show that, and he'll show that live in a box recording of the new type of valve. Over to you, Ramesh.
Yeah, thank you very much. So we do about 250 towers at our center, and we probably do about nearly 70 to 80 balloon valvuloplasties in a year. That is because we are not able to accommodate them in a timely fashion for a tower. So what is the fear? The fear is always that, you create a severe AI and what happens suddenly when there's nobody to crimp the valve or if you don't have enough staff trained for it. So things like that, and always you don't have a valve that you can take off from the shelf and use it. So I'm actually very surprised that we do not have that type of valves in the US, but there's one in India. So I'll show you this presentation, and then I'll stop whenever you need me to stop and take any questions. Okay. So this was just done recently. A 70-year-old patient with BSA of 1.48, a previous SAVR and 19 millimeter St. Jude epic valve and post-cabbage vein graft to RCA in April 2023. So dyspnea on exertion vein mean gradient is 50. And, coronary CT angiogram showed some coronary artery disease, moderate disease. And ECG is, I'll show it to you as well, narrow QRS. So here's the gradients of 51 millimeters of mercury and narrow QRS. Thanks to Dr. Raja Ramesh for making these slides for us as well. And as you can see here that LVOT is 21, annulus is perimeter derived diameter is 20.8, and coronary heights are 15 and 17 on the right and left. Okay. And so this is actually, epic valves are very difficult to visualize on fluoro, which you will see in the future as well. So everything looked okay, but this is the internal diameter, and we'll talk about that for the coronary heights here, 15 and 17. And the root angle is okay, it's about 52. And here the vessel sizes look okay. So this is a valve, is Vienna valve. The sheath size is about 20 and a half French. So outer diameter is actually 22 to 23 French. And always is a concern about what the vessel size. A couple months ago, one of the cases I did in Bangalore was actually 4.3 millimeter femorals, and actually the vascular surgeon, we asked him to do an ileal conduit. He said, don't worry, Ramesh, I'll be right next to you. If anything happens, I'll save the patient. So he didn't agree to do an ileal conduit. He said that is a much complicated surgery. You go ahead. And I said, okay, there's no calcium, and we probably will be able to stretch the vessels, but be careful for dissections, perforations, and all of that. And so I used the Centrent sheath. Yesterday evening we were talking about if you have any difficulty, the Centrent sheath from Medtronic is beautiful, very hydrophilic, very smooth, and I think equivalent to probably Go dry seal, but much better than in my opinion. So we used Centrent dry seal sheath 14 French and then crossed everything and went with the valve, and without any vascular injury at all. So even though this is fearful for us to think, it has actually been very good. So here the epic valve, 19 millimeters internal diameter, true ID is 17. It is fracturable, and if you use a fracture, you might have to think about oversizing. But even the valve size here with 17 IDE, I will not go to 26. It'll still be 23 millimeter self-expandable valves. And so the plan was a right femoral artery, TAVI, Lunderquist or a Safari wire, and you see both those wires were used, and temporary pacemaker, valve fracture, if required with 20 millimeter balloon is what we thought. Initially, we thought we'll try to see if we have to do post after valve is deployed. So the two ways of doing a balloon valve fracture, either before or after the valve deployment. I like to do before just because I don't want to the freshly placed valve leaflets to be exposed to that much of pressure, and that's my argument against post. So this is 1 minute. So we went through this, and so the valve was crossed with AL1 and straight glide wire, and so we had placed a
Just making sure
18-inch sheath
in position, and so flushed.
So now in the picture is showing how to prep this preparation is something that is so simple that even you and I can do it. All you have to do is 3 flushes from distal to proximal, and and now then just making sure.
So that's pretty much it for the valve preparation.
It takes hardly like a minute, and so that flushing the one.
And one more side port for the inline sheath flush. So just start from distal to proximal, distal flush, and then the delivery system flush and the inline sheath flush. So that's ready. So now we'll go with the balloon.
Once the,
as we said, it's very difficult to see the balloon.
The valve.
And so zoom up.
Take one cine.
And so even then with the zoom up, we couldn't see the valve at all. And so we are trying to fracture the valve first.
The mid-marker is at the...
So unfortunately, it did not fracture.
Okay, fluoro and pacer on.
Pacer on.
Okay, we're going to inflate.
And we are doing this under
and
conscious
you can
sedation.
see that
the waist is seen. And then I should have had a different indiflator and probably an open. It didn't. Okay.
Okay.
So
pacer off.
And the patient was getting restless, and as we are doing it under conscious sedation.
Walk back. Okay, 1 minute. Hold on. I got it.
So then exchange that for the valve vena system.
Okay. Now we can advance this one a little bit.
So sometimes you might have to use an 18-inch
small puff a little bit.
So which we did, and the valve was not going easily. So at this point, after we crossed, we exchanged the wire, horizontal aorta. We exchanged the wire for Safari wire. It actually helped us to get the valve easily into the aorta. Crossing the valve, epic valve, was very difficult.
Let's wait until we flare up a little bit.
And you have today
now right there in that position. Okay, off fluoro. Save it. On fluoro. Small puff. Okay, I like that. Off fluoro. Save it. Pace at 120. I'm looking for the blood pressure to come down. Go to 140.
It's diving in deep, so now I pull back a little
small
bit.
Puff.
It's still about 6 millimeters, so I'm still pulling back, and you can see the valve is moving to the inner curvature. You don't want to do...
Cine and inject. Okay, good. Okay, go to LAO.
Look at the size of the ascending aortic root. Size.
Come. Karthik, sir. Kunchu, just here. Okay. Okay. Zoom up. Inka zoom in. Kunchu LAO kalan.
This is new X-ray system from...
okay, good. Stop. Okay.
Cine. Japan.
Push it in.
So the valve was deployed, and I think we missed that. But anyway, the gradient was still about 12 to 14, so we post-dilated further.
Save it.
Zoom out.
pigtail.
I have the best. Give me a gradient.
So exchange the Safari for pigtail for gradient measurement and the gradients were, I'll see if I can. Okay. Or 9 millimeters on the.
We'll flush everything again.
And 9 millimeters on echo, and same about 6 millimeters.
So, as you know, this is a very complex valve-in-valve procedure that we have done. We did a BAV with a 20 millimeter balloon and tried to fracture it, but we were not able to. We were just able to stretch it, and then we went with a 23 millimeter Vienna valve. Horizontal aorta, but we were able to cross it over a Safari wire easily, and then we deployed it at about 4 millimeter depth, and so then we had a gradient of by echo about 12 millimeters, and by invasive there was a mean peak to peak about a 30 millimeter gradient. So hence we did a BAV again with the same 20 millimeter balloon, with which actually the gradient has significantly come down. On invasive, there is only about 8 millimeter peak-to-peak gradient, and non-invasive, we are measuring it probably it will be about 4 or 5 millimeter gradient. So there is no pericardial effusion. Patient tolerated the procedure quite well with the help of our anesthesiologist, and we have the 7 French sheath is placed, and we'll take a 18 French sheath out from the right groin, and we'll use a perclose again. If need be, we'll put a second perclose after that. We'll show you that just in a couple of minutes.
Yeah, so I skipped that.
So the mean gradient on by non-invasive by echo is 9 millimeters, and so with that, actually, we can conclude.
So this is 2 percloses we applied, and you can see a little bit of pinching in the femoral artery. So this is because it's a larger delivery system. We use 2. Usually if it is 14 up to even 18 now in the United States, now my practice is 1 perclose and manual pressure, give protabid and manual pressure so that you don't see this sort of narrowing of the femoral artery at the site of the percloses.
So this valve.
So I think... So as you can see, that is the pinching there, right there. Okay. And any questions?
Whether it is as it is a valve-in-valve, we have a doubt of the existence of the patient process mismatch and the coronary obstruction. I think with the meticulous planning, we are able to do successfully and attain a single-digit gradient in this small aortic annulus.
And that too with the 23 Vienna valve, which is a larger valve, but we didn't have any vascular injury or anything, and our depth was about 4 millimeters below the valve, and there's a narrow QRS.
Yeah, I'll stop here. Narrow QRS and did not need a pacemaker. Thank you.
Thank you. Any comments?
No, I think it's intriguing. I mean, there's all these valves coming. How many do you keep on the shelf? Procedural techniques are difficult. I mean, and this is unique in that the dry storage and the ability to prep quickly. I think these valves are going to add features. The question is, what does it mean for durability and all these things? That's where we need the longer term data, right? Even like Siegel, I think the Mirus valve, it's dry porcine pericardium. I think there's advantages. The question, what that means in terms of long-term durability, I think but this is unique. And I mean, I think we'll have to see where these go. And
I mean, at least in my practice, our practice, Raja Ramesh is also here. We've been using this only in people who have been either surgical turndowns or extremely high risk for surgery. And so those are the patients, because it is supraannular design. And as you said that, what is the durability? We have to still wait and watch and get more data on this.
Thank you, Ramesh. I think that mild pinching, what you see generally, even if it is a little more, also you take a balloon and do low pressure inflations, it settles. You need not be worried so much, but we have to check always. That's mandatory before you close. And thank you again. We congratulate our Indian company getting one more valve. But my interest is we want the valves to be more cheaper. And rather than having some minor advantage with extra cost, the routine stuff with let's say cheaper valve is what we want as the clinicians. We hope it will happen.
And this is from Hyderabad.
Yes. Another major thing which is we are all eagerly looking and waiting forward is we were looking for a good tricuspid valve solutions, and we wanted to learn where is this therapy going? And we thought we would request Eberhard Grube, who's with us, actually to share his ideas and thoughts about what is happening in the tricuspid valve front. So with this, I request Dr. Grube to deliver his talk on tricuspid valve, where are we now, and what are the newer therapy options. It's a very innovative talk, and we would like you to deliver. Thank you, sir.
Can you? Yeah, thank you very much, Srinivas. And my understanding is that, tricuspid is just beginning, the interest in the tricuspid valve is just beginning here. In Europe and in the United States, we have been dealing with the tricuspid valve for quite some time. And what I mean with tricuspid valve therapy at the crossroads, I mean, when two streets are crossing, the question is, which direction do you go? And that's what I mean with crossroads. And I will point that out as we move forward. My disclosure again. So this is an outline of my presentation. The road that we took talking about tricuspid valve. TR, the learning is, over the years, we should care. The arrival of the first devices, and then the arrival of the first data. The road ahead, those are the crossroad moments. Those are the moments that we have to decide which way to go. Is it both ways, either or? Something that we need to discuss. The prospect of impacting on hard endpoints, very important, and the promise of TR abolition. And as you all know, one of the most prominent publishers and doers in tricuspid is sitting right here, Sushil Kodali. So why should we care? The historical narrative was TR is secondary to left-sided disease. Treat the left side, leave the right side alone, and it will follow to get better. That's what we have been doing, and that's what our reasoning was, not to do anything. But new data taught us TR is relevant, shown on the left side, and highly prevalent on the right side. Increasing TR is associated with worse survival, and severe TR is more prevalent or as prevalent as severe AS, warranting similar attention. TR is relevant independent of systolic pulmonary pressure and independent of left ventricular ejection fraction, as shown here on those two slides. TR is prevalent and might even show the highest prevalence of the relevant VHDs, especially more than 75 years, according to broad community-based data, the Preview Valve study, as shown here. Something that we simply cannot ignore in the population that probably will be more in focus in the years to come. TR is prevalent and is the main pathology in the very age group, 80 to 85, that is projected to grow by 74% until 2050, increasing the American VHD population by 4 million, also shown on this slide. The recent state of care, TR historically remained vastly undertreated. Looking at the US population, 1.6 million patients with moderate to severe TR, 250,000 new cases per year. But less than 8,000 TR surgeries have been performed per year. So clearly, vastly undertreated. This undertreatment has been due to lacking awareness, but also due to the fact that surgery as only treatment option, also in recent practice, was associated with high rates of peri and post-procedural mortality around 10 to 15%. Recognition of the prognostic significance and scarce therapeutic options in elderly high-risk TR patients represented a substantial unmet clinical need. Novel, minimally invasive transcatheter devices aimed to fill this gap. Arrival of first devices to treat. A summary here: direct suture annuloplasty, direct ring annuloplasty, coaptation enhancement, and valve replacements. Arrival of the first devices, the initial steps. Out-of-the-box approaches and mimics of surgical predicates were early pioneers. TriClinch and TriAlign, the very early trial and early devices that try to treat tricuspid regurgitation. Then M-tier transitioned to T-tier. Adoption of the well-established M-tier technology to the right side moved the field tremendously forward. Off-label use of the mitral clip on the tricuspid valve, according to the early TriValve registry experience, proved effective in reducing TR and improving NIHA class, as shown here on the left and on the right side. This encouraging first experience led to the development of a dedicated TriClip T-tier system, enhancing maneuverability and effectiveness. And as Sushil pointed out yesterday, there are tremendous differences between the M-tier and the T-tier devices. So, arrival of the first data with T-tier, the Triluminate study, as first randomized single-arm study with 85 patients, could establish stable TR reduction and significant NIHA class improvement at 1 year, as showing here on the two graphs. The Triluminate pivotal trial, as first randomized trial, 350 patients of T-tier versus GDMT, could show significant benefit of continued TR reduction, mainly driven by quality of life benefits at 1 year. The Triluminate pivotal trial could furthermore prove that T-tier is very safe, with 98.3% freedom from MAEs at 30 days. If you look at secondary endpoint analysis, freedom from MAEs at 30 days, 98.3% in the device group. The TriFR randomized clinical trial allocated 300 patients to TIER or GDMT and similarly could show good TR reduction and a reduced composite driven by quality of life improvements, shown on the right side. TriScent 1, now arrival of the first data with TTVR, replacement, here the EVOC, TriScent 1, a bit later to the party, but with even bigger effect on TR, TTVR, using the EVOC at 1 year, showed dramatic TR reduction, as well correlating with quality of life benefits. You can see here in the TriScent 1 study, 98% less than mild TR, clearly a very effective reduction of TR. TriScent 2, as first randomized trial of TTVR versus GMT 2-to-1, at 1 year could also show almost complete abolition of TR in the TTVR group, accompanied by, again, quality of life improvements. TR reduction on the left, highly significant, and quality of life improvement on the right side, 95% less than mild tricuspid regurgitation. TriScent 2 again, however, again, no relevant benefit in terms of survival or heart failure hospitalization. And for TTVR, a safety signal emerged, given 50% bleeding and 17% new pacemakers, looking at mortality, heart failure hospitalization, and adverse events. So clearly something that emerged with TriScent 2. So the road we took, TR, the learning we should care. TR is highly clinically relevant and very prevalent. The arrival of first devices, a variety of devices have come up to address the unmet clinical need with T-tier and TTVR solutions leading the field. The arrival of first data shows effective TR reduction and improved quality of life. The crossroads moments of TR therapy, and that is something that we have to decide which way to go. only quality of life benefits or hard clinical endpoints, something that we have to decide, and TR abolition or safety. Those are the crossroad moments on TR therapy. So crossroads of TR therapy, quality of life versus hard endpoints. Quality of life versus hard endpoints, a triluminate pivotal trial. At 2 years, TR reduction in the T-tier group proved stable, no question. And now at 2 years, a significant reduction of heart failure hospitalization was observed, shown here again. The TRIFR randomized clinical trial discussed at the ACC 26, also in the TRIFR now at 2 years in the T-tier group, a significant reduction of heart failure hospitalization was observed. 44% reduction of composite endpoints. T-tier induced around 50% reduction of heart failure hospitalizations at 2 years. Clearly, the field moved forward. Trident, also in Trident, now at 2 years in the TTVR group, albeit limited by crossover design, a signal of significant reduced mortality emerged. A signal emerged. Composite mortality, heart failure hospitalization left, and heart failure hospitalizations on the right. Crossroads, initial data suggested it could be quality or life benefits or hard clinical endpoint, but recent data seem to suggest quality of life benefits and hard clinical endpoints are possible. The continued follow-up of large randomized T-tier and TTVR trials, albeit in parts limited by crossover, now seems to prove the clinical hypothesis that significant reduction of TR will break the vicious heart failure cycle of right-sided volume overload, marking a crucial moment in the development of TR therapy. Longer follow-up will have to prove whether TR reduction is stable, whether the devices, especially TTVR bioprosthetic leaflets, are durable, and whether this results in continuously improved clinical outcomes. Crossroads on TR therapy, promise of TR abolition. Clearly, consistent data, less TR post-procedure means I don't see anything here anymore, so yeah.
Something's going on with the screens up here. Can you change it?
Something is going on, yeah.
We're not seeing it up here.
Yeah, I know you do, but I don't. I mean, I don't hear. It's a great screen. The screen doesn't like me.
These screens are. Here, you can turn around and look at that if you want. That easier.
Yeah, that's actually a good idea, Sushil, as always. The promise of TR abolition, TR after T-tier, a relevant portion of patients, about 10 to 20% after T-tier, still has relevant tricuspid regurgitation. Looking at the triluminate pivotal, at the BRIGHT registry, and the PACE registry, something that we have to recognize. So the promise of TR abolition, predictors of residual TR following T-tier, really is unpredictable. As you can see here, a summary of maybe finding some predictor of how much TR you will have after the T-tier procedure. Even though individual analyses may seem to identify certain predictors of successful TR reduction, high variability of these findings is obvious, questioning reliability and generalizability. The promise of TR abolition, clearly transcatheter tricuspid valve replacements come into the game, as we have seen before. The valve, perfect, thank you. Thank you. The transcatheter valve therapy replacement clearly abolishes tricuspid regurgitation, but at what price? So in contrast to T-tier, TTVR shows consistent near elimination of tricuspid regurgitation, as shown on the right side. As I said, 95% less than mild TR. The promise of TR abolition, TTR versus TTVR durability, clearly you all know this. This is anatomic suitability for TTR versus TTVI center experience. The more complex and the more complicated, even not doable for TTR, then the replacement comes into the game. But it is not just anatomy and imaging. Doability of TTVR also means, can the patient tolerate lifelong oral anticoagulation? Is the patient frail at HBR or preferring the less invasive, less risky approach, meaning TTR? Crossroads of TR therapy, TR abolition must not be TR abolition versus safety. Much rather, we need to think TR abolition plus safety. The availability of two systems able to achieve impactful outcome-relevant TR reduction brings the responsibility to the heart team to balance achievable TR reduction, procedural safety, individual patient needs versus safety to undergo oral anticoagulation, pacemaker risk, and of course, durability. The promising path ahead with these crossroad decisions. TR has entered the center stage of the interventional arena and will also be in your country. We have understood that TR has a dramatic clinical impact and it is highly prevalent. The gap of undertreatment has sparked rapid evolution of transcatheter devices. Initial data showed effectiveness and improved quality of life post-procedure. Now, defining moments in the development of TR therapies arose. For the first time, consistent data using different treatment approaches proves an impact of significant TR reduction on heart clinical endpoints. In parallel, TTVR replacement as a treatment option enabling near abolition of TR has been established, albeit some safety concerns remain in comparison to TTR. Given the promise lying in transcatheter TR therapies, heart teams are now facing the obligation to carefully select the adequate treatment modality for each individual patient, balancing chances to effectively reduce TR versus procedural risks. With that, again, I'd like to thank you for your kind attention.
Thank you, Dr. Grube, for sharing all your new thoughts on the upcoming trend. In India, we do see a lot of tricuspid valve disease. It's more relevant, but probably our patients are younger. Sushil, you are part of many trials of tricuspid valve. Would like to comment anything?
Yeah, I mean, I guess the challenge I think you highlighted well is, the doability aspect. And in India, I think there's a lot of rheumatic-based tricuspid valve disease where TEER may not be, a good option because the leaflets themselves may become more leathery. And, although we don't get tricuspid stenosis typically with TEER, I think in rheumatic patients, that's something to be concerned about. And so replacement and the potential of replacement is, there are several technologies coming down the road where it will be a fluoroscopically driven procedure. And then that doability changes quite a bit, and maybe the safety as well. And so here where the centers are options are limited, the experience is limited. And one of the things that we've struggled with both TEER and EVOQUE is the imaging requirements are so heavy sometimes. And to have not just the trained interventionalist, but the trained imager that's able to do that, I think that's where the challenge is in India. And so I think it will be limited to some centers for the time being, but I think these technologies have to evolve to be more simplified. Because I think you highlighted, well, it is a problem. We have to find solutions. But how do we find solutions for this geography where it might be different variability? In the U.S., we see a lot of atrial fibrillated, ischemic, LV dysfunction related TR. Here, it's a little bit different. And so I don't know if you want to comment on
Yeah,
that.
well, I obviously can't suggest any solution for India, but I know most importantly, and that's why I believe that Srinivas wanted me to talk about it, it's the awareness of tricuspid. It is not a forgotten valve. It is something that is more prevalent than we think. It is more important, and you can simply not say, well, let's treat the left side and the right side will be okay. So that's very clear. The other problem that we're facing, at least in my, and now I'm speculating a little bit, I don't know whether you guys agree with that, but now, because we really don't have a very good mean to treat, let alone M-tier for the time being. We really don't have good procedures to repair the mitral valve. And remember, we are not circulating in our own world. We are still having our surgeons who do, if they are experienced, excellent repair. So M-tier is important, but now because M-tier is kind of an exhausted field on the left side, now we all focus on the right side. And now we have, I think, 20 tricuspid valves and various repair devices and in the pipeline. Now we're focusing on the tricuspid. With repair versus replacement. I still believe, regardless of left or right side, a repair is still better than replacement. Replacement means a new artificial heart valve, period, with all the consequences. We have to realize, even though T-tier as well as M-tier is easy to do, no, I'm sorry, it's not easy. It's very safe. It depends on your own I should say, bar that you establish on how the patient should leave. And you cannot take Cybal. Cybal clearly is the king of M-tier. But many centers in the United States particularly don't have that much experience. And the patients are leaving the cath lab with still MR more than 2, or even TR 15% or even more with significant tricuspid regurgitation. This is not what we need and what we want. That's why I clearly focus on hard endpoints rather than quality of life. And I think that's an important message, and I hope I brought that across.
Now that innovative people like you are concentrating on it, I'm very confident that solution will come to it. And then we're already slightly behind. I know all of you are waiting for interventional pharmacological therapy session 2, but I request you to bear with us for another 10 minutes because Dr. Sanjog has to leave and catch an early flight. We didn't want to lose his talk. There's another new innovative concept coming up is an hybrid PCI, where you have a combination of drug-eluting stent and drug-eluting balloons. So I requested him, I know he is an excellent speaker, that rather than losing his talk, I requested him to deliver his talk and go. So I request Dr. Sanjog to deliver his talk. Thank you, Sanjog, for accommodating, and please, we'll sit together later.
Someone who doesn't distract.
Can you get Dr. Sanjog talk slides?
Good morning, everybody. I imagine I'm probably the only person that's standing between you and lunch, so I'll try to make this clean and quick. This is about hybrid PCI. This is a concept that I think you're all familiar with, but probably needs a degree of definition and systematic structure so that we can start to study the concept and move forward with what we do every time, just as you heard from Dr. Grube, initial experiences into expertise. So scaffold what must be scaffolded, but treat what must not. These are my disclosures. Consider a case, right? We always start with a case, something interesting. Hey, Girish, I didn't see you were there. It's good to see you, my friend. Nice case yesterday. So 54-year-old guy, ischemic cardiomyopathy, acute exacerbation of heart failure, CCS class 2 angina despite medical therapy, bad EF, surgical turn down, and we've been asked to fix everything. So that included the LAD, the RCA, but we're going to focus here on this CIRC, obtuse marginal branch bifurcation. The CIRC, I should say CIRC OM2, that big guy up there bifurcating is a ramus. So we're dealing with this bifurcation here, okay? And so when we think about managing any sort of a lesion, we ask ourselves, what is the tissue we are trying to treat? And what we've done heretofore is assume that the tissue that we're treating is in fact a continuous lesion. But the truth is, when you look at this LAD, or this circumflex, or this OM, or whatever the vessel is, you have a lot of different mechanical properties within this continuous lesion. So it's anatomically continuous, but it's physiologically and pathologically distinct. And as a result, it makes sense then that we can ask the question around treatment strategy, where if you have a physiologically and pathologically distinct lesion with distinct segments, which millimeters actually need a scaffold? And are there other biologic ways to address other parts of the vessel? So hybrid PCI then needs some definitions, because a lot of people will say, I'm going to go in, prepare a vessel, put a DCB in, and then when it looks like garbage, I'm going to put a stent in. That's not hybrid PCI. That is a failure of an initial strategy, where if you lump with hybrid PCI, you predispose the data that come from your experience to more complex lesion subsets, worse vessels, worse disease, etc., because those are by definition lesions that did not respond to your initial approach. So hybrid PCI can be divided into 4 buckets. Okay, you've got your diffusely diseased tapered vessel, where your goal then is a proximal segment DES and a distal segment DEB. Then you've got spot scaffolding, where disease on either side of a tight lesion can be easily treated with a DCB, and so you need a DES only where the mechanics of your preparatory strategy are failing, where you get acute recoil, where you have a residual stenosis that's more than 30%, etc. You can then have a bifurcation. This has been studied in DCB BIF, where you have a main vessel DES and then side branch DEB. This is the only real randomized evidence that looks at this strategy. And then you have multi-vessel, where you can do a DES in one vessel and then a DCB in another vessel. And what we need to remember then is that hybrid PCI is a planned strategy. It is an acknowledged strategy at the moment of the start of the procedure. So you are dealing with a predictable outcome. If your vessel compliance, if your vesical characteristics are not such that you can plan that strategy, this is no longer hybrid strategy. You're dealing with a bailout scenario. The question is, when do you plan? And that's what we're going to get into in a moment. So planned crossover or accepted crossover is reasonable because it's an extension of the strategy. We heard from Miroslav yesterday around EBC main, and the idea that going from a single stent provisional strategy into a culotte is not a failure of provisional, it's a progression of your strategy because it's a declared potential for crossover. But that is fundamentally different than when you prepare a vessel, it looks like garbage at the end, it acutely shuts down and you're rushing to put in an ill-sized, underexpanded whatever stent to try to rescue a scenario. And so scaffold needs to be used for mechanics. So that's recoil, flow-limiting dissection, high-consequence instability, proximal vasculature where it's going to shut down. Because permanent scaffolding supplies mechanical value, right? It's a fundamentally different concept than anti-proliferative therapy, which happens to come along with the scaffold, but with the added tax of metal. Whereas the anti-proliferative therapy, where a scaffold is not necessary, where the balloon angioplasty preparatory strategy actually produced the result that you're going for, is really all that you're trying to address within the vessel, because those are the biological needs of that segment of plaque, right? So when you do this approach, you deal with a very low rate of late stent related events, right? There is a hazard ratio of about 1.88 when you stent long. Okay, so this is from Grand DES. When we look at overall failure rates, there's a patient level combination of long segment versus short segment stented disease, where when you start stenting long, you get a hazard ratio that's higher for TLF, and you get definite or probable stent thrombosis increases in risk. So this is the purported reasonable rationale of using this approach. But rationale does not equal causal proof. So we do have to approach this with a little bit of reasonable clinical judgment. And generally speaking, whenever you have an unproven concept, you want to have an approach, right? A strategy that you can systematically execute on that is backed by reasonable clinical rationale, that has good devices inherent within it, so you're not dealing with the string ends of both, so that you can then study what comes out at the end. So when we look at the evidence around this strategy, probably the strongest stuff is DCB-BIF, right? Where there was randomization after main branch stenting when the side branch was over 70% stenosed, and some got balloon angioplasty, whereas some got DCB angioplasty. We recognize that these are relatively simple bifurcation lesions, less than 10 millimeters, okay? And it was not it is not to be construed as a two-stent comparison. And what they found was that there was a reduction in events following DCB PCI, but it was driven by periprocedural MI. And so you have to ask yourself whether or not we should have touched the side branch at all if there was reasonable flow, right? So there's still much to be learned here, but this is still some data that show the approach is randomized trial-based. It has been studied. It is safe. It may not be additionally effective, but it is safe at this time. So what other data are there? Right? There's the HYPER registry, which is a prospective multi-center registry. It's not very big, but this shows pretty high procedural success rates with very low device-oriented clinical endpoints of target vessel failure. So it's feasibility data, but it's not a randomized comparator. Then you have a bunch of other studies from East Asia where they do a lot of DCB and imaging-related work where they look at prospective observational groups, where when you look at long stented segments versus shorter stented segments in the Yang group, at 3-year MACE, the MACEs are about equivalent, right? There was a large metal reduction, but that doesn't mean that you've had a clinical endpoint change because your MACE rates are equivalent. What about TO study? This was an all-comer hybrid registry. So this is now getting real world, where there's 400 patients that were involved with a very low 2.2% TLF rate, right? So once again, safe approach. We need to learn more, though, about exactly how we should be using it. And we recognize that this 2.2% TLF rate, which is exceedingly low, was not compared against a DES comparator group. And let's face facts. With intravascular imaging-guided DES PCI with good, modern, 3rd, 4th generation DES, we're getting restenosis rates and TLF rates that are in the same range. And so then you look at Shin's group, which is probably your best real-world group of data. It's multi-vessel PCI, 254 DCB-based lesions, where your 2-year MACE is way, 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 way smaller than with stents. But we recognize that this is hypothesis generating because it's a small group, it's non-randomized, and some of it it's all retrospective and propensity matched. So we have data, but it's not causative data. It's not gold standard data yet, but I'm sure it's going to be coming given the fervor that we all have around the therapies. So what we have to do is recognize that there's a consistent observational message, and so it's a safe thing to do based on what we understand, but the efficacy we still need to be honest about with ourselves. And so this is the sobering message, right? This is rec cage free, where it tells us that a DCB first strategy is not a default strategy, right? Rec cage free told us that in large vessels, DCBs are probably not the right approach today, given the process that they followed. And this process is so important. But this is not an anti-DCB study. This is an anti-indiscriminate DCB study where you run around putting DCBs in everything. That's probably the wrong thing to do because we don't understand how to do it perfectly well yet. And we don't understand exactly the patient groups that are going to benefit and that are going to be harmed. But this is not to suggest that a selected patient upfront hybrid strategy that is declared at the front is the wrong thing to do. Because once again, we have data to show that it's safe. We have data to suggest it may be effective. All we need is a process. So here's the process. This is what hybrid PCI should probably look like in 2026. And let's walk through this for a moment to give you something to anchor your knowledge on. Let's start with mapping. So let's start with our case, right? We have a circ OM2 or OM1 bifurcation, considering that bifurcating branch is a ramus. There's calcification in the circumflex. The patient's unwell. There is real consequence to losing a vessel. It is moderate disease throughout, but it's tight diffuse disease in the OM. So the next thing you do is try to prepare. So we prepared the circumflex, but then when we ballooned the OM, we started to lose, we didn't get appropriate expansion of that balloon, right? As you can see, that's a 2.0 balloon and it's laughing at you despite very high pressures. That probably tells you that you're not going to be able to deliver much. And let me tell you, even getting that balloon there was difficult. So then recognizing this, we went forward to atherectomy and we started to atherectomize that branch because we wanted to own the branch and we wanted to really prepare the plaque. Rotablation was fairly straightforward. It was a 1.5 burr. 1.5 burr went across in a couple of runs. And then we went back to ensure preparation with an appropriately sized cutting balloon. Now you can see that it's expanded. Right now you can see that you're starting to get good preparation throughout the vessel. And we did this throughout the OM. I've just kept the pictures brief in the interest of time. All right, so now a 2.5 millimeter cutting balloon's better expanded, let alone a 225 that was being laughed at. So now we're prepared, and we step back, and now we make our strategy, right? Because we can't do anything unless the vessels are prepared. And we ask ourselves a question: which segment needs a scaffold? So where are the loss risks highest? Where is the likelihood of mechanical recoil highest? So circ, main vessel, calcification, big dissections. Where is the likelihood of acute shutdown highest? And where are you likely to compromise multiple distal branches if you do? So we looked at this then carefully and we said, I think the circumflex should probably be stented. But I think the obtuse marginal branch, which looks very well prepared with no dissections that are greater than type C, with no residual stenosis in it and TIMI3 flow, probably does not need a scaffold. And so then we stepped back and we said, where are we going to put what? We need a DES where we're going to need mechanical stability versus a DEB where we're going to need antiproliferative therapy, biologic therapy for disease that we've relieved. And so when we looked at this again, then we said, well, we're going to DES here and we're going to DCB there. And that's when we chose our strategy, and we chose an Onyx DES, which was going to be able to taper very nicely, given the size differential between where we were dropping that stent, with large side branch holes so that we could get back in. The maximal expandable cell diameter is about 5.5. So it's easy to get through the side cells of that strut. And we chose a Prevail DCB because remember the aforementioned misery with delivery. And this is one of the most deliverable balloons out there with the most experience around deliverability because it's a coronary rapid exchange balloon that was designed as a coronary balloon first. It's got the highest amount of drug of any of the DCBs out there, and so the likelihood of us being able to get antiproliferative into the wall, even if there's some loss on delivery, is also high. We recognize that too much drug is also probably bad, right? Because you can start getting positive remodeling. But that's why we chose a side branch. That's why we chose a bifurcation, because positive remodeling is not going to affect flow. Whereas thrombosis in a main vessel with a large positive remodel section gives you concern, and we're going to stent across it to give it an additional scaffold. So that's what we ended up doing. And when we stented and we DCB'd, we went to step 4, which is a critical step, and that is verify, right? So we did an IVUS of the circumflex. We ensured optimal stent expansion, and these were our final results in this otherwise relatively high-risk patient. But the key was that we declared the strategy and had an approach. And we followed that approach, and we followed that approach consistently, recognizing that this was an upfront strategy that was systematic and that reevaluated our thinking at every stage with careful attention to the detail. That's usually where we lose the flow, right? We lose it at the detail level because we're used to doing wire balloon stent when interventional cardiology is endovascular surgery. We are way, way more complicated than that now. So the procedural process is declare your strategy, prepare your vessels, achieve your less than 30% residual TIMI3 flow, no limiting dissection, deliver your DCB, deliver your stents, join up any untreated gaps. So this is the junction bit, okay, because we don't want untreated vessel. You've traumatized it. And then decide precisely where you're going to need to augment your therapy. And this is following the basics of the junction principle, which is minimize your gaps, but don't use huge overlap because double drug is just as bad. Okay? There's lots of choices, lots of data. You know, we see the data from Solution recently. It's not necessarily available everywhere for us. We went with a balloon that was available to us, and it's because there are good data that support its use. Probably the best worldwide data is from the SCAR registry. That's an all-comer data set that has some fairly favorable numbers and a hazard ratio that's almost a wash versus DES. So coming back, this is not about leave nothing behind. This is about leave nothing unnecessary behind. Use a scaffold for that which needs a scaffold, where the mechanics are what you're treating. Use DCB for the biology, where the plaque alone is what needs to be managed. And move yourself towards where you put a DES in the right space, a DCB where you're going to need wall drug, and side branches where you're going to need to keep them open for a period of time. So with that, I'll stop. I apologize for going over by a few minutes. Thanks very much for your time and attention.
Thank you, Sanjog, for highlighting the concept that DCB cannot replace DEB desk totally, but a combination of it would do good. And because of the running short, we will not take questions. Thank you again for the.
Thanks very much for your time, Rajesh.
And then we request next set of chairpersons of Interventional Pharmacology Symposium. We have none other than Dr. Venkatesh Ram. We apologize for slight delay, sir. And I know others are eagerly looking forward to the lectures coming up. And we have Dr. Shastri, BK Shastri is there. I request Dr. M. Srinivasarao sir to come over to take his place because both have been working same. And then we request Dr. Rakesh Verma sir to come and chair the session. Other these panelists who are available, whoever is there, Raju, Kemke Reddy, Gaurav Agarwal, Jwala Kumar, whoever is there, Sushant, and please join. We have interesting talks coming up on Cangrelor and newer antihypertensive drug and some life-saving approach on lipid therapy. And with this, I hand over the mic to Dr. Venkatesh Ram. Over to you, sir.
Everybody is here, right? Good afternoon, ladies and gentlemen. We break the mechanical approaches to treatment to more interventional medical therapies to reduce the burden of cardiovascular disease. Our first speaker for this afternoon is Dr. Girish Navasundi, who is going to talk about Cangrelor, new IV antiplatelet drug, when and how to use. Please.
Thank you, sir. Thank you, chairpersons and organizers for this honor. We're all great interventionalists, but we want, if your pilot, your co-pilot is as important. I think the drugs play the major role once you have done your job. Can I just have a changer if you don't mind? Oh, it's here. Thank you. Okay. We know what is the amount of CVD that will be treating. It's going to increase by at least another 30%. When we look at the milieu of thrombus, antiplatelets are the most important things. Anticoagulation just adds another brief support. The cornerstone therapy for management of ACS, preventing ischemia in PCI, when you look at it, what is amenable to us? Aspirin and then P2Y12 inhibitors such as clopidogrel, prasugrel, ticagrelor. That's been the best so far. And the DAPT guidelines post ACS PCI. ACS is the only space where your intervention has shown to reduce mortality. Most other situations, it's primarily to improve quality of life, prevent hospitalizations. So these are the most vulnerable patients where you need best drugs which act very fast, very consistently, and very predictably. So when you look at apart from aspirin, what are the 4 drugs that are available to us is now clopidogrel, prasugrel, ticagrelor, then you have mostly tirofiban and Cangrelor. What has really made difference to my practice in the recent days is Cangrelor. Let's look at the onset of effect. It's very important. We talk about door to balloon time. When somebody comes with an ACS, the success or survival and the LV function depends on how quickly you relieve that obstruction and establish TIMI3 flow. It's not just you opening the block, but at the same time, how quickly your drugs can open it and keep the vessel open. That's as important. When you give clopidogrel with whatever dose, whether 300 or 600, for the maximum effect, it needs 2 to 8 hours. When you look at prasugrel, it could be 30 minutes to 4 hours. Ticagrelor is usually about an hour, 30 minutes to 4 hours, depending on the hemodynamics of the patient or metabolization of the drug. But when you give something IV, Cangrelor, just takes 2 to 3 minutes. Can you imagine a drug giving you maximum antiplatelet effect in 2 to 3 minutes? And the duration of effect, this is also important. If you land up with a complication or you change a strategy to surgery, what is the duration of the loading dose that you had given? If for a clopidogrel, it takes 3 to 10 days to reverse. Prasugrel again, sorry, I'm not able to see. Okay. For a prasugrel, it takes about 5 to 10 days. Ticagrelor, 3 to 4 days. But look at Cangrelor, 30 to 60 minutes. If you need to bail them out for a surgery or you need to bridge it, it just takes 30 to 60 minutes. So that's why it becomes a preferred choice in what are the current limitations and how that can be met. Limitation of antiplatelet drugs that are there currently, apart from aspirin, is clopidogrel, ticagrelor, prasugrel, is oral. They have delayed absorption, not suitable in presence of nausea and vomiting, variable pharmacokinetics and dynamics, genetic polymorphism of liver enzymes may lead to variable responses, and delayed onset of action, which hinders your assurance that I have done best for antiplatelet effect. This delayed offset is also a problem if there's a bleeding or change if you want to send them for a surgery. So the risk of perioperative bleeding due to prolonged effects, unpredictable and often inadequate platelet inhibition at the time of PCI, that's the greatest unmet need. Then drug-drug interaction and slow conversion to active metabolites. These are the concerns. When you look at an injectable antiplatelet agents, IV antiplatelet agents like GP2B3 inhibitors and Cangrelor are reversible P2Y12 inhibitors, address shortcomings of oral antiplatelets. I think most of us today use ticagrelor, prasugrel, add on GP inhibitors. However, GPI were linked to higher bleeding risks, although it gave you immediate beta anti-ischemic effect, but led to higher bleeding risks. So 2017 guidelines, which we still follow, says GP2B3 inhibitor should be considered for bailout. Cangrelor may be considered in patients who have not received P2Y12 receptor inhibitors, which is the case in every ACS. How Cangrelor bridges the gap of oral antiplatelets? Look at it. Limitation of oral, we just said that there's a delayed action, delayed offset, and unpredictable in situations such as somebody has got a very low blood pressure, cardiogenic shock, nausea, vomiting. Those are the situations orals are not going to protect your PCI. Where is then use of Cangrelor? I think, any case, if you're going to intervene within 60 minutes of the patient arriving to your emergency, I think our oral drugs would not have had its full effect. So in my practice, in an acute MI, if I'm going to intervene within 30 to 60 minutes, Cangrelor is the drug. Then if you have peri-procedural MI, repeat coronary revascularization, stent thrombosis, in these situations, recommended dose is very easy, 30 microgram per kg IV bolus followed by 4 microgram per kg per minute infusion. While this is going on, you can load ticagrelor at any point, at the time of presentation, during the procedure, or soon after the PCI, you can load them. Once Cangrelor IV infusion is discontinued following PCI, patients are transitioned to P2Y12 inhibitors. It could either be clopidogrel, prasugrel, or ticagrelor. How do you transition? Look at it. While there is an infusion going on, you can give ticagrelor at any time during infusion or immediately after discontinuation of infusion. How much you give? 180 milligram. Prasugrel, you give immediately after discontinuation. Please do not give before or during infusion. How much loading? 60 milligram. If you're giving clopidogrel, give it immediately after discontinuation of Cangrelor. You must give 600 milligram. If GP inhibitors are to be anticipated in use, Cangrelor should not be administered. This is the only caveat you must remember, because both are significant propensity for bleeding. So there is no additional advantage of using GP2B3A if you have already started them on infusion of Cangrelor. So the landmark trials, you've got Champion PCI, Champion Platform, Champion Phoenix. What it has shown in a pooled data is Cangrelor significantly reduced the rate of peri-procedural ischemic events compared with clopidogrel, including stent thrombosis, with no increasing severe bleeding. And in Champion Phoenix shows that primary endpoints of death, MI, ischemia-driven revascularization, and stent thrombosis at just 48 hours were reduced by Cangrelor, 4.7% versus 5.9%, with no significant difference in severe bleeding. So there is a definite benefit that you see. Even in the Scantic study, you can see that significant difference observed at 5 minutes after bolus administration, that there's a significant inhibition. In the swap also you see Cangrelor has become an alternative potent strategy to glycoprotein 2B3A inhibitors with a favorable bleeding profile in PCI. Cangrelor was associated with similar ischemic risk and reduced bleeding risk compared with clopidogrel plus routine GP2B3A. Cangrelor reduces periprocedural thrombotic events with low risk of bleeding compared to PCI. So another case is bridging. When you have done a recent PCI and patient is scheduled for some emergent surgery, either it could be a bypass surgery, neurosurgery, oncosurgery, transplant, you can stop your antiplatelet about 5 days before and transition to Cangrelor and stop Cangrelor a couple of hours before the surgery, and they can do it and restart when considered safe. It's been a boon to many of these high bleeding risk patients requiring immediate surgeries. So to conclude, what I would like to tell you is the salient feature of Cangrelor is currently only available P2Y12 injectable inhibitor, has a rapid onset 2 minutes, offset about 60 minutes, maximum concentration within 2 minutes, very reassuring, superior to clopidogrel, overcomes limitation of many orals in different clinical situations, and interrupting the infusion restores normal platelet function if there is a bleeding or major adverse events. Thank you, friends. Just to conclude, you got 4 or 5 situations. Acute coronary syndrome presenting to emergency room. Second, any hemodynamically unstable patient because the absorption is going to be inadequate in the GI system. Third, hemodynamically unstable. Hypotension, absorption is unpredictable. And wherever you think, oral is not going to be appropriate, IV Cangrelor is a go-to choice as a second antiplatelet. Yeah. Thank you.
Thank you, Girish, for covering this. I'd just like to take 1 minute to explain to the audience what has happened about exactly a week back. We had one young lady admitted and husband. It's a reverse story. Husband again got emotionally attached, and the next day after PCA to the young lady, this man developed chest discomfort, had a cardiac arrest. He was taken to ER and resuscitation was done. And our ECMO team, people were active. They wanted to put an ECMO, but I said, let me see once. And then some rhythm came back after repeated shocks. It was showing ST elevation and interval MI. Then we immediately switched to cath lab. And then we started to do PCI because there's no time even for the ticagrelor to act. We started IV Cangrelor infusion. And then to put Ryle's tube and all, it was taking some time, though we put Ryle's tube and later on give crushed ticagrelor. But we started the procedure within half an hour, artery was opened, and the rhythm came back. As you know, once the rhythm picks back, the blood pressure also improves, everything improves. So ticagrelor really saved that life, I feel. So such sort of... Cangrelor, and followed by ticagrelor acting. So without Cangrelor, that patient would have developed stent thrombosis or what all we don't know in the acute phase. So it's a really good drug and very useful in such acute scenarios. This has happened 1 week back and patient is now discharged and is comfortable. So such sort of lot of stories all of you could have, and there's a great drug for acute usage. Thank you.
Yeah. Thank you. Thank you, Dr. Sindhi, for an excellent presentation on Cangrelor. Now I invite Dr. Tani Nair to talk about aldosterone-mediated hypertension. And we all know that aldosterone is one of the key mechanisms by which hypertension develops, and is going to talk us about new insights about aldosterone-induced hypertension.
Good afternoon. Good afternoon. Thank you. Yeah, so very recently on the 20th of May 2026, Nature Review said that there's an approval of a first-in-class new drug for hypertension, and that is, as we know, aldosterone synthase inhibitor, baxdrostat. And that's what we are going to talk about. Aldosterone synthase inhibitor, baxdrostat. We know that aldosterone is bad, right? Aldosterone is a villain, and through the MR receptor, it creates all sorts of trouble. And the first thing is high blood pressure. But we also know that aldosterone creates a lot of other problems. For the heart, it creates left ventricular hypertrophy, fibrosis, and eventually perhaps a driver for HFpEF. For the kidneys, it creates even more problem, leaking of protein, and finally CKD. It's a driver for CKD. Now, we always try to inhibit aldosterone by acting on the receptors, spironolactone, eplerenone, finerenone, and even now the new drug esaxerenone. But we always dreamed that maybe one day we would inhibit aldosterone at its source, right? And that we need to look into the pathway, right? From cholesterol, pregnenolone, progesterone, we got 11-deoxycorticosterone, and finally aldosterone. And that converting enzyme is CYP11B2, what we commonly call as aldosterone synthase. The aldosterone synthase, today we know the exact structure. So it's very easy, right? You have a 3D modeling, create a drug that can inhibit exactly that structure. And that's how we got the first aldosterone synthase inhibitor called osilodrostat. Look, fantastic, right? Fascinating. It'll inhibit aldosterone synthase. But we missed out on something, and that is this. The other pathway of the same adrenal gland metabolism produces cortisol. And that enzyme that is responsible looks so very similar, right? It's similar. It's CYP11B1. Looks exactly similar, like a twin brother. A little different, right? 503 amino acids, 93% similarity between the two. So what happened? Osilodrostat also inhibited cortisol. And so it was out. In fact, if you follow the news, osilodrostat and the newer generation ones are now being used for Cushing syndrome. Then we got highly selective aldosterone synthase inhibitors, which would act on the CYP11B2 100 times more potent than the B1. It's like the highly selective beta blockers. So we would be talking about the highly selective second generation aldosterone synthase inhibitors, baxdrostat, and of course we have the lorindrostat. Right. The first trial came in 2023. It was a phase 2 trial of baxdrostat, which was called the Brighton trial. The Brighton trial took 250 odd patients, resistant hypertension, defined as those who needed 3 or more drugs, and one of them had to be diuretic. And they were given baxdrostat. At that time, people were not sure what the dose should be, 0.5, 1, and 2 milligrams. Okay, and they were followed for 12 weeks. Now look at the treatment, 100% received diuretic, very well treated, right? Look at the ACE inhibitor ARB, 93%, 92% received RAS inhibitors. So very well treated group. And when we looked at the blood pressure drop, it was truly fascinating. 2 milligrams of baxdrostat reduced systolic blood pressure on the left by 20 millimeters mercury and diastolic blood pressure of 15 millimeters mercury. Think of it. These are all resistant hypertensive patients who were on 3 drugs. One of them were diuretic, and on adding baxdrostat 2 milligrams, we got a 20 by 15 millimeter blood pressure drop. Right. Truly, truly fascinating. They also looked at what happened to aldosterone. This is an aldosterone inhibitor, right? So look at that placebo there, high, all dosage significantly reduced aldosterone. They also asked, what happened to cortisol, right? We were talking about cortisol being suppressed by the first generation drugs. Look at cortisol. All dosage had no effect on cortisol, exactly like placebo. So cortisol, no suppression, significant aldosterone suppression. I know what you were asking about. What happened to adverse events? Look at the potassium levels. Look at that potassium levels, 2%. Baxdrostat had hyperkalemia, more than 6, 2%. 5.5 to 5.9, about again 2%. We'll take that up in subsequent trials. So they tolerated the drug well and significant blood pressure drop. The second trial is called the BAX hypertension trial. 2025, much larger trial, 796 patients. Some were uncontrolled hypertension, defined as those who were on 2 drugs, and the rest resistant hypertension, 3 or more drugs. Similar pattern, baxdrostat now was 1 and 2 milligrams versus placebo. Look at that data again. The good thing is about 25% were Asians. We always ask, is there a data from India? 25% were Asians. And look at that diabetic, 30%. The usual kind of patients we would all see in our outpatients, right? And what happened? Look at that. Systolic blood pressure with 1 and 2 milligram baxdrostat dropped by 16 millimeters mercury. And diastolic pressure dropped by about 10 millimeters mercury. So similar kind of blood pressure fall with 1 and 2 milligrams. 2 was a little more than 1 milligram. So good data, good data. And the third trial, and of course, this is something very interesting. We should not skip that out. Look at the homogeneity of the benefit. Age, gender, Asian, non-Asian, whatever you look at, they're all on the left of the midline, showing that Baxdrostat did benefit every kind of subset, right? Very clearly, no heterogeneity at all. Well, the side effects. Look at the side effects. Look at the side effects. Potassium more than 5.5, 11%. More than 6, 3%. Pretty acceptable. After all, listen, it's an aldosterone synthase inhibitor, right? So you are expecting that there could be hypokalemia, but then this was right, not much. What about the next trial, which is called an BAX24? That is the reason why this trial is called the BAX24 trial. This was a large trial, 22 countries, 79 clinical sites, 217 patients. You might think why the numbers are small, because they're all resistant hypertension. More than 3 drugs, one of them is diuretic. Baxdrostat 2 milligrams, 12 weeks follow-up. This came in Lancet, right? And you look at the data, the Asians were about 15 to 20%. Very well treated again, diuretic 100, RAS inhibitors 93, 95%, CCBs 89, beta blockers 50. And this is the result. Look at that baseline on top. Yellow, the blue is placebo, red is Baxdrostat, and this is at week 22. Placebo there, Baxdrostat there. Significant drop, right? Significant drop. But that is not what we want you to focus on. Look at that. I just put the square on a night blood pressure. This is by ABPM, ambulatory BP. Look at that night blood pressure drop, significant. People in hypertension research, we always want that the night blood pressure should drop because that is what determines long-term outcome. And with Baxdrostat, the night blood pressure drop was very, very significant. Okay, right. So again, look at that homogeneity. Every category, age, sex, gender, race, whatever, everybody benefited. In fact, the trial is commented that the response rate was near 100%. There was hardly any non-responder. Some responded well. You know, in trials, some respond good, some respond bad, some don't respond. But in this trial, non-responder rate was near zero. Near zero. Happens very rarely. Right. Adverse effects, again, hypokalemia. Look at that. More than 6 was 5%. Acceptable rate. Acceptable rate. Be careful about hypokalemia. So see, this came in 2026, JACC, where they talked about second generation aldosterone synthase inhibitors in hypertension. They took all the data, lorundrostat, Baxdrostat, and this is the central illustration. Just focus on that. 8 multicentric double-blind studies, and this is 1,000 patients Bax, lorundrostat, again 1,100 patients, and Vicardrostat 215. Right. This is final thing. 94% of patients showed overall response. Systolic and diastolic blood pressure drop, you can see there. But what is even more interesting is severe hypokalemia was 2.1% compared to 0.3 placebo. Acceptable, right? So this is the overall data that we are talking about Baxdrostat today. Finally, they tried to compare all the available, by network meta-analysis, all the available ASI. Where does Bax stand, because lorundrostat is also going to come, and this is a SUCRA plot, meaning surface under cumulative ranking curve, but finally it shows that the largest effect, most potent, is Bax compared to lorundrostat. So Baxdrostat is effective, safe, and it does work. Indian subset, where should we focus on? Number one, people who have got abdominal obesity. We know that in India, we take too much of salt, double that prescribed by WHO. And of course, about half of our population are salt sensitive. And in these 3 situations, we know that the unseen driver is aldosterone. So perhaps these are patients, if they come with a resistant hypertension, uncontrolled hypertension, I should start thinking that should I use the new drug when it is available in India? Finally, we end with this. This is a very interesting article called Inflection Point. Aggressive treatment meets novel mechanism. This is written by Dr. Rajiv Agarwal just about 2 weeks back in JACC. Very interesting, very interesting. Just look at the central illustration. He says that today we are at a crossroad. Because today we know that the blood pressure needs to be reduced below 130/80 as close to 120 as possible. Right, all the guidelines say that. And why do they say that? Because SPRINT, STEP, ESPERIT, and BP Road, all these 4 trials, have shown that by keeping blood pressure below 130/80, we reduce MACE, we reduce mortality, And there is no evidence of a J-curve harm. No J-curve, mortality reduced, MACE reduced. So we are looking at a far lower target. And not just that. Today, first time in the last 15 years, we have 4 new antihypertensive therapies that has come to us. First is aprocitentan, which is a dual ETA-ETB antagonist. FDA approved it in March 2024. It's quickly going to come to India. Second, we have the new hardware for the renal denervation, which has been approved by FDA again in 2022. And of course, we have the aldosterone synthase inhibitors, baxdrostat, lorundrostat. The article says FDA decision pending, but then on 30th of May, FDA has cleared it for the first time. Is FDA cleared, baxdrostat, right? And of course, you have the hepatic angiotensinogen inhibitor, zilebesiran, which we know it's going to be the dream drug, 1 injection, and hepatic angiotensinogen would be down for the next 6 months. 1 injection, 6 months. Hopefully, it should come after the phase 3 trials are over. And where do he recommend aldosterone synthase inhibitor? 2 situations. 1, resistant hypertension, where ASI plus other drugs would be game changer. And of course, 2nd, obesity-related hypertension. So thank you for your time and attention.
Thank you, Dr. Nair. Thanks very much. Do we have Dr. Viveka Kumar here, please? Okay, if Dr. Viveka Kumar is not here, then we proceed to the next lecture.
This is the problem. Being the organizer, they're requesting me to just briefly present. And I love this molecule. That's why I said immediately, okay, Reddy's being one of the important help for us. I'll just briefly take 5 minutes time and can you get his Vivek Kumar slides? It's the fastest preparation time I've taken. They told me just a few minutes back that he's not there, his flight is cancelled or something. So I'll briefly take into these slides. But one thing I would like to say before the start is Repatha, there's a evolocumab molecule, and now the inclisiran molecules are game changers in lipid therapy. And such a low single-digit levels of LDLs we have not seen before the advent of these 2 great molecules. So we all understand that once a patient suffers ACS, this bothers us. 50% of them had developed some problem or other. Most of the time, sometimes it could happen in shortly within a month. So we want some drugs. Those statins were there. We were wanting to have some other things which will control the lipid levels sooner. We know that because so much of instability happens to platelets and these things are recurrently happening, endothelial dysfunction, oxidation, immune response. And that's why we were looking for a drug which controls this platelet vulnerability apart from the lipid control. So if you see this PCSK9 levels, and then immediately after MI can significantly decrease their values and not expose these patients to longer. So immediately post-MI, because of inflammation, a lot of things go up in the body. So and then we wanted to have a drug which immediately could act as fast as 48 hours immediately post. And that's why this drug initially tested. And now the latest guidelines also say that we need to get the LDL cholesterol less than 55, which is difficult in many patients. So these molecules which are pretty potent does it very fast and gets those levels down as soon as possible. So this initially after PCI, then another setup after rather than MI is after PCI. So PCI again we do stenting. Now we know that not only doing treatment with stent, and even the acute levels also see it come down. So as a protocol, what we started doing, I'll take you through that next. After PCI, again, immediately controlling, there's some data come up that giving this molecule immediately would help. And especially when not only post-MI, there are so many trials being conducted, which I can't go in details post-MI, but I'm primarily also interested, apart from this ACS, where it is proven that rapid control is necessary, and sometimes subclinical atherosclerosis progression also is prevented, a lot of data coming up. Another thing where I'm saying is so much low LDL cholesterol reduction apart from statin therapy is also possible because of this. Then multi-vessel disease patients. Now each of these young patients come with not only the culprit vessel, but disease is there in the other vessels too. So like that control of that, as well as nowadays we do multiple stents. If you see average stenting for us, each patient, I think 3.4 stents are what is put. Such complex cases do come. So we want not only immediate treatment of that particular vessel, but we want the disease to reduce even in the other vessels too with these molecules. As a protocol, after multi-vessel PCI, especially complex CHIPS type cases, we give this molecule before discharge and then follow it up with long-acting molecules like inclisiran, where levels will continue to low. So there are a lot of studies are coming up. I spoke with the US gentleman too. There's a lot of research going on this front after secondary prevention for the complex cases. So that's what I wanted to mention, not only in post-MI where acute inflammation is noted, but even patients who have multi-vessel disease, residual disease, where the disease incidence is high, recurrence rates are as high as 30 to 50%. Usage of this molecule in the early stage will decrease the risk and also probably prevent future events happening. Such aggressive lipid lowering therapy is being promoted not only as secondary prevention, but the Victorian Prevent trial is saying even for the primary prevention that we are not yet there. All the doctors who are sitting here, Eugene Braunwald said, if you want to control your lipids well and get your cholesterols very low, all of us can live without getting heart attacks for 100 years if you take the help of these molecules. One thing I can say with whatever little usage we did, they're quite safe molecules, and single-digit LDL cholesterols I have started seeing with the advent of these new great molecules. I think with this, I wanted to save some time also. Thank you very much for your patient hearing.
Thank you, Dr. Saab. Our next speaker is Dr. Rahul Gupta. He will elucidate about plaque formation and plaque stabilization and its role in acute coronary syndrome. Dr. Rahul Gupta, please.
Yeah. Can I have my slides? So good afternoon, everyone. And I think he has already built up a little bit of background because we need to move from plaque formation to plaque stabilization and the impact of lipid lowering therapy. I think these are some points which all of us needs to think. As an interventional cardiologist, are we focusing more on treating the lesions or the disease that created the lesion? I think this mindset has to change. Now, keep answering in your mind, what proportion of myocardial infarction arise from the lesions that would have been considered significant enough for PCI the day before the event? We all know that more than 40-50% of the ACS which we face are the one which have non-obstructive plaques. If angiographically mild plaques can cause major event, is percentage stenosis still the wrong lens through which we view the coronary artery disease is what we need to think. A patient has undergone technically perfect IVUS guided PCI, but is discharged with LDL-C 105. Are we having a biological success or only looking at the technical success? Would you start a combination lipid lowering therapy during the index admission or first demonstrate failure of statin monotherapy? So do we need to be a little more quicker as we do with the antiplatelet? So why do we use an aggressive upfront strategy for antithrombotic treatment, but a stepwise strategy for LDL lowering? I think we need to think about all these points. Is waiting 4 to 6 weeks to intensify therapy clinically sensible or administratively convenient? Because once we answer, I think our psych is going to change, the mindset is going to change, and should recurrent event risks determine treatment intensity rather than the baseline LDL-C number? So these are the questions which we need to think, because LDL-C is a growing health challenge. 185 million have high LDL. High LDL-C is a causal yet modifiable risk factor of ASCVD, and 85% of ASCVD mortality is primarily driven by coronary artery disease and stroke. So this LDL-C driven atherosclerosis journey, if you look at, so we know how it begins: endothelial dysfunction, fatty acid streak, plaque, vulnerable plaque, rupture, thrombosis, acute event, and obstructive disease. So can we prevent this progression by being a little more aggressive? I think this is a very important slide. Higher LDL-C levels directly correlate with increased number of vascular sites with atherosclerosis. And progression of early subclinical atherosclerosis study has shown that each 10 milligram per deciliter rise in LDL-C increases the odds of multiple site atherosclerosis by 18%. This is a very important number. The number of atherosclerotic site increases with LDL-C levels from 11% at 60 to 70 milligram per deciliter to 64% at 150 to 160, and 30% shows involvement in multiple vascular sites. So achieving substantial LDL-C reduction is critical to mitigating the risk of CV event, and this is an important part of this PISA study. So from plaque formation to plaque instability, why plaque methods are they linked to the clinical outcomes? So what defines a vulnerable plaque? So let's look at thin fibrous cap, hallmark of thin cap fibroedema, reduced tensile strength, large lipid-rich core, more than 40% plaque area, highly thrombogenic substrate, positive arterial remodeling. Lesion may appear non-obstructive despite high risk, and spotty microcalcification, which increases the local mechanical stress and instability. And these are biological features like, which is plaque activity, macrophage and T-cell infiltration, neovascularization, intraplaque hemorrhages. So angiographically mild plaques, less than 50% stenosis, can rupture and cause acute event, and which we see in our day-to-day practice. And what are the consequences? We all know, which is a driver of MACE, atherogenic lipoprotein LDL-C deposition, plaque vulnerability, high-risk plaques, thrombosis, plaque formation and growth, and all these clinical events which follow with increasing LDL and these kind of plaques. So we have to see what can we do for these. And these are the clinical evidence which support the mechanism, because plaque rupture drives most fatal MI. 70 to 75% are due to rupture, rest are because of the erosions. High-risk plaque are TICFA, higher event rates, 3 to 5 times increased MACE risk. Events arise from non-obstructive plaque, majority originate from less than 50% stenosis lesion. And risk versus plaque burden. Risk increases with plaque burden, multiple vulnerable features, 4 times higher event, and imaging evidence shows that vulnerable plaque feature shows 3 to 4 higher MACE. So can we reduce this? So plaque regression translates to reduced CV risk, and these are various studies which are there, and each 1% decrease in plaque atheroma volume reduces 15 to 20% MACE events. So conclusion was reduction in coronary plaque burden is strongly associated with lower CV events, confirming that plaque regression is a clinically meaningful surrogate of cardiovascular risk reduction. So when we use lipid-lowering therapies which can cause plaque stabilization by reducing the lipid core size, thickening the fibrous cap, reducing inflammation, promoting plaque regression, improving endothelial function, shifting plaques to stable fibrotic phenotype, and greater LDL-C reduction is greater benefit. So if we all know each 1 millimole per liter reduction in LDL-C level was associated with 24% reduction in major coronary event, 25% lesser coronary revascularization, and 60% reduction in stroke. So overall, there was a 22% relative risk reduction across all major vascular events per 1 millimole reduction in LDL-C levels. These are various imaging modalities. I think we will go through them during our discussions in the next part of the talk. And these are various coronary CT, intravascular ultrasound, OCT, and NIRS, which can actually allows for the quantification of the lipid core. So we'll discuss amongst the panel that how each one of us use these different modalities to characterize our plaque, and can it change our treatment strategy. We have enough evidence with lipid-lowering therapies. In the previous talk also, Dr. Srinivas discussed the reversal trial, asteroid trial, Saturn trial, all showed that high-intensity statin can actually reduce the plaque atheroma volume, and we all know that plaque atheroma volume, once we reduce, we can have beneficial impact. Adding ezetimibe plus statin, additional plaque regression has been seen. This we saw in the IMPROVE-IT trial, and further LDL-C reduction with ezetimibe on top of statin reduces cardiovascular event beyond statin alone. More intensive LDL-C lowering with PCSK9 inhibition and greater plaque regression and stabilization. We saw in the Glagov, Pacman, fibrous cap increased in the Huygens trial, and the lipid core decreased and macrophage signals decreased. So these are various trials. We need not go into the details, but they have conclusively shown that by reducing by increasing the intensity, we can actually reduce the plaque and we can reduce the events. So inclisiran is emerging evidence in plaque modifications. There are ongoing trials advancing the beyond LDL lowering impact on atherosclerotic plaque. One of them is V-plaque study, which is mechanistic evidence, and it is the first dedicated mechanistic study evaluating inclisiran versus placebo on top of maximally tolerated statin therapy and designed to provide direct imaging-based evidence of plaque regression with this molecule. V-Accelerate study is early ACS intervention, which we had with the evolocumab. Now, this is ongoing studies in the Chinese AMI study, inclisiran versus standard of care, initiated during acute event. And objective is to evaluate change in coronary atherosclerosis burden and explore the impact of early LDL-C reduction in plaque trajectory post-ACS. So to conclude, the future interventional cardiologist may be judged not only by how well the stent was implanted, but also by how effectively the next plaque rupture was prevented. So I will just go with one case scenario, which is a thought-provoking, and then we will go. So because this will be interesting, this is, we should want to end with a provocative case because 60-year-old male, status post PCI many years back, SDH in August 2024, came with cardiogenic shock. So look at this picture. Immediately after the angiogram, he arrests, CPR is ongoing, thrombus aspiration, PTCA, ongoing CPR, and this is what we achieve. And distal LED thrombus treated with POBA results after the distal LED occlusion. So, we can all discuss how many would stent at this stage, would leave it at this stage. And so we thought of not treating this patient with stents. I repeated the nurse IVUS for this patient after a few days once he was stabilized. These were the findings. So mid-LED lesion with area of 5.2. So mechanistically, it's not flow limiting. Circumflex structures were there, a little bit protruding in the left main, and LM non-significant with MLA of 7.4. LCBI was high in this patient. And after the nurse IVUS of the circumflex was okay, this patient was initially put on evolocumab and then was on inclisiran, and this patient is doing well just with the biological therapy for this patient. So I end up with this case, and then we can have the panel discussion.
Thank you. I think one more, Dr. Shamshad Alam, other panelist is also sitting here. I believe. Please come on. Who are other panelists in the program? Please come over to podium. I think Dr. Jain has already joined. Thank you, Jain. We can continue the discussion.
Yeah. So can we have the second slide, second presentation, second PPT? So I think we all need to change the mindset. I would like to have the opinion of the experts once we have. These are the questions for all those who are on the panel, that how would you utilize this therapy? Is there a change in the mindset for, how we treat? So can we get the slides? Can we go to the next slide, next presentation? Okay. So I think these are the questions for the panelists, which I am supposed to ask. And what plaque feature do you consider the strongest predictor of future cardiovascular events? So I think lipid core, cap thickness, plaque burden, or positive remodeling. And how would you address?
I think all of them are actually high-risk features. In fact, the lipid core and the cap thickness and plaque burden percentage, the volume, and positive remodeling also. For all these, one thing which often missed is the last one, that positive remodeling. We think that vessels is not narrowed, only realize that there is a positive remodeling, there's a plaque sitting outside the margins of the vessels. So all of them actually are very high-risk features, and each of them can be treated with early lipid lowering therapy, aggressive and very early lipid therapy. We shouldn't be waiting in order to order passivating the plaque. One important study I think we must recollect in 1989, which was published in New England Journal of Medicine by Glonstein, is that every MI that you see with the conclusion of an artery, many such plaques are there which are likely to vulnerable plaques which are likely to rupture, are already ruptured but not propagate themselves into a complete occlusion. So this shows passivation of the arteries are extremely important. So once at MI, we should actually think there is a many such kind of plaques which are very high risk nature, and we should treat aggressively these patients with aggressive lipid therapy.
So I would agree that all of them. Yes, go ahead.
Thank you. This is a very important question, and what we have seen is thin cap fibroma. This is one of the thing which is more prone. What we did in our hospital is whenever the patient acute coronary syndromes come, so the non-culprit vessel we started investigating where it's not significant echoangiogram wise except 50%, and we have seen especially with we're doing a small 40 patient study with both OCT and neurivus, and this non-infarcted vessel we have seen that there's a lot of LCB index more than 400 and 500, and we're trying to correlate OCT findings with the neurivus, and we have shown that both are correlating well. In fact, neurivus is much easier to understand. OCT, you need to do 100, 200 to understand OCT readings, but neurivus has shown that the NCLB index is more than 400, and those patients were aggressively treating them with these newer drugs, PCSK and inclisiran, and we probably another 10 patients are remaining. We might be publishing probably in the CSA also.
Correct. I think this is a very important finding and message that sometimes because of the positive remodeling, we don't see, stenotic plaque, but we all know that they can cause trouble. And so managing them aggressively is a good idea. So I think total plaque burden is important, but most dangerous plaque is where we have everything, as you rightly said. So if cost and access were not limitation, I think you spoke about the imaging modality. So which would most influence your treatment decisions and why?
So if the cost is not an issue, I don't mind doing both OCT and neurivus. But what I said again, any patient who's high risk, who is a very high risk patient, who has repeated events, try to investigate them and look for a vulnerable plaque and tell them that there's an evidence. I was not just giving drugs. You are going to be more risk for further event, and then give this. That's what it's an individualized therapy for high risk patients. And then we're trying to practice it regularly in our hospital, and then that is going to yield results. Like somebody has a second event, do an imaging must, and then tell them that you have a high risk plaque feature, LCB and LCB index is more, you have to be more careful, more events, and they're ready to take the medicines when you have evidence. If you just show them the LDL levels, they're not convinced still.
Exactly.
So, but both the modalities, IVAS and as well as OCT, are complementary to each other, because some of the features of plaque, characteristics are much better evaluated by OCT, where IVAS can give you a better modality in the form of what you call the percentage volume of the plaque. So both are actually complementary, and then at least one of them we have, then it's going to be good for us, and both of them are even better.
Right, but I think imaging, as you rightly said, we need to understand our plaques, but more and more studies have shown that somebody has developed ACS, and even in the non-culprit vessels, they would have a vulnerable plaque. So we can, because not everybody can afford, but we can be aggressive in our treatment when we have, all those high-risk features in our patients. So imaging modality is, of course, chosen based on the question we need to solve for our patients, and we can, decide, but these inputs are valuable. So if vulnerable plaque is the substrate for future event, should plaque stabilization become a therapeutic goal alongside LDLC target achievement? I think, yeah.
Absolutely. I think once there's MI, and then we should actually aggressively treat them by imparting them to a highest level of what we call therapy and trying to reduce the LDL cholesterol marked levels. Most of the statin therapies what we have today may not be achieving in all the patients. In fact, there's one of the Indian studies which showed that 80% of the patients are not achieving the LDL reduction to the extent that should be reduced. That is less than 55 in the first instance. For that matter, Lipid Society of India actually showed that if high-risk patients, we have to go to all the more less than 30. So this is usually not possible in those patients who are giving even highest amount of dosage of statins, even if we have bempedoic acid and as well as ezetimibe, because they all take the sweet time. Right. So what we need to do in high-risk patients, at least patients who have multiple MI or multivascular disease, who got multiple risk factors, it's always prudent to start them with some kind of therapy which guarantees us to have LDL cholesterol reduced dramatically very early. That is, of course, we have monoclonal antibodies, followed by, of course, inclisiran, which can give us a long-term therapy with a very good reduction in the LDL cholesterols.
Exactly. You want to add in something?
Yeah, LDL is a biomarker, but plaque stabilization is a biological achievement. That's what you should understand. Okay. And then it's not only in the lipids, but also you should have lifestyle modification, hypertension control, diabetes management, smoking cessation, and most important thing is anti-inflammatory drugs. So you should not forget the other drugs whenever you are dealing with vulnerable plaque.
Right.
So all this has to be taken in consideration.
No, agree. So I think treat the patient to stabilize every plaque, not one image. And we have all these trials and which has shown that how controlling aggressively helps our patients. Now, how would monitoring LDL help in these parameters or impact your decision in clinical parameters? How do you monitor LDL in your clinical practice? How frequent? How do you decide escalating the therapies?
Yeah, irrespective what is LDL cholesterol and in these high-risk patients, we need to be very aggressive. Number one, don't go by the LDL level what we have seen there, because number one, LDL cholesterol levels transiently they come down after the the MI is there, and then LDL converts itself into a small dense LDL. So, which is very highly heterogenic. So, we should not go by the LDL level at that time and give a aggressive therapy to them, so that we have reduced LDL cholesterol to markedly reduce levels to the optimal level. Then it is, of course, we can at the end of 4 weeks, we can look at the LDL cholesterol whether reduced or not. But most often when you are giving these newer therapies, it's likely to reduce to optimal level. And if you are not using these new molecules like monoclonal antibodies or inclisiran, then of course we have nothing to do, but we have to have all the 3 drugs on board and try to give them. Look at the LDL cholesterol after 4 weeks. But if unfortunately they don't drop the LDL cholesterol to low levels, what we expect at the end of 4 weeks, already we are doing some harm to them. So what we probably can do is that, we have what is called a monoclonal antibodies which are available. They are not very expensive. It's cost of 14,000. When we're spending so much of time for primary angioplasty or admission ICU, you give one injection, and it not only reduces LDL cholesterol to very dramatically low levels. More importantly, it also sequesters all the circulating PCSK9 molecules. PCSK9 molecules are independent risk of actually destabilizing the plaque. It's a highly inflammatory substance. So then it should be followed by inclisiran, because inclisiran may not actually dramatically reduce acutely, but at the same time it may not do anything to circulating LDL, the PCSK9 molecules. So there is a combination of these two things, like an early one injection of monoclonal antibodies followed by a inclisiran would be the best thing to do, or at least if the patient cannot afford, give one injection of monoclonal antibodies.
Right. Any other point? Otherwise, we'll just quickly go through the question and. So for you, what are the top 3 barriers preventing patients from reaching and maintaining LDL-C targets in routine practice? Maybe quickly then.
Yeah, this is a very good question. The first is the cost. The second is this interventional cardiologist inertia. All of us are so busy in labs, so we forget to check LDLs, educate them that these numbers have to reduce. So when you are having 2-3 angioplasties, 4 angiograms, we concentrate more on that. When you don't have, on that day, we'll check all the parameters. Then we educate the patient. I think that's a very, very big problem with our practice. In India, unfortunately, we're all intervention cardiologists. We're clinical cardiologists. We have to monitor everything. We have to do echo. We have to do everything. Not like in Germany, they have separate doctors. That somebody else manages LDL. He does only CHIP PCI. So, but India, we have to do CHIP PCI. I think that's the biggest barrier in our country. The third barrier is the cost, of course, that not only India, in US also the same barrier is there. So I think the most important is inertia. That inertia has to be removed.
I think that's the most important part. We have all the knowledge, we have all the things, but we are sometimes not able to apply it because of all these reasons. So I think final take-home message, because our time is up. And
even the multiple doses what they need to take every 15 days, the PCSK9, a number of pills they have to take every day. If you have something which is given once in 6 months, like inclisiran, it's going to be another milestone in achieving a better control of this LDL cholesterol. Besides, I also want else we should put the some kind of information to the labs also, not to say 130 LDL cholesterol is normal. They usually have it. And also it's high time that we also incorporate LPA levels in our routine lipid panel. It is not there.
Right. Thank you. I think we will end our session here. Very insightful messages from both of you.
Thank you very much for this session. Dr. Tiny Nair is here, one left behind after all this. So at least we'll have some comments for him. Yeah. One study he has shown, this is the difference between clinical trials and clinical practice. In clinical practice, we're labeling every other patient as resistant hypertension. In clinical trials, he showed one study, 80 centers to recruit 200 patients with resistant hypertension. 80 centers, 200 patients with resistant hypertension. That is true resistant hypertension. So the one comment I have for Dr. Tiny Nair is aldosterone goes down, cortisol doesn't go up, doesn't go down, but the incidence of hyperkalemia is still less. Why is that? Such a decrease in aldosterone, but hyperkalemia is much less. Can you comment on it?
I think two things. One, of course, the hyperkalemia thing. At one point of time, for example, we used to be guided to diagnose Conn syndrome as hypokalemia, and aldosterone syndromes are all looking at potassium. Today, we know it's not true, right? 20% of our patients might have aldosterone high state without having change in potassium. So I think potassium and aldosterone don't really move that closely to give us a strength of evidence of diagnosis or complications that comes in when we put an aldosterone antagonist on board. That's one. And the second thing Professor Ram said is very, very important. Right? When we talk about resistant hypertension, take 10 resistant hypertension and just admit them in your hospital. 5 of them, with the same medication, their blood pressure will be controlled. So the first thing is they're not taking the medicine correctly. So compliance is number one. For example, take OSA, sleep apnea. That's number 2. You take care of those, and half of your resistant hypertension might get controlled. That's right. That's why 79 centers, you could recruit about 200 resistant hypertensions over time. Thank you, sir.
Thank you. I think post-lunch we'll have a RDN session on which I keep telling Medtronic that the way you counsel them that if you don't control, you do this procedure, half of the patient's blood pressure getting controlled because otherwise he has to spend 5 lakh rupees for the RDN therapy. So that's the effect. I said this procedure not only has the effect before you tell, even counseling itself, patients are becoming compliant and the blood pressures are better controlled. I think we request you to reassemble back immediately at 2:20 p.m., half an hour break for lunch, and we'll have RDN talk by Sandeep Mishra, and then 2 live cases coming up at regarding the regulating balloons and again calcium modification. Finally, you will have aortic regurgitation, penultimate case to keep everybody in the hall. A newer therapy of newer type of Janaval therapy coming from US as a live case. We break now. The same thing, same way. The faculty will eat in the Kanak restaurant here, and then all of the delegates can eat in the Tuscany restaurant 1 floor above. Thank you again. We'll please reassemble back by 2:20 p.m. here. Thank you.
India.
This is the left system that can you able to see the angiogram?
We are seeing the slides. Can you move to the angiogram? Now we can see.
Yes, sir. Yes, sir. Yeah. Circumflex, that continuation is very small. That OM1 is a severe disease, and one OM measure, that bigger OM is there, that is CTO, that was occluded from that point only. That we can see that is distally it's seeing a small filling from the same OM. That
OM just above that. Next slide. So that I just wired that OM first because its origin is severely diseased. If I lost, that patient might be become very symptomatic. Next. Then after that, we took a microcatheter and placed that with help of routine wire. And I've taken the Gaia 2. Then this Gaia 2, next please. It was not negotiating properly, but somewhat I can able to hit. Next, okay. So it was advanced somewhat. I've taken the long injection. Sometime it looking it's okay. And this injection we can see it's not in actually true lumen. It is somewhat outside or some branches. And same we can see in another view also. Next, please. So I just withdraw the wire and reposition it somewhat, but still it's not in actually true lumen. It might be in some branches. And after several attempts again, this time I'll also it looking it's not in good shape. The true lumen from the homocollateral is just above the wire. Next, please. And after that, again I have done some manipulation. Next. Now I withdraw the wire. Next.
Did you try to use parallel wire technique, which will be maybe useful?
This we can see there is some dissection probably that is created by the Gaia wire. Next, please.
There is a section hematoma as well.
Yeah, I agree, sir. Even this time again, I went into the same where I went earlier. Next, please.
That's why to avoid
this
Dr.
could be
Benaslo
side branch.
is suggesting something. I think it is okay.
Yes, sir.
You follow what is called as parallel wire technique. Leave that wire there in the false passage and take another wire to go into true lumen. That's what.
But lastly,
you could enter.
I can able to negotiate negotiate the distal true lumen, and after that I dilated it 1.25 balloon. Next, please. Just I confirm it in another view. Also looking, it's okay. It's in the true lumen only. So
it's very important to confirm in both views because sometimes it looks
yes,
one.
Sir.
Yeah, you did that. Okay.
Yes, there's a 2-3 view. I have taken elocranial also. It looked like true lumen, and then back. Then this saw clearly my wire is in true lumen, sir.
Yeah.
Then I exchange that Gaia wire with normal workhorse wire, and that OM wire came out during that procedure, but I can able to wire both. Now I am here. Now I will dilate both branches with the bigger balloon and do the IVAS. Next, I just want to know from you, sir, what should be our option in this case? Balloon.
Did you plan? Do you plan to perform the predilatation as a kissing balloon maneuver or just sequentially?
First, I will dilate both branches and see how it is behaving. Then I think better to decide what we have to do because I have not dilated till now.
It looks at the moment like a small diameter vessels, but now you have quite long segment with probably hematoma and dissection, so you probably have to go with the stent, distally probably drug-coated balloon, and for the posterolateral branch, I would recommend you to use also drug-coated balloon if possible. Try to avoid double stenting in small vessel diameter.
Yes, sir, that is also similar.
Did you check before, if I understood you right, there was PCI of the right 10 days back, right?
Yes, sir.
Okay, and did you check the right result of PCI?
Yes, sir. Right is okay, sir.
It's okay.
Right is okay.
You go now with 2.5 balloon or what do you plan?
Sir, 2.5 balloon, sir. Just give some dye. Okay, go. 8, 9, 10. Negative. Once again.
What is the balloon you have taken now?
Semi-compliant balloon, 2.5.
Okay.
15, sir. Suit. Ready? Now flow is good, sir.
No, it is opened with some dissection, I think.
Flow is definitely better, but there is a very clear dissection in bifurcation area. So what you could do now, take 2.0, pretylate the posterolateral branch, and then most probably you have to go with stent for the main branch, stented distally drug-coated balloon. Just try to keep stented segment very short.
Sir, yeah. So that upper OM, shall I dilate that ostium part? That will be probably open somewhat.
Yeah,
That
maybe a little smaller size balloon, 2 mm balloon or something. You can keep it to open strategy, then we can think of dilating with DEB.
I would definitely recommend this. Take small balloon to 0 to posterolateral branch and then just to try to keep it open.
Is it possible to do the DCB there because it's that dissection is not flow limiting?
You can try. You can, of course, you can try.
Yeah. Because if we, after putting that DES, probably that OM, we cannot able to salvage because that ostium is very severely diseased.
Yeah, but what you can do, you can use a gel balloon technique. We put it 1.5 balloon, you can overstand and then you can remove it. If there will be no flow, you open 1.5 balloon with 10 atmospheres and you would have still flow into the posterolateral branch, which is from diameter, I think, below 2.0 millimeter, even if you give nitro.
Yeah, definitely.
So definitely nothing for stenting.
So you can dilate the upper branch with a 2 mm balloon now, and then.
Yeah, sir, I'm trying the same.
Okay.
Well, both were.
One learning point for Jacob juniors is once he crossed that, he exchanged to regular workhorse wire because sometimes that stiffer wires could produce trouble distally. So that
what is now very important for younger operators. Try definitely not to lose the wire because you have some dissected areas. If you go again with a wire crossing, then you could go subintimal and then you could have troubles. Take care not to lose wires now.
I think he exchanged with a microcatheter, I think that one before.
Even if needed, yeah. What we can see, you have many doctors in your cath lab they can help you.
Yes, sir.
I think I crossed it a little.
What I can tell you in Germany, in my center, I'm only one operator and we have only one nurse, which brings me all the materials. So we are very, just two people.
We saw you doing a chip case also, impeller assisted PCI.
Yeah.
Only one he and one sister doing, that's all.
But patient is stable, everything is fine with hemodynamic situation.
Yes,
yeah, that's perfect.
Yes, sir. Yes, sir. Ready?
So you probably use it now 10 atmospheres. So you see the flow is much better, looks now
yes, sir.
like after sufficient prodilatation. So now I don't know if you have imaging on the table. You can show us.
Yes, sir. I have the tab
for the main branch, and then we can make final decision. Try to catch this lesion with drug-coated balloon, or even maybe hybrid, maybe distally drug-coated balloon, in proximal part short stent. And again, avoid to lose the wire position. At the moment, everything is looking stable, and you do a very good job at the moment.
Leave wire.
So you have IVUS?
Yes, sir. I have that.
Boston, okay.
Boston, sir.
Yeah, that's good. Any questions from the audience or remarks?
Yeah. Any suggestion, that will be most welcome.
Actually, luckily this went in because you dilated well with the brain. Sometimes these catheters create trouble going, but here I think the latest Boston catheter Fabrigo is also slightly better. I think you can show us the IVUS picture once connected.
Yes, sir. Yes, sir. Yeah. It's on, sir. Can you able to see it?
Yeah, can you make IVUS bigger and fluoro smaller? The technical team? Hemodynamics is not required. Anyway, right. We can see go ahead.
We can see now IVUS. The small caliber distally.
Calcium is there, sir.
Yeah, some fibrocalcific plugs as well.
Still tightest.
Very, very diffuse lesion.
Sir.
So now diameter will be around 3 millimeters.
That's a branch, I think, besides then a vessel.
Now it came into main vessel, sir, probably.
I think there is one more prodilatation needed, maybe with scoring or cutting balloon, or with NC balloon and high pressure.
Yeah.
I think cutting balloon, if we have it, will avoid having too much dissections, I think, if possible. NC balloon could create more dissections because also worried to want to avoid stent if possible to avoid too much dissections.
Yeah, that
if you have a cutting balloon, probably you can
cutting balloon I have, sir. We'll go with that one.
Okay. Is it okay?
2.5 size will be okay. 2.5 size will be okay, sir.
Okay.
Because size I have probably almost 2.5.
Ashish, is it okay if we go to the other lab and come back to you after what you will again come back after 15 minutes?
No problem, sir. No problem. Please.
Okay. Can you connect to Vijayawada?
Vinit, sir.
Yeah.
Okay. See you later.
Yeah. Can you connect to Vijayawada? Dr. Surendra sir, I am Dr. Srinivas Kumar from Hyderabad here. We can see you now. You are live.
We can hopefully you can see all of us, and we can hear you very clearly. And we are very happy and privileged to be part of the ACVS, and I can see both of you guys on the stage. And the case for us today is the orbital atherectomy for calcified ostial left circumflex. I'm accompanied by our extremely talented team with Dr. Krishna Prasad and also Dr. Kamalakar and Dr. Subhash, along with Dr. Raviteja and our talented staff headed by Kamala and Balu and Vamshi. As you can see, this is the angiogram. I hope you can see the angiogram.
No, please play the angiogram. We're able to see you only. Now we see. Go ahead.
Say right. Okay, right. So you can see there's an ostial, this patient actually was referred from outside hospital. He had an angiogram done at an outside hospital in Vijayawada. They offered him surgery, but he didn't want to. And we did discuss with him regarding that also. He did not absolutely want it, along with his two sons also did not want that. So we took as a high-risk PCI. We did in pigtail LV-EDP was 7. So we did not put any balloon pump or anything like that, or MCS-wise. So angiogram, as you can see there's ostial left main, significant, and which will deal with it. And also proximal to mid-LAD, and you can see the ostial circ. By the way, the right coronary had only mild disease, like 30–40%. So we did do a OCT on him yesterday via right radial. The reason we chose groin today was he got his diagnostic cath, as I mentioned, outside facility via right radial. We did the OCT also via right radial yesterday, so we didn't want, he still had a beautiful pulse, but in the future we want to use that. For this reason, we chose groin today. We took 7-train system. As you can see, there is the ostial circumflex stenosis along with the left main. And the circumflex is right after the bifurcation. And then we did the OCT yesterday, and I think you can see it on the screen. There are two projecting
nodules.
Calcified nodules you can see, but they are non-eruptive. You can see the endothelium is there without any exposure of the surface there. And I don't know whether you can see underneath the circle of the OCT, the square area was about 1.25 to 1.5, 1.6. As all of us know, if it is less than 2.5 square area at the place of the calcific nodule, actually atherectomy might be better there so that we can decompress in a way the calcified nodule. But again, the problem, as you all know, calcified nodules can be difficult also to decompress. But the ruptured calcified nodule is easier, but the unruptured, like this one, can be a little bit tough. But again, we want to make sure the lumen is better. And it doesn't matter what device we use, as long as we make the lumen better. So we chose orbital atherectomy. Our goal is to go antegrade with glide assist and come back retrograde that short distance. And we can ablate that and see how the response is, and then we'll go from there. So we already had the orbital atherectomy ready to go. It's just in the left main there. So we're going to advance it at the glide assisted. And then we'll come back in a retrograde fashion for the actual atherectomy there.
Once again, how significant was the LAD lesion in the mid part?
Yes, the LAD significant was mid, and we're going to fix that at a later time. The ostium of the LAD was moderate disease. And we're going, as I said, we did offer him surgery also. We told him about the 3-vessel plus left main. They absolutely vehemently refused, including, as I said, the two sons also were there. We counseled them multiple times, including this afternoon also. So they agreed for the procedure. So the LAD will be intervened along with the left main also at a later time, but ostial left main will fix it today. And the proximal LAD will do it probably at a later time.
So your plan will be ablate non-eruptive plaque, more or less crack and shave method, right? Maybe on top, if needed, you would go with IVL if needed. And then you probably plan to stand from left main to LCX and kissing with LAD, right?
Right. But that's one strategy. And the other strategy, what we talked about was probably we can do the, once the orbital atherectomy is completed, based upon how the OCT looks like, whether we're able to create the cracks. And then we can see whether we can do either a DCB and then do probably left main to the LAD stenting is also one consideration for us there.
I think you saw that orbital just suddenly jumped from the LCX osteum.
Yeah, there
what
was
are the
a
precautions you take, Ferenc, to avoid such
Right.
Yeah.
We didn't see that actually, right? Yeah.
No, we use glide assist to
we use glide assist
not crossing without push. So we use
But it was glide assist, which is low speed, and yeah. But normally you should try always avoid such big jumpings. You are quite deep now in LCX. But please start first with 80,000 low speed, and then you can repeat this with 120. Because vessel diameter is more than 3.5.
Yeah, 3.5 diameter wise there. And again, the intention for the retrograde way is so that, we can avoid the same, the jumping wise. And I always prefer that in these kind of osteal areas. We'll do 80,000 RPM, and everybody who knows me knows I'm not a big fan of the 120,000 RPM, generally speaking. But if need to be, we'll do that. And then we'll repeat the OCT and see how it looks like.
Yeah, perfect.
Yeah, thank you.
So we would like to see this very gentle approach. So you have to be very careful, very slowly. Try to avoid jumping.
Yeah, absolutely. What the plan is to do about 1 millimeter per second, very gently coming.
But don't forget, this is left dominant system, and there will be no flow in left main, or maybe nostril LAD. You will be in troubles.
Yeah, absolutely, absolutely. Absolutely, that's the whole idea there. That's why we measured the LV-EDP beforehand, and we had a venous axis also in case we need to do any hemodynamic support and measurements. Everything is in place.
This is very useful as well to use 7 French guiding catheter. That's very good.
We already had 7 French, yes.
Perfect.
And Dr. Kamalath and KP are going to do the ablation. Slowly, slowly. As you can see there, we're doing it very forward.
The reverse cutting you're doing, coming back.
Coming backwards, exactly. For 20 seconds, we'll do that, and then we'll stop. Come back. Up there and come back, and then stop there. Stop. Right. Okay.
Okay.
Stop there. As you can see, he got developed bradycardia. We'll use some atropine. Yeah, we can give cough.
There is some bradycardia, as we can see. Maybe give some atropine.
Okay, perfect. Yeah, he's back. He's already back. He's coming back. He's coming back.
Yeah.
We give some atropine. He's okay. He's okay. He's all right. He's okay. So as you mentioned, there's a dominant left system. Right there. He's okay. Put him down.
Sir, as it is a dominant circumflex, should we have TPI backup?
Even generally speaking, you don't need to, because that's what we're giving the atropine. I'm not that worried about, because he's back again there. We're not really worried about that. We moved away from the temporary pacemaker a long time ago. We try not to. So we're just giving the atropine. Already, even before the atropine, it came back again. So that's why don't panic. Things will come out. So not to worry about it. Ready? We'll go one more forward.
So please go ahead.
Yeah, mortgage advanced. No, it's good. It's good. Advanced. No. Device advanced. Right. Advance the device.
What do you do now? You lose.
No. Okay, stop. Yeah. What we're doing is now we're advancing the device. Advance the device.
Okay.
All right, we're advancing the device. Now the device was pulled back. Just leave it there.
What's a full send?
I'm got there.
Full send.
Keep going. Go forward. Let's go forward.
It won't go forward. We need to.
Yeah, right. That's okay. Now we can do that regularly. Yeah. No, forward, sir. Yeah, that's okay. Right. Just go forward a little bit. Listen after that. Go ahead. Yeah, we just go forward a little bit now. Coming back again. Retrograde way.
Yeah, we have impression everything is a bit under tension.
Right. It is there backwards again. So 20 seconds. So we'll stop there. Stop. Right. Okay, good. Now we made 2 runs. Now put the device back a little bit. We'll take a small picture.
What I will tell you, 20 seconds is just a general recommendation. You can stop after 5 seconds and keep rewire patients.
You would like to, now that orbital is done, you would like to wire the LAD also now when you're
right. In fact, actually, I didn't tell you that before that we did put in, because initially we thought probably we put in a microcatheter also in case we need to. We are going to wire the LAD. So we wired it before and we took it out for the meeting there. That's what we already done. We're going to do that again.
Okay.
Now, as you can see, we did at least 2 runs. We'll make 1 more run for you. Go ahead. Yeah, go for it. I got it.
I think, you should do 2 runs more and very slow. Try to avoid jumping.
Right. That's good.
And on the way back, probably it will be useful to use
we're going to go very slowly.
High speed.
Come back. Pull the guider back.
It's jumping a bit. Yeah, that's difficult. Yeah.
Not that much. You don't need to. That's good. Come back. I don't know whether you can hear the audio sound.
Maybe one remark to you. One remark to you: if you have jumping, maybe just stop and check the flow, because if you have jumping can produce a huge dissection with no flow, then you will be in big troubles.
Absolutely. We don't want to be there. Yeah, this flow is good, as you can see.
Okay, yeah,
Yeah, right. Mhm.
very good.
I think you can remove that now and wire the LED,
LED,
then secure.
and then we're going to the OCT with the sir.
Yeah.
Exactly.
So the
I'm
question.
a little bit old-fashioned. I usually do it, in a manual fashion with the wire. You can do with the glide assist also.
As that we have seen the important step, we'll go to the other lab and come back to you, sir.
Sure. Yeah. Okay. No problem.
Okay.
So can we change now the cath lab?
Yeah, Vineet, we are with you now. Hello. Doctor, can you change to the other lab?
Yes, sir.
Yeah. What have you done? Can
Yes,
you?
sir, am I audible?
Yeah, yeah. We can
Yes.
see you and.
I have dilated. I have dilated that main OM with a cutting balloon.
Okay.
It was 2.5 at 3.0.
Yeah, 2.5.
2.5.
Yes, 2.5, 2.5. Back.
And finally, you can show us again IVUS after cutting balloon dilatation, and then we have to make final decision: stent or drug-coated balloon, or maybe both.
And that other OM also ostium that I have dilated again 2.5 balloon, sir, because it was not looking good now. And this OM, I think it
Now it looks better.
will do the DCB.
Yeah.
Yes, sir. I've just dilated with drug-coated balloon.
To
that
upper branch.
Upper branch, yes, sir. Upper
Okay.
branch. And this is the image after that. Just saw the last image again.
What is the balloon you have used? Which drug-coated balloon you're saying? 2.5 into 30. What is the balloon?
Yes, sir. 2.5, 30. Magic touch, sir.
Okay.
Yeah. Give the IVUS.
That is looking good now. We can work on the lower branch.
Relatively compared to earlier.
Yeah, there is still some direct behind bifurcation.
Yeah,
There was
below the branch.
below the bifurcation. There is some
But people
flow
who advocate
limitation.
DCB are advocating even a significant antenocolumn and all says after dissections also sometimes they tend to heal if you do it
Yeah.
with DCB.
Yeah,
Especially when the stent is there inside. You're working in the stent, I think little amount of dissections intra-stent.
For me, at the moment, I would just would like to take a look how it looks in IVUS.
Yeah.
And then finally, at the moment, my impression is we can go distally with 2.5 drug-coated balloon, and for proximal area, probably with a short stent.
Okay.
But we will see how it
Yes,
looks
sir.
in
That will be like
IVUS.
that only. Yes, sir.
So the patient is not so old, right?
No, sir. Patient is old little bit. He is 80 years, but he is very
80.
active.
Okay, that's I think
80.
80, so it's quite old.
Yeah. Start.
Our patients are also gradually simulating the West and the German patients.
Yeah.
So what are you doing next? IVUS, huh?
IVUS, sir. Yes, sir.
Okay.
Just make the IVUS images bigger if possible. Can you see, sir?
Yeah, IVUS bigger. We are seeing the angio bigger. Right. Wait, we can see it now.
Distal part I have not dilated, sir.
But this is definitely very small vessel, below 2 millimeters. So now it's going to be bigger. There is some clear dissection here. It looks like
The stent, I think that will be there. Okay.
The stent and
Stent and distal DCB.
yeah, I think this will be probably the best way. At least here, look
it
here.
looks better.
That's not so bad.
Here it looks better here.
In which position it is just at the moment?
Proximal to.
It's now proximal to the side branch.
Into main branch. Yes, main branch. Which main branch, sir?
Oh, yeah.
Stop.
Yeah, there is definitely very diffuse
Only one
disease.
concern is there. Yes, sir. Only one concern is there. After putting the stent, probably that upper branch of OM might not.
Okay, I think if you plan to do DCB, it's up to you. You can do that and then see.
sir.
There's no problem. Suppose if you
I think it's agree.
his worry, he says, is if you put stent across, he might close that upper branch. That is
Yeah,
his worry.
that it was my suggestion to take a 1.5 balloon and use it a jail balloon technique.
Yeah, if it closes, you can work on that.
Yeah, you can open again and then you have at least flow. So what is your final decision?
Having put one stent.
Yeah,
upper
at least
proximal
here
joint.
from the quality which we see here, it's difficult to make a decision for us. You have a better quality of imaging.
Because that still
Okay.
it is very much hazy there, sir.
I think you can cover that proximal hazy portion to normal segment, just cross it till that normal segment and stent it, and we'll see your final result after that.
Okay, so we switch now back to.
That we can have. That one doctor has a flight, he says. We'll just briefly finish his talk in 10 minutes.
Okay.
Then come over. On this come. What to do? And there's all. You can break lab and we'll have his talk, then we'll go to them.
Good afternoon.
Instant restenosis management
First of all,
with
I
drug-coated
thank-
balloon. Welcome.
Good afternoon. I thank the organizers ACVS India, especially Dr. Srinivas Kumar sir, for this invite. So, you know that ISR more than 50% by angiogram or intravascular imaging carries the most challenging for the interventional cardiologist, more MACE events. In US, 10% of PCI done for ISR, but when you go to the European data, it comes from a small survey, 5%. ISR is not benign. You have worse outcomes when compared to de novo. The MACE events are higher at 3 years, and it could be a patient-related factors like diabetes, CKD, or could be a bifurcation, thrombotic lesions, or by cardiologists. What we can do is to avoid undersizing, underexpansion, better to oppose and avoid edge dissections, and all these means stent fractures by means of imaging. So imaging is a must for ISR to find out the type, whether it's a neointimal hyperplasia, neoatherosclerosis, or stent fractures or underexpansions like that. There are a lot of classification, angiograph, OCT, IVUS, and Waxman calcifications. So the DCB, this proven in two is one is an ISR and another is small vessel disease. So the DCB approach is pre-dilate 1:1, long balloons, longer inflation times. If not, go for specialty balloons. If needed, laser or atherectomy devices. Finally, look for less than 30%, no flow dissections, or FFR more than 0.8, and Asia Pacific document says more than 0.75. And the lesion preparation is very important because the TLR rates are decided by the lesion preparations in the DCB, whether you use a NCB or cutting balloon or a specialty balloons, the lesion preparation should be adequate. And this is one which shows that clearly the residual stenosis, the correct DCB to the stent vessel size, and the longer inflation, at least 60 seconds, carries the TLF rates lower. So the options are either POBA, DCB, repeat DES, or atherectomy. And so we'll see that DCB clearly shown in BMS ISR to be better. And this 2018 guidelines and 2024 as modified, but still the European guidelines says DES for DES ISR, but still DCB can be used if the balloon angioplasty brings a good result. So the DCB can be preferred in either a de novo lesions or ISR. It's a common sense. You have multiple stent layers. Definitely there is no role for next DES. If there is under expansion, better do it with a good expansion with NC and put a DCB. And if you have high bleeding risk, again, DCB scores. And especially ISR involving major branches, do DCB. And even fast ISR, even though ESC guideline says does, you can try DCB if the preparation is adequate with either LCA or with IVL, and you can have the chance of again DES in the future. And this is what the flow chart goes that. So we'll go through few cases that 67 male diabetic hypertension, non-STEMI, had a PCI2 LCX. This guy comes with chest pain, and you can see that the LAD is showing a 90% lesion with multiple diagonals, 1, 2, 3 diagonals hanging. So I did a OCT imaging, and you can see that the run of the OCT. And you can see that there is eccentric calcium and in the fibrocalcium, fibrotic plaques. So with this, took a balloon preparation with 2.513 aperture and inflated at 16 atmospheres. And then look at the recoil for waiting 5 minutes, and it's not there, went ahead with 2.7520 depth. And you can see that all the diagonals are well preserved, even though it's a proximal LAD, and you have to wait at least 5 minutes or up to 10 minutes sometimes in the lab. So in DCB, it is more of the preparation and looking at the recoil and the flow limiting dissections, which decides the prognosis. And this is a 77-year-old male, diabetic, non-STEMI, TROP positive, had adequate LV function, and RCA is okay. And you can see that the LAD had a proximal LAD at the close to septal has 80% and the diffuse calcium. So the OCT run showed that not only the calcium length is more than 15 millimeters, but also the arc of the calcium is thickness is more than 800, 900 microns, and the arc is more than 270, 360 degrees. So I started with LCA, saline lacing. You should be very careful in doing the native arteries. LCA use, you should do only saline lacing, and contrast lacing is off-label. I went with 60-45, the total pulse 11,400. Then initially I was not able to even track a semi-compliant balloon. After LCA, able to take the Scoreflex balloon down and prepared, and then OCT run was taken post-laser scoring. And you can see that the LCA has done the work, and you can see the dissections also, and it has modified the calcium. So since thought that is a long calcium, may not get adequate expansion, so we went ahead approximately with 2.75, 25 DCB and got a fairly good result and left that. This is in 4 months follow-up, the patient's doing well. And this is a 67-year-old male, a chest pain of 1 day, had a ACS, had a PCI2 LAD, RCA, diabetic hypertension. You can see that there is a mid-LAD stent showing that mid part of the stent having a thrombus with so the lesion prepared with aperture, then took a OCT run because imaging is a must in ISR, either use IVS or OCT. Want to know what is the pattern, whether it's a neointimal hyperplasia or under expansion, or it is neoatherosclerosis or edge dissections. Imaging is a must because once ISR, the chance of next getting ISR is 20% and third is 40%. And there is a gross under expansion is shown on the proximal edge and the under expansion in the mid part of the stent. So again took a LCA, the saline blood lacing and even a contrast lacing because it's inside the stent, and that OCT run was taken post LCA. And you can see the lacing effects on the 11 o'clock positions and in the 12 o'clock and all these things, and then went ahead with 2.5, 25 DES, and that was the final result. And this is the fourth case. A diabetic had a PCI2 LAD in 2020, 3x30 DES at Gulf. Stopped the DAPT antiplatelets and all the drug statins for past 8 months and landed with a E of 35%. RCA had a moderate to severe disease in the proximal, and you see the proximal LAD, you have a 90% lesion. So without pre-dilatation, direct OCT was taken. Predominantly, it was a homogeneous ISR, neointimal hyperplasia, had some calcium also. So the segments. So what I thought is, being middle-aged and having a proximal LED stent, if you want to put again a DES, it should be from LM to LED. So went ahead with lacing. So first it started with saline and then went with contrast lacing. The contrast lacing produces the shock waves more than IVL 120 atmospheres. You can do it inside the stent. And so after that, contrast lacing check was done, and then went ahead with this was the OCT after lacing. You can see that effects, and then prepared with 3 scoring aperta, and that was the final OCT after scoring before DCB. That was fair expansion MLD, and you can see that from 1.95 it has grown to 4.96. So final depth was done with 3.5 into 25 millimeter. And that's the final result. Thank you.
Maybe final question, how often do you use laser for in-stent restenosis, and when? When do you use primary laser for lesion preparation?
For ISL.
Yeah.
See, I have done more than 22 cases the past 1 year. What we see is, if you use ISR for laser, and especially if you can come out with DCB, but more of ablations, and also after laser, if you do with a scoring balloon, you're able to get a good lumen gain and can come out with DCB. Or even if you're going with DES for DES, the sandwich is very less once you do with LCAM.
Right. Okay. Thank you so much.
Thank you, Arnachalam, for adjusting and doing this talk. As we see such cases, we get more confidence. Otherwise, we keep thinking that dissections, if we leave, it could land in trouble. Post ISR, it is okay because stent scaffolding is there, but otherwise, native vessels, sometimes the proximal vessel leaving like that, we feel a little odd. Thank you for sharing your experience. Thank you. I think we'll go to lab, whichever lab probably, on the orbital atherectomy. Sushil, can you join here? They're taking 15 minutes to join.
Yeah,
the US.
we are here.
Yeah. Can please, we can see and hear you, sir. Now.
Right, good. So we did after the orbital atherectomy, we have done the OCT, and I can show you the OCT imaging there. And as you can see, let's play the OCT. Come down and come back. Yeah. Right. I think you can see the OCT. And the nodules are more or less effectively ablated. And obviously, so let's play it slow, Ramesh. You can show the OCT-induced OCT-induced cuts also. You can see that. What you can see, the nodules are done, and you can see those smooth cuts, like almost like a convex shape there. And these are all related to the orbital atherectomy. And then we did with an NC balloon of 3.0 by 12. And then we did the DCB with the 3.5 by 15 also. I guess the company is called Cardiovascular. And that's where we are at this time. Patient's hemodynamics are stable and he's doing well. And then we're going to see how it looks. We didn't check the angiogram yet. And then if needed to be, we'll stent it. If otherwise, we'll see how the DCB course will be. And then we'll figure out the left main to LAD intervention also afterwards there.
So your personal idea is to go with drug-coated balloon for this large ostial circ lesion?
Yeah, yes, for the ostial circ, we want to do DCB, and then if there is no obvious dissection there, there is no dissection, then we'll do the stenting also. If there is dissection, we'll do the stenting. Otherwise, he's doing okay there,
Other option is if the LAD also is diseased, from left main to LAD we stent and put a DCB to L6 ostium, the bigger size.
Absolutely.
Yeah,
that's what the plan is.
The other option.
And then that's what the plan is. And then we can recross again and do the DK kissing again there and see how they respond. That's another option there.
The injection
and as you can see, this is the post DCB injection. Then the flow is good in the circ, and then there is no other problem at all. It looks pretty good. Then we're going to fix the left main to the LAD also subsequently. Then we'll just do that in a few minutes. The ostium of the LAD we're going to do with the Cepal technique also. That's already planned.
So go ahead, and we would like to go for a second to the second cath lab just to see final result.
Okay.
You want us to go there, sir, or you want to stay with you for some time, whichever?
Right, it's up to you there. Then you can you want to stay here, or you can go back and come back to us again. We'll show you the final picture.
Okay, 5 minutes. We'll go there and come back, sir.
Okay, sure, no problem. All right.
Can you connect to partner, please?
And అట్లా కేసు అట్లా చేయకూడదమ్మా. మీరు చూడండి ఇలా.
Can you connect it, disconnect Vijayawada and connect partner?
So we would like to have now a final result for LCX PCI. Can you hear us?
Yes, sir. Am I audible?
So what was your final strategy? Did you put stent?
Yes, sir. Stent I put the proximal, sir, and distally I have done one drug-coated balloon.
To be honest, we have very poor quality of the angio. We have very poor quality of the angio pictures. And now it's a bit better, but
the result I can able to achieve. Distal also I just put one drug-coated balloon.
Yeah, that's very good strategy.
On a stent.
What we can see, there is still flow in posterolateral branch.
Yeah.
So this will be, from my point of view, very good result.
Very good result, actually. Proximal thing is covered with stent, as you said.
Yeah.
Distally, he did a DEB also to the branch of the smaller one. Very good.
Congratulations to you and to your team, and thank you so much.
Thank you.
Yes, sir. Thank you for giving me the opportunity to solve my cases.
Thank you.
Actually, when it was dissected, I was thinking I may not able to cross, and it was very short time, but fortunately I can able to cross.
If you do with good intention, God will cooperate with us. Don't worry. Okay, thank you. Congratulations again.
Thank you. Thank you.
And now we'll go to. Thank you.
Thank you.
Sir, Surendra sir, we are back with you. We saw the final there.
We're going to the Sepal technique there for the left main to the LAD now. And then we'll see how things are. And if need to be, we can always, circumflex looks all right on the DCB. And as you know, the restenosis rate with the circumflex stenting is almost, one of the worst worst restenosis that you can see. So we're trying to avoid it. And then we'll see how much lumen is there. And, still we had a little bit of, you can see it didn't expand as best as we thought it would be. So we may have to do the stenting also and then come back again and do the left main to LAD. So probably our thought right now is to go ahead and stent at the circumflex ostium and then do the Sepal for the left main to the LAD. That's what our plan is.
All right.
Go ahead. Go ahead. Yeah, go ahead.
So you are now.
Push the Sepal. That is okay, Daddy. That is. There was contraction. That's right. Yeah.
We'll come back and come back.
We'll come back in a second there. And I think, his blood pressure came down. Pressure is okay. He's not any pressures there. And we'll give. Yeah. Another better. He's stable. He's sleeping. And wake him up there, please. Yeah, he's sleeping. Yeah. Give me atropine.
Okay, dear Ivan.
So you just put it one more wire to a marginal branch.
A marginal branch there. So that probably that gives us the landmark also. And right. And his pressure is about 100 so systolic. You can see on the screen there, about 90 is probably. And we'll give him a little bit of norepinephrine to make sure the pressure is good. And all right.
So again, the question is the flow in the circ perfect?
It's good. There we can see, yeah. Right, the flow in the circ
otherwise you have to stand from left main to the circ.
You can see the pressure in the circ is there. And
don't lose circ, otherwise.
Right, we're not going to. We're not going to. Yeah, we're not going to. We'll do the stent of the ostium.
We can just stent left main to LCX and fix it, and then we'll see.
Fix it and then come back to the LAD. That's what we're going to do now there.
Because patient is becoming unstable.
Can I have unstable? Yeah, 3 point. Can I have a 3.5 by 18 or 23 stent, please?
Yeah, that's a good idea. Yeah.
Right. That's what we're going to do quickly there. Better sir.
Yeah,
3.523, please. Which is
that's for sure. That's really dominant LCX system, left dominant system. You need to fix.
Yeah, his pressure is holding on there. He's sleeping also. So, which is circuit? Look, sir. All right, okay. Okay, the stand ready. Flush it, please. There.
What will be your plan B if the patient?
We're going to the left main to circ stenting, and then we'll deal with the LAD subsequently.
What you can do, you can now go from left main to LCX.
LCX, and then we'll deal with the LAD.
Rewire to LAD, and then you can still go with DK culotte for LAD if needed, or maybe even with drug-coated balloon. It depends.
Sure, yeah.
So now take a look. It's very important to place the stent perfectly. Go to LAO cranial, please.
Right. Go ahead. Come back.
Yes, this is
good. Let's go ahead and do it.
Don't miss the left main ostium.
That's it, right. Yeah, we are in the we're a little bit in the aorta. We're at 12. Watch the pressure. Okay, right. We're down. That's it.
Okay, take care. There is probably now a bit protrusion. You can make some shortening with the guiding.
Right. What's the pressure there? No?
Very easy to do shortening because you have here 3 wires.
And wake him up, Amma. Every anesthesia.
Want to give him time to.
Pressure, yeah, pressure.
Okay, then.
We have to reverse the anesthesia here. We'll be right back with you.
We'll be right back. We'll leave to work. We'll come back to you.
Yeah, I'll come back to you. Right, yeah. Okay.
Just make your job.
Sure, yeah.
Can we stop the transmission?
Yeah, can we try that? Right?
AV, please.
Okay, so I'm not sure. Do you have one more lecture in background? What we could do now? They have some.
So maybe we'll come back to a lecture.
Yeah.
So it's something what can happen even in live cases. So the question will be, guys have now femoral access, which is now a good thing because you can go from femoral access with ECMO if needed. And there is still ongoing resuscitation, at least in my cath lab. We would go then with ECMO, stabilize the patient, and then continue with optimal PCI management.
What do you think was maybe it's worth a few minutes to debrief on the case. What do you think happened? Because the pressures have been stable for a long period. I mean, I missed the beginning part of the case.
The problem was, I think it was they spent a lot of time for lesion preparation, and they lose it probably the flow in the marginal branch, and this was the continuum of prolonged PCI, and then final stent probably. They put it final stent very fast, as you saw, and there was some protrusion of the stent into the aorta, and most probably they occluded now LAD, and that's why it's pressure is going immediately down. So they need now probably to put ECMO patients on ECMO. This is what I would do now in my cath lab.
Mm-hmm.
Now the question is, do we have one more lecture between?
Yeah, they're just checking.
Any comments from the audience?
What is really important in such situation, if there is a patient doesn't has pressure, it doesn't make sense to put impeller, right? The only chance is to go with ECMO. Then you can rescue the patient. Otherwise, there was no chance.
Yeah, I mean, at this point, it turns into a hemodynamic case, right? You got to stabilize the hemodynamics, ECMO, get a blood pressure, and then you can go back to do whatever is necessary.
I'm quite sure if they will be able to rescue the LAD. So then they have LAD open, the main branch of the circ will be open, then they can go ahead. Because marginal branches is a secondary topic now. The LAD, the flow, perfect flow in LAD is now essential for this patient, for survival. You know?
Right.
And imagine if you have 6 French radial, then this will be even much more disaster. It was clever to go from femoral access.
So you would give up the guide and everything at this point and go on ECMO first and then regain access?
I think we would go with compression, with mechanical compression. We have some devices for that, just not to make interruption and then prepare ECMO. ECMO in this situation will take, at least in our center, something between 12 to 14 minutes in this setting.
So in your center,
we have a team. We just had one call. So there's this ECMO team will come, including surgery guys. And during this time, we do punctures, wiring, and then in 10 minutes later, we can go ahead with ECMO.
Well, just to clarify, you would give up the guide and do ECMO from the side that they have access, or you'd stick the other side and get access?
Probably, if possible, in this situation, probably I would just try to canalize vein. You need vein access, and just not to lose the time, cannulate the groin, which is now sterile at least. You know, you don't lose 2-3 minutes time, and everything is sterile. Just go with the ECMO. If the ECMO is working, then you have time to cannulate the left system, or you can go from brachial or whatever, right?
So, Srinivas, let me ask a question here. In India, PCI is done in most centers where there's not cardiac surgery. Yes. The availability of perfusion, ECMO in these environments and these type of cases, like what is the strategy?
But I hope this center...
This center has everything. The CABG is set up too. It's a medical college, NRI medical college.
They have all options.
But generally, as you said, what I feel is in centers which such facilities are not available, you should avoid doing left main.
No, I mean, that's my point, right? So this case, you know, anything can happen. So a case like this should be done in a center where there's cardiac surgery and ECMO.
Yes, definitely.
Yeah, they have everything there that's set up. Probably we didn't see, but one more important thing I feel is when you're working on a vessel which got affected and the other non-infarcted vessel gets into trouble, that's where you have trouble. So probably the original plan of stenting to left main to LAD and then doing this would have been okay, but once they stented from left main to LCX, something LED which is not ready, that flow must have gone down, then they must have landed in trouble. So
it's also this ischemic spiral. If you're hypotensive for a period of time, your LVEDP goes up, coronary perfusion gets worse, and you get into this vicious spiral. And I think managing hemodynamics during PCI is something that's not often appreciated until it's too late, right?
Exactly.
If the blood pressure is 130 most time and it's drifting, you know, stopping or figuring out what's going on and trying to get a blood pressure up, giving norepi early to maintain a perfusion pressure, I think is critical, because that perfusion pressure will maybe help avert that ischemic spiral. We see this in structural heart quite a bit as well.
Exactly. I'm not sure they exclude pericardial effusion, because this, after ablation and some maneuvers with wires, can still be essential to exclude pericardial effusion. But I think the problem was occlusion of marginal branch and LAD, so there is definitely need for probably ECMO. Yeah. If they can manage in 5 minutes to open LAD, it's fine, but otherwise only ECMO.
Yeah, no, I agreed.
Any questions from you? There was one question. Maybe you can come here to the micro. To get micro. Yeah, Michael. Switch on.
Switch it on. The mic's not on.
To begin with, it's a complex case. It's a left main
It's a left main, and also we are doing the atherectomy. If I had to do in my lab, probably I would have done with the Impella pacemaker support.
Yeah, that's a very good question. This is a complex anatomy. This is a distal left main lesion. And there is, I don't remember how was LV function. I think it was good LV function initially, but finally, the question is very good. Should we perform this case as a protected PCI? So patients is on.
Did they do a right heart before? I missed the beginning of the case. Did they do a right heart at the beginning, or?
Me personally, I would go without Impella in this case.
But did they do a right heart?
He said LVDP is normal.
Normal. Okay.
Yeah.
So you would not do this as a protected PCI case?
No, in this case, definitely no.
So can I ask the question then? So you obviously have high volumes. Should individuals that maybe not have high volumes or in centers where there's not a lot, is it safer to do it as a protected PCI or less safe?
Yeah, it will be definitely if somebody is not extremely skilled in left main PCI, and then Impella protection will be very helpful here for sure, because this they could have time to rescue the flow in the LAD. But to do this under compression, chest compression, it's very difficult for. I personally have done now 26 such PCIs under mechanical compression. That's manageable for me, but I'm high volume operator, you know. But if somebody is doing maybe 200 cases a year, maybe it's not enough.
Sir, I have one question, sir. Anyhow, this is a high-risk PCI. We have seen commonly, like in our practice, those who are having an arrest in a cardiac table, it is quite difficult to revive him most of the time, because this is a case we accepted. In some cases, most of the cases, whenever the patient got arrested, for any reason, it is quite difficult to get him from that time to the reviving is quite difficult.
Listen, in this case, what doctors can do, what you can do in this case, there was one wire, now two wires are behind the struts, right? And the problem is, what I believe, there is a LAD compression. What you can do, you can take new balloon, let's say semi-compliant 2.5, and go to LAD behind the struts. Yeah. Open then with 10, 12 atmospheres, and then you can restore the flow. This, I'm not sure they can they have done this approach. We will see. But this will be very helpful for you to restore the flow. If you restore the flow to LAD, and the stent to circ is open, at least partially, then you can achieve hemodynamic response. So
you would quickly crush the stent. I mean, is that the safest?
Yeah, you can crush. Finally, you can crush, definitely, and go with it will be long segment crush, but it's not a big issue.
So this stent's hanging out quite a bit. I'm just asking the question. Say the stent was at the ostium, just throwing out something else out there. Can you get behind it and do almost like an SKS and try to restore flow quickly?
This will be option. This will be definitely option.
Okay.
Yeah.
Yesterday during your talk also you showed that put a wire behind the stent and then take the balloon if it accrues.
Exactly.
That's what I keep telling.
Because I think it's important from a learning perspective. What is the easiest, safest, quickest way to restore flow? If you say you've got a picture and you're convinced that the LAD is down, the simplest thing is to get
I would go with a marginal branch out into the guiding catheter and try to get this wire through the distal strut through to the LAD. If this should work
how long do you try?
I would try maximum 20 seconds.
Okay.
And not 2 or 5 minutes.
I think that's important because you can go forever trying to try different things.
If this doesn't work, then I would tell my catheter team, bring me new 2.0, 2.5 20 millimeters semi-compliant balloon, and then go behind the struts, partial crushing, but then you restore the flow to LAD.
And then do you just get a stent and keep that flow?
And then you can even go with a stent, crush the first stent. Usually you will have still some flow to L6, and then if you restore the flow to LAD and you have at least partial flow to the main branch of the circ, you will rescue the patient.
The only reason I talk about the SKS strategy is, so if you crush and there's some issues and you got to rewire, recross, and complex in a patient that just arrested, is it simpler acutely to just say, try and get SKS type stents here, let's get this stabilized, get the patient out of the lab?
This will be still a rescue option, right?
I'm just trying to figure out from people that don't do a ton of cases, this scenario happens. You're not looking for the ideal long term now. You're trying to save the patient, get him out of the lab.
That's correct.
Yeah, and so whatever's the easiest.
Actually, the patient was giving enough signals to take care. Pressures went down in between. He had some problems. He was telling patient is sleeping and all that.
I think they spent too much time, and that was a too long procedure.
So can you use the mic? We can't.
LAD, the thicker catheter, the guide was 7 French. The left main, when it was going inside, I think it was occluding the entire flow.
I see.
And that's a
What
problem.
you should know, if you take 7 French guiding catheter in the standard normal left main, it's making a 30% stenosis. If you have left main lesion osteally, maybe just 40, 50%, it looks not bad, but you put 7 French guiding on top, then you can have really significant hemodynamically significant lesion.
Yes.
And this is what here happened probably.
He must have taken 7 French because he thought he would do a 2-stent technique if required. That's the only time where we might take 7 French. And one more thing we would have done differently in the osteal lesions is generally avoid taking XB3 because it tends to deep suck in, and probably take a JL to not to go deep into the ostium of LAD. And but he thought 2-stent technique, that's why he must have taken 7 French. Generally, we avoid taking 7 French. Most of the times we can get away by doing a 6 French.
Srini, one question for you.
To be honest, so I do really many left mains, so minimum 250 in 1 year. So I definitely try to get 7 French guiding catheter for left main.
It's 6 and 7, that is slender catheters, I think.
6 is okay, but it's better to have 7 French, if you ask me.
7 and 6, that slender sheath, I think we can still go through radial, I'm saying.
Yeah.
Radial
But how much of your left mains are radial versus femoral?
You mean left mains?
Yeah.
If I have to perform elective left main PCI in a man, then I take radial 7 French. And small lady, 7 French radial is a bit too much. Then I go via femoral or brachial. What you can do, I don't know how many of you have done, if there is a difficult axis in the groin, if the radial pulse is not good, take an ultrasound and go ultrasound guided puncture from brachial artery, which is usually 3 to 4 millimeters, and you can occlude with Femosil. I have now done more than 20 cases and no bleeding ever, no occlusion. So Femosil in brachial artery is working sufficiently. This is very good tip and very helpful.
Srini, I have a question for you.
Yeah.
In the US, what happens is whenever we want to do the procedure, we don't think about the finances. We want to impella, pacemaker, everything is available in the lab. Is that for when we do the procedures here, because we have talked to the patient, it's very expensive. That's why they have a higher threshold for using all these support systems?
Yes. I think when you're doing complex high-risk procedures, this financial stress should not be there on the operator. What is best when the already patient is able to afford, then probably you can plan some left main, other complex procedures. Especially, please avoid using all the another re-sterilized material because that tends up using more resources and your efforts too. So where the procedural, there is financial challenges, they can always guided to go for surgery. If the suppose patient is comfortable in everything, then only take up such high risk complex procedures. That will avoid a lot of stress on the operator too. Otherwise, you need to conserve cost also. It's a big problem. So we generally advise like that, unless patient is fully conscious of his costs and not bother too much about it, then only we should take up high risk procedures. I think Srinivas Poturi said he will be ready by 3:50. Ojal, can you check and connect him onto the lab? We are eagerly waiting to see his case. We unfortunately rushed to go on time to him, but now the other lecture person has to leave early, so finished early.
So we have now nearly 4 o'clock.
Yeah, I think Ujjwal, can you connect them? We can start from the beginning of the groin. I told it's okay. Yeah, he's connecting. 1 minute. I think anybody has any questions or comments on what you have seen before in the conference. I think last lecture will be on acute stroke interventions. The other new therapy which is coming up is where the cardiologist also should get in, because not many interventional and neuroradiologists are there. Many neurologists don't do those procedures. I think that have been my passion since last 8-9 years in our TCT ACVS meetings. We have been conducting stroke workshops and pre-conference workshops too. A lot of new materials, new procedures are coming up. Initially they were expensive. Now some Indian modification, Merrill is coming to that also. And then it's becoming cheaper. There's nothing like if you can avoid the patient becoming paralyzed totally. And nowadays in the era of TAVR and other things where you immediately get acute stroke, then becoming comfortable and doing some procedure, removing immediately thrombectomy, all that goes a long way in preventing residual damage to the patient's brain. Actually, neurologist seniors used to argue with me saying that brain is different and all that. I said, as stroke is a vascular occlusion, it has to respond once you remove the thrombus or clot. That's what is now the trial showed. Initially, they said it will work only for 3.5 hours, later 4 hours, 4.5, then 6 hours. Now, the latest study showed it might work even in 24 hours, but provided you do it faster. The protocol now in Apollo stroke, the stroke protocol gets activated faster than our acute primary PCA protocol. They removed MRI from the protocol because MRI takes quite long time. So they take into CT, rule out any hemorrhage, and then sometimes CT perfusion is possible. Even if it's not possible, still the patient is reeled into and then taken up for procedure. So that's how I think patients are getting benefited with stroke index. We have Suresh who is about to join us to deliver his experience, share his experiences about 250 plus cases of stroke intervention. He thought his lecture would be slightly later, that's why he's just joining. And meanwhile, we'll have your question, please. Go ahead.
What is the incidence of late coronary aneurysm with drug-coated balloon?
I don't think there's any definite data which has come up already because recruiting balloons itself are coming new. But
I personally saw only few cases. So we use now around 1,500 drug-coated balloons per 1 year in one center. So I use it every day. If I just follow last 3 years, maybe in one case there was some aneurysmatic change, maybe according to drug-coated balloon use, but it's not a big issue at the moment. Not clinically relevant, as you can say. There is a very dangerous signal.
And when we do routine angiograms after 6 months or so, something to have a check, because one of our seniors case actually presented with an inferior STEMI, circumflex. It was a double vessel disease. Circumflex was the culprit, addressed. Planned for a staged angioplasty, discrete lesion, distal discrete lesion, and he convinced the patient to come back. He was a high-profile policeman also. He put above an agent like this in the mid, and then overlap like this in the distal. And after 6 months, when he did an angiogram with the OCT, huge aneurysm here, another aneurysm in the exactly place where he has kept the depth, and the place where he overlapped that became severely stenotic.
It's very, very unusual.
That one agent above paclitaxel, another is a prevail paclitaxel. So
maybe you had small dissection and maybe some hematoma, which...
No, that procedure has been done with OCD guidance.
Okay.
Everything has been ensured that nothing is there. He's a very high volume OCD operator.
Okay.
And then when he went back and then read the literature, actually, who routinely does angiograms, that might not be clinically relevant actually, but then when we do routine angiograms, probably we'll be able to pick up this.
Actually, it's also important not to reuse material sometimes in periphery where these things happen. Infections also we do see come leading to aneurysms. That becomes a very challenging situation where we might need to take the help of surgeons to excise that bit of coronary artery. Otherwise, there's infection, myocardic aneurysm, you try to seal it again, you get into more trouble. So we do see such cases occasionally where the patients come back with aneurysm, but that is a different, totally avoidable cause for aneurysm. That you can't say it is attributable to disease. But very rarely we have seen without any per se with drug-eluting balloon leading to aneurysm. I have not yet seen. I think.
So we have now connection back to
Surendra sir, you want us to back?
Did they want us to come back?
Ujjwal?
Right, yeah, we are here. Go ahead. Yeah.
You wanted us to come back, sir, or is it okay?
Yeah, you can come back there. You know, what happened was, yeah, go ahead. Can you guys hear and see us? You know,
yes.
He got respiratory problem there. He got a little bit more sedation from anesthesia colleagues. So they have to take care of that. Then he stabilized without any problem there. That's what the whole issue was. No, right. And then we are we did the part already for the left main to serve. And then we recrossed again to the LAD, and then we're dilating there, and then coming down.
He wants to see the coplanar.
Right, you know, and then go ahead. That's okay.
So what is your plan now to
Now we're going to do the Kula type to the LAD to the left main, and then we'll do the circumflex re-intervention again there. That's the plan. And he's stable, and hemodynamics-wise, rhythm is good. And, yeah, go ahead.
Yeah, that's fine.
That's good. Yeah, he just mostly respiratory issue there, you know, because he got both fentanyl and Versed. Yeah, right.
USA is also ready.
Ready there.
Okay, great.
Yeah, you know, yeah, he's doing good.
So good, sir. Very nice to note that.
Can we just see an angio of the one before where what your last picture before this?
Yeah, we'll take it now there if you want. Yeah.
It will be very interesting to get a spider view. Can you go to spider view?
Yeah, we'll go there in spider view. Spider. LA will call. Is the lady, no? Yeah, we'll just see her there. Yeah. Ready? Ready? Connect?
Okay, the left main circ are very nicely fixed. The question is now, would you go now with culotte to the LAD? I think this will be very useful.
Right, that's the plan. And then obviously we'll recross the circ and then kissing balloon. You know, that's the plan. Yeah.
How much of the stent is in the aorta?
Not much at all there, and actually you can see maybe a millimeter at the most, half a millimeter to millimeter at the most. We didn't flare it, we just did part a little bit, and at the end actually we'll do the much more flaring again one more time afterwards.
That's good.
Very good.
Yeah, you can see the left main and everything looks good.
Yeah, the question is good from Sushil, because if you recross, you have to take care not to go between struts and ostium of the left main stent.
So too much stent protrusion happens, that should be careful, right?
Yeah. That's what exactly right, you know, right. But it looks good, and actually there, in fact, we were able to engage the left main also very well.
If there will be difficulty with the crossing, I would recommend you to use double lumen microcatheter, which will
right. We'll take it there. We'll give it a try here, there.
Yeah, very good.
So I think we're going to move on from you. We're very fortunate, happy to see that things recovered in a nice way. So I think that was great. We're happy. We'll let you finish up here.
Thank you so much.
Thank you so much. Nice day. Congratulations. Thank you again.
Thank you. Bye-bye.
Thank you so much.
Thanks.
So if we can cut this transmission, we're going to go in a second, but I'm glad we got follow up from that case and everything as well. So you want to introduce the?
Yeah. I think Srinivas, I am Dr. Srinivas Kumar. I'm joined with Sushil Kodali, whom you know, and then Miroslav Farang from Germany. All of us are waiting eagerly to see the new procedure from you. Sorry, we had troubled you little to start early, but you're on time. And the entire 1 hour is with you. Whatever you want to show, we are with you. If you want us to break in between, we can have a lecture break. Otherwise, we'll be with you throughout. Please take us through your case, and Sushil will be interacting with
whatever I would just go through whatever you need and finish whatever you want to. And I can't thank you guys enough for doing this case early on a Sunday. I'm impressed. So.
And that too very early in the morning.
Yeah.
So all the staff also need to be thanked along with you.
I just really want to thank your club staff and everyone else because I know I would never be able to do that.
Hear us, right?
Yes.
So nice of you. Thank you very much, and you go ahead with that case.
All right. Thank you. Thanks for giving us the opportunity to do the live case, and we are here early at 5:30 a.m. here. Anyway, I'm Srini Parluri. I'm one of the international cardiologists and the chief of cardiology here at the Baylor Carter-Red, the Heart Hospital, Plano. And I have with me our regional structural director, Dr. Marley Zerlip, and Dr. Justin Schaefer, who is our CT surgeon, and also have Khaled, who's our structural fellow. We have 2 structural fellows every year.
Real hard team in the lab. Congratulations.
Yeah, yes, absolutely. We truly believe in our team, and we wish to continue it that way. And then with us, we have also our anesthesiologist, Dr. Patrick Boy. He is here early to help us with the case, and Armando is our echo page of perfusion, and our cath lab staff, Victoria, John, Brandy, and Lisa. They're helping us with all this, and we have Sheila and Ivy from the OR team. Box is here to support us with the AV needs, and our own audiovisual person, Anthony, is here with us, and he's been the one who's coordinating with Ujjwal to get this going here. So again, thanks for joining, and we're going to show this case of AI and how we're going to do JenaValve in this patient. Sushil, you have a lot of experience with JenaValve with doing the Align trial and etc. So please comment on what you think about some of the stuff while we're doing it. Any questions or comments at this point?
No.
Otherwise, I'll ask my.
No, please go ahead. You're
right.
Molly. Hi, Molly. How are you?
Hey, hi, Sushil.
So I'm going to ask Khalid to present the case. He is our structural fellow.
Good afternoon, everyone. So we're going to...
Presentation is there.
Yeah, next slide, please.
Next slide. So our patient is a 79-year-old gentleman with a relevant history of severe aortic insufficiency and heparin-induced thrombocytopenia, non-ischemic cardiomyopathy with HeartMate 3 LVAD placement in 2019, and CKD stage 3B, diabetic type 2, and ventricular tachycardia, history of ventricular tachycardia with CRTD placement, and prior subdural hematoma with prior history of craniotomy, and STS score is 5.13, high surgical risk, New York Heart Classification stage 3, and BMI is 27.8, and the plan is for JenaValve 27 millimeter, axis right transfemoral, right conferral. Yeah. So he presented with a progressive dyspnea, as I said, New York Heart Classification 3, recurrent admissions with decompensated heart failure, cardiorenal syndrome requiring dobutamine infusion. So we did the right heart cath showing right atrial pressure is 22 and mean pulmonary artery pressure is 41. Pulmonary capillary wedge pressure is 31, where the cardiac index is 1.55 and peripheral resistance is 3.05. So we did the LVAD ramp study, and it was a formal echocardiographic LVAD ramp study, different speed and incremental increases in the LVAD speeds were associated with progressive worsening of the aortic regurgitation and accompanied by a reduction in the cardiac index. And given the persistent symptomatic LVAD-associated AR, despite the optimization of the device settings, we proceeded with the transcatheter valve placement using the Jenna valve.
Next slide,
please. So here our frailty assessment, he failed the grip and the 5-meter walk, 2 out of 4. Next slide, please. So here we can see the 5-chamber view showing the depressed LV function and severe AI. Next slide, please. And here we can see the AI with the ramp study at 5,000 and 5,500. So we can see the worsening if we compare it with increasing speeds. And the CT analysis is showing the short annular diameter is 24.8 with a long annular diameter 29.8, annular area 563, and perimeter of 85. So the plant valve size is done at 27. Next slide, please. Yeah, and here the coronary heights showing left coronary height is 8.1 and right coronary height is 22.5. The sinus of Valsalva diameter is 35 and the STJ is 33.2. Next slide, please. So here we can see the angle, which is 51 here and less than 70. Next slide, please. And the femoral axis evaluation, as I said, we're planning for right transfemoral, and it's showing the minimal luminal diameter here is 9 millimeter. Next slide, please. So in summary, a 79-year-old gentleman with a STS high 5.3 and high surgical risk, planning to go for a 27 millimeter Jenna valve via right common femoral artery access.
All right, thank Khalid. Any questions? I think we are having a very high-risk case with a lot of comorbidities, and who's not. It was very difficult for him to stay out of the hospital, so that's how we ended up choosing to do Jenna valve in this patient. Anything to add, Molly?
Yeah, so in the past we've done quite a few of these LVAD cases, and before we had this valve available to us, we would have to use one of the commercial valves, which makes it a little bit more difficult because it's not made for that. So once this got approved, it has been really nice to be able to use a specific valve that's made for AI. Makes it a little bit easier to be able to get the job done with this and get rid of the AI.
No, I think that's great. I mean, just for the audience here, some of them may not be familiar with LVAD associated AI. I think it's an important issue in LVAD in use is increasing in the U.S. and especially in older patients, and in a significant percentage, as Molly and Srinath mentioned, you see AI. And oftentimes the AI gets underestimated because it's continuous flow, and so what oftentimes is called moderate AI. And they did the ramp study where they increase flow and the LV/EDP keeps going up, and really emphasizing that the AI is playing a prominent role. But I think and the challenge, and like Molly said, we've done those off-label ones as well. But the risk is that if it doesn't anchor those patients, then you are already high risk and you're going into high risk surgery. Because we spoke earlier today because people are using off-label TAVR for AR here, not talking about in VADs, but we're talking about off-label TAVR for AR. And so this topic is relevant because there's some of that going on here because it's not available. And so we're hoping that Jenna will be available at some point, but It is a challenge, but it's clearly a high risk case, and I think they seems. And one comment that was made, maybe it's worth sort of discussing, is the MR. The MR looked pretty significant on that echo. Maybe worth sort of commenting that I don't know. Because what you do is if you decompress the LV by getting rid of the AR, the LVAD will sort of take care of the MR is sort of the rationale. I just wanted to maybe sort of have that conversation because people look at the echo and they say, wait, why not treat the MR? And so it's a whole different entity here. So it's really about decompressing the LV from the AR.
But many times you've seen when do TAVR, AS and MR also regresses. Correct. That's just the heat. Farang wants to say anything?
Yeah, I was just wondering. So this is a primary symptomatic indication because I don't know, can you improve survival in this patient?
I mean,
That's a question.
So there is a study going on called Yenavad, but it's really about symptoms, right? Trying to keep this patient out of the hospital. Because, I mean, the way I look at it, you've made such an investment in this patient. It's been 7 years, I guess, since the VAD, and they've done, sounds like, reasonably well until this year when they developed AI, right? So this patient has tolerated the VAD well, and I didn't see in the history of any sort of driveline infections or other problems. Sounds like they've tolerated everything until this year. Now the AI is developed, and so the issue is to keep them out of the hospital. And you're never going to get a study with survival and benefit in these patients, but I think symptomatic relief, I think, is clear, hopefully.
Size 27 is, how is it selected, Sushil?
Maybe Molly or Srinivas, do you want to comment about the sizing?
Yeah, so basically based on the perimeter and the average diameter. So one of the biggest things we learned from Align-AR trial, when the trial was done, when you look at the initial phase of the trial, the pacemaker rate was very high, over 20%. And then what we learned was oversizing this valve is one of the reasons why I believed that the pacemaker rate was high. And since then, the company and the investigators, as investigators, we started sizing it appropriately. And since after that, the pacemaker rate is now under 15%, with more of the experience that came with proper sizing. It's a self-expanding valve. Obviously, the minute you put it, you'll see here in a minute. But then it has to be sized appropriately. So based on the perimeter and the average diameter, we sized it to be a 27 valve.
Yeah, and I think as you can keep going forward as we were talking, but I think one interesting thing is you showed the low left main, and we've done early on in the series because the Yenna valve clips the leaflets away. It's a great valve, and people have low left mains. I know the sinuses are big here, and it's not as much of an issue, but you get better coronary access and flow because you clip that leaflet away. So the initial trials with Yenna, there were some AS patients that were done as well, and so
lights down, please.
You could. It was a good example.
What French is this valve now?
So I think it's an 18 French sheath. And so you see here, if we could make the fluoro big, it would be easier for us. I don't know if they're...
Take the wire out.
Would it be possible to make the fluoro big?
Let's make the fluoro bigger.
Oh, that's perfect. Now we see it.
Good.
Perfect. So it's a long 18 French sheath. It goes all the way into the arch in the ascending aorta. And so keep going, as Srinivas and Molly, you guys you talk through it, please.
So far what we did was we got the both axes and we got the multi-purpose catheter up in the aortic root. That's to give us the basically the anatomy, and then we got this. We pre-closed the groin and got the Yenna valve sheath all the way up into the STJ, as you can see on the fluoro. We did take a picture to select our coaxial views, and that's our coaxial view, LAO 8 and cranial 9. So it's very important to establish this coaxial view when we do Yenna valve to make sure all our the locators, if you can see where Molly is pointing here, those are the locators. Those are the ones that go at the bottom of the cusp. And in the coaxial view, you get it there, and then we'll demonstrate as we go. We'll swing the C-arm to RAO to make sure we are commissurally aligned, and then advance the valve all the way down to the cusp with the locators going all the way down to the sinus.
So Justin, tell us, would you do surgery on this patient?
Oh, so obviously before all of our TAVR cases, we have sort of our backup plans as to how we're going to support the patient if something doesn't go to plan. In patients who have a previously placed LVAD in place, our options are quite limited in terms of support. So for this gentleman, we consider like doing some temporary, VA ECMO and or RVAD support if the patient were to crash. But a reduced sternotomy for like a type A dissection or for valve displacement is probably not in the cards for this gentleman. So we better make sure nothing goes wrong so that we're not pronouncing this patient live on TV.
And so you're going over. I don't see.
So we put the sheath all the way up into the STJ, and we're advancing the valve all the way to the STJ.
So it's not over a wire, obviously, because the sheath goes all the way.
So you need to get the wire. No. We need to put the wire.
Yeah. Can you guys get the wire, please?
As I was looking for the Safari wire, it seems
Hold
to
on
come
one
out.
second.
Yep.
So it's AI, so we're thinking that it'll go in without.
Without the. Will it go in without the?
Okay.
Hold on one second.
Yeah.
So as Justin was saying, if something was to happen with this, do you have a surgical bailout? Justin?
No, we just have temporary support bailouts, I think, for this gentleman. So,
Yeah.
like
So-
either VA ECMO or RVAD, but
It looks like
So
the Safari came out. So if you want some time, we can give you some time.
Yeah.
Do a lecture
for a minute.
Yeah, we can do a lecture.
While you're talking, we can do a checklist real quick. So to make sure, we usually do the checklist when we get the sheath up before we put the valve in.
Yeah.
Can you do the checklist, please, V? Yeah. Yeah.
$17 biomedicus arterial, $21 biomedicus venous, no balloon.
Use a regular implant. See if that would go.
No BAV. Thank you.
Nope.
I'm going to take it out. That's fine. Ready?
Wait.
Yes.
So what
we can do is if you guys want to recross, we can come back to you in 10 minutes if that's easier.
Yeah. Just go ahead and do a lecture. We'll be right back.
Okay.
It'll take two.
So
It'll take us a couple of minutes.
Oh yeah, can we
wondering why
go to the slides for a second? Wait, maybe we'll wait because you're already across. That was quick.
It helps when there's AI and not AS.
I guess so. I guess that could.
It's okay.
Give us one.
We have
second.
Bruce here with Jenna, and he's helping us flush this out and stuff. So.
Yeah. Be right in the correct
There it goes.
place at the.
So,
So my nurse asked what the valve positioning plan. So I was saying.
So I have been at our institution. Torsten's done most of the VAD cases. I haven't, you know, when we do them, they turn down the pump. I'm not sure it's necessary. They turn down the flow rates. I think Jacob, are you guys planning on turning down the flow rates? You know.
Yes, that's a great point, Sushil. It's like you said, it might not be necessary, but we always do turn down the speed. Right now, the speed is at 5,800 RPM. We're gonna turn it down to like in the 4,000s and see if you know that'll help the valve stabilize and position where it needs to. And now we're going on the wire. Obviously, it needed to be going on the wire.
How does LVAD causes
wire?
AA? How does LVAD causes AA?
How does what? I'm sorry.
LVAD causes aortic regurgitation.
So I think part of it is the inflow cannula is there, and when you have an LVAD patient, the aortic valve isn't normally opening well. In some cases, it doesn't open at all. So that constant pressure and flow, I think it potentially it's a damage on the leaflets. So that's the mechanism. So now here they do a small check here because to make sure the locators didn't get infolded.
Yep.
And so
And you can see the 3 locators there.
So the wire's coming back a little bit there. Yep, there you go.
Yep.
And so the sheath is down at the STJ. So the entire valve is, you know, the sheath goes all the way around, unlike most other valves, is to protect those locators because they can injure the aorta as you travel around.
Tell me how far. Okay, ready?
Are you guys happy with
So
that?
you don't
Yeah, we're
need
happy.
pigtail in the aortic root?
Yeah, you put the valve right there and then you pull the sheath back.
So now you see those locators open up. We don't put a pigtail in the root because we used to do that and we had an embolization. I think there was one where, because the pigtail can get caught in the locator when you try to take it out. So that's why I use a multi-purpose so it doesn't get caught on a locator and yank the valve out.
So what we got the valve there, and now can we show the handle here so I can show them? So now we deflect the valve to center it into the aortic root where the aorta is. So I'm here adding the deflection here. You'll see the valve move a little bit. So before we try to position the valve, I'm going to extend this valve into the root a little bit by 1 centimeter.
You kind of keep your thumb on it and
You can see I extended it out.
Yeah, and you can see the locators have started to open up a little bit.
Okay.
So
check on echo also.
So you can do this
So
with
we're trying
TE
to
or it
center
can be
the
done
valve.
fluoroscopic here. And this patient is under, it looks like conscious sedation, so then no TE.
So what we did was we
we're looking to see if all 3 of them are in the correct cusp, and then you move your C-arm suite to see if it is anterior.
So what we just did was we got the C-arm to the RAO to make sure that the locators are in the right cusp.
So what you can do, what they're talking about is in the coplanar view, you want those 3 locators in all 3 cusps. But when that coplanar view, you don't know if that middle one is behind or posterior or anterior. So if they go from LAO to RAO, that locator is going to move towards the right side of the screen, and that tells you that it's in the correct orientation. If it moves the other way, then you know it's 180 degrees off, I guess.
You can check by
Correct.
echo and TE.
You can check by TE as well if you
Right
want to
there.
do a TE. Yeah.
So we're repositioning a little bit here. There's a little bit of repositioning. The biggest thing is once we get it all straightened out, then it's a quick step. So I'm checking again. So there, the middle thing is on the right side, which is where the right cusp is.
So what was your coplanar view again?
It's LAO cranial 10.
Okay, so this is your, this is your coplanars.
that.
Okay.
Yeah. Yep.
Mm-hmm.
So as it
We're now
advances down,
getting the valve in.
yeah. And
We're pushing
if
the valve
those
in.
locators
So you
splay
can-
out, that tells you that you have the leaflets. And it looks like they did. It looks like you have the left and the non, right?
Yeah, if y'all notice the little splay on the left.
Yeah. It did splay on the left, it looks like, right? Because sometimes what happens is you don't see the splay, and so you've missed the leaflet, and it goes into the LVOT. So you have to really make sure, and you do this with angio if you're doing it awake. So they're doing a small injection. It's hard when there's AI. That I guess the multi was sort of maybe.
Yeah. Hold on. You want it in the. You want to check the left?
You're on the left cusp, yeah. Yeah. See, the left side is in the right cusp, but not in the left cusp. So we'll come back and then re-advance it. I'm pulling it back. And had a little more deflection there.
So the maneuvers are either deflecting the catheter and so sometimes pulling on the wire gets you more central. So it's a little bit of wire and catheter manipulation to sort of change orientation.
But you don't rotate?
They did rotate. So early on they weren't there and they rotated. So then in the coplanar view, one was in each one, and they made sure when they went from LAO to RAO that it was in the correct anterior position.
Do you want a cine?
Push the spray, yeah.
Do you want a cine?
Yeah. That's on the right cusp. Yeah.
I think the multi's in the right now. Yeah. This is sometimes the most painful aspect of the procedure.
Yes, it is.
Positioning that multi, right?
Yep.
So now they're looking at the. You guys gonna look at the right cusp?
Can't do it from
Yeah.
Mm-hmm.
Yeah. So they've gone to a view which, positions the right a little bit lower so you can better assess.
I can't do it. Thank you.
We might be in it.
There.
Okay. Yeah.
No,
right
I'm
there.
still in the right.
Yeah, that's good. Okay, right there.
Yeah, and I'll be honest, I would say 50% of the time we end up using an AL1 to get to the left cusp because it's this, as I was saying, I'm like half joking, getting the shot of the left is a miserable part because you have this whole valve in there, you're trying to reach over and you're trying to torque these catheters and the multi doesn't go very easily to the left. These big aortas sometimes, right? These big aortas, it's hard.
And then you get a interplay with the big sheath and the
yeah.
What? Back.
So, and one aspect here is these you can notice we don't see the hemodynamics, but these patients generally are very stable, right? They already you're not making their AI worse. You're central with the catheter. If anything, you're occupying some of the space where their AI is.
Space.
And you have time, and this is because as I think Molly said earlier, the deployment's very quick and once you're in the right position.
Right.
So this is where you spend your time. You just want to make sure that all of these things are in the right location, and then.
Yeah, most of the cases do go very fast, but there are some that we may. I mean, there was a case I still remember took for almost an hour just to get the locators all the way at bottom of the sinus. And once you get it and all, it's very quick.
Yep. Yeah.
Hold on one second.
Right.
There we go. There we go.
We do.
That should be correct.
I think less contrast. I'm okay. I'm okay.
Good. Still on the right course.
Biplane.
I don't think so because you got to get. I mean, I guess you could set up a biplane in those two views, but that would be cumbersome. I don't. Yeah, I'm not. Yeah.
Yeah. You all
guys
saw
see
that?
it?
Yeah.
You just show the left
So-
cusp.
so
the
you
left
see here-
locator and the left cusp.
The left cusp
Yeah.
looks good, right? You see, it's on the inside of the leaflet. I mean, the outside of the leaflet. So, and I believe you guys took a picture. I missed it quickly, but you took a picture of the non already, right?
The non in the
You
beginning.
did
We
early,
can do it again.
and then do you have to do the right, or did you already do the right?
We did the right with the multipurpose.
Okay. Great.
We'll also have the multipurpose back.
Yeah, and they'll go back with the multi here, because, and then I think Srinivas mentioned earlier that the pacemaker rates were high, but, and they're still quite high. If you look at even the continued access series, it's still around 15%. It's not 25, but it's 15.
I assume they're going to exchange this for that.
And part of it is the oversizing. Part of it was the depth. Before in the early experience, we were always so worried that it was going to embolize. We pushed forward aggressively. Now they're going to generally position that marker right at the annulus and not push forward as aggressively. The challenge, as they've shown in some of these cases, if the aorta angle is tough, you end up being pushed aggressively on the left because you need to try and get down enough on the non as you look at these angles.
Right, and that's one of the things that's like screens out these guys is if that angle is too steep.
Yeah, and the other thing we've learned in this series is the majority of embolizations occur on retrieval of the delivery catheter. So you never get excited after the valve deployment until the delivery catheter is out. So because it's AI and it's not that yeah.
But you need ACT around 250 or?
Yeah, that's what we did, 250. Maybe a little more aggressive because it's a long sheath.
Right, and this he had hit, so this guy's on angiomax.
Oh, I see.
Yeah, Patrick, what's our ACT right now, boss?
Okay, can I?
482. We're being aggressive
Ready?
today.
Yeah.
So you see that's clearly in the non-coronary cusp.
Yep.
So I think we're with all the cusps. I'm going to check the right again for to make sure. Is it right on the right side of the screen? There it is. Can I?
Wait, it's not.
Yeah,
Yeah, okay.
So this is the right cusp. So I have all the locators where they need to be.
So he's verified all three locators are at the base of the cusp or in the correct cusp. They're not all equally at the base sometimes, and that's okay.
All right, so now we are here for the final deployment. So before we do the final deployment, we'll go down on the LVAD to around 4,000. And then once we set up the LVAD, we pull the multipurpose back, and we usually try to do the final steps with the pacemaker on. So is that how you do, Sushil?
Yeah, I mean, I think on the LVAD patients, it just depends. If there's not much flow, then it's less of an issue.
Okay, yeah.
It's really, yeah.
But
we generally do with pacer because our one embolization was before early part of the experience. We weren't pacing during deployment, and it was a liver failure patient that it was high flow, and the valve embolized aortic. So after that experience, it's always been pacemaker.
Yeah.
Yes.
So what I'm going to do is, as that's all the steps of deployment, I'm going to take this green stopper away, a limiter, if you will. So and then just turn and then push. Very quick deployment. You'll see that here in a second. So I'm going to ask our anesthesiologist to go and start tracing here in a second. Okay.
Yep. Ready? Pacemaker
on. Okay. Capture. Turn. Let go. And then push. Let go. All right. Deployed pacemaker off. Laura? So the valve is completely deployed. Now, another important step that comes along with this is to take this nose cone out. It can drag the valve if we're not very careful about it, and we just need to manipulate the wire and the catheter together and try to get it out. So I'm gonna try to center the wire along with that, and
Be careful right there.
Did you see ever a case with embolization in this situation?
Yes. In the trial, these were more the embolizations were on delivery catheter retrieval.
Oh my gosh.
So that so
grasping defeat from the jaws of victory.
Exactly. And that's why they have these aortic root angle of 70 for deployment as an exclusion, and the reason for that is retrieval of the delivery catheter in the ascending aorta. That's the biggest challenge, and so we've done some aortas that were bigger.
There you go.
I did.
All right.
I mean, I think Molly, as I told you, I think I said before, I don't know if you guys heard me, this is the scariest part of the procedure for me.
No.
I feel like I hold my breath the whole time.
How often do you
exactly.
need? How often do you
So
need?
there we are. So we got the deflection out. So there's another important step too, which
Yeah, I'm holding it. I'm bringing.
zoom out a little.
I'm trying.
How often do you need post-dilatation?
Rarely, almost never. I think we've done one out of more than 100
So
cases.
that's
Yeah.
sporadically.
I think this too high.
And it was a patient where it was sort of really borderline for the size, like the biggest size, and we were trying to just expand it a little bit more to see, because we had PVL.
So one of the important steps comes here is again to load this into the sheath.
Right.
No, this is
You have to-
associated there or part of trial.
It's approved.
Take care with your wire. Wire is in the valve.
Yeah.
You almost lost you.
There we go.
All right, so we're all in the sheath. The valve is deployed. We go ahead and check the echo, please. So we didn't have a TE. We did not want to do a TE on this. So we have a transthoracic echo. We'll see what kind of images
Can we
get here.
see the echo screen, please? Can we switch to the echo screen?
Yeah.
Ramp.
Go to 5,000. We're going to slowly go up on the LVAD back to 5,000. You know, one of the things I realized, Sushil, is at least in our LVAD patients, we had a pretty good amount of GeneVAD cases that we did. One of the things we noticed is the valve gets thrombosed if we run very high flows in the LVAD. So we try to keep the flows around 5,000 and not run at close to 6,000 RPM for the LVAD flow after we do the NVAD. NVAD.
Can we see the echo? We're not seeing the echo.
Okay. Hey, can we see the echo, please? All right.
So I think that's a great point, Srinivas. I agree. So part of it is like if you run the VAD too high, the leaflets won't open and they're going to thrombose. So and sometimes the leaflets don't open, but if you can have some leaflet motion, I think here we see some of the leaflets moving a little bit. But if you can have some leaflet motion, that's better. And that's why I was saying the LVAD is being run a little bit slower.
What are the specific views to locate the depth locators? Every single.
So they were that marker band that you see here during deployment. They positioned that at the annulus essentially. And that's what you use. So some of and it's going to drop in as it goes. So because you're non-coaxial, all of those locators aren't at the base of each cusp sometimes. You try to position the marker band at the level of the annulus, and then it will sort of drop to the right to that position.
You told about the depth actually. Anyway, it will never go deep. Anyway, it is all locked.
If your locators in the cusp, it can't embolize below.
It can't go any further.
But before we would push aggressively, so it would end up 8 below, and we thought that was contributing to pacers. So now we try to just keep the marker band at the annulus, and ideally 4 or 5 below. Yeah.
Okay.
You don't have the control like you have with the balloon expandable. It's going to drop to where it wants to drop, and that's fundamentally the issue.
There, and you can see it all nice in that. Can you go back to Flora? Can you guys see the Flora?
We see the Flora. Yep.
Okay.
Yeah. So it's now fully deployed. You can see both the coronaries fill very well and the valve in the right position there. It looks pretty good. Actually, there's some forward flow through the valve, which is what I would like to see. And he has pretty good.
I mean, I think the shot is good as well.
Visibility too.
Yeah, the contrast is clearing, and so there's some cardiac output through the valve, which is good. And
you see that in our hemodynamics as well. Like we were totally flat prior to ramping down and probably to Patrick administering some inotropes, but now we have a reasonable amount of pulsatility on our hemodynamics here.
oh, can we see that? That'd be great to see. Can we see the hemodynamic screen, Molly? Or I see it now.
Can we?
Yeah. So that's great. Yeah, you see the hemodynamics. That's nice pulsatility. So what about anticoagulation, antiplatelet regimen? Yeah.
Sushil, can you repeat that question?
What anticoagulation or antiplatelet regimen will you do? One of the audience members was asking.
Yeah. So, normally we would put them back on their Coumadin and run their Coumadin around 2.5 INR. And as far as antiplatelets, I'll just go with the big, low dose aspirin. Are you guys doing anything different?
No, same.
You're supposed to give Coumadin for this.
In the VAD patient.
Yes.
In the VAD patient, yes, because it's a VAD.
For LVAD.
Not in a normal but in a VAD, yes.
All our heart rate 3s are going to be on Coumadin anyway, unless they have some sort of hemorrhagic event like a GI bleed or, the risk benefit of being on anticoagulation and LVADs is always a toss up, right? Because you're always at risk for your late GI bleeds versus risk for thromboembolic events, although we've seen very few with the heart rate 3 VADs in our patient population.
So for Geneval, we don't need anticoagulation. The anticoagulation here is for the LVAD.
Yep. Okay. All right.
So we deployed the valve. So I'm going to take the delivery system and the sheath out, and here we already pre-closed, and we'll just close our groin. If you want to watch it, that'd be fine too.
How often do you use a pressure injector for the injections?
Pretty often for regular cases, but this one we are doing NOVAD that I have to manipulate my catheter into all the cusps multiple times. So we just do hand injection for this one.
Yeah.
This is pretty standard closure. No?
So do you guys do one per close or two? I was noticing
We do two.
I got it.
Yeah, I do as well. I just noticed in the live cases today, the majority did one per close here. And I don't know if it's because of smaller vessels or something, but everyone seems to be doing one. But I still do two in every case. So
you use it too?
Yeah,
me too.
Yeah, we did too. Like right here, you saw it looked pretty good, no bleeding. So we always do put a micropuncture sheet back and take a picture before we finally tie the knot on the per close.
Okay.
You have can I have the contrast, please?
Take the wire out.
Oh, there's another way to do check.
Yeah.
The micropuncture.
I learned something. That's a nice way to check, because that way you don't have to cross over. You get a sense.
Yeah. There's good flow.
Yeah.
So we check for bleeding and we check for any issues before. And we have routinely been doing radial access for our second access. And we also, if we need to intervene, we always we have radial to peripheral sheets that we use.
Well, again, this was a great demonstration. I know it's a technology that's not here yet, but I was giving a talk on it earlier today, and there's a lot of interest and enthusiasm. And hopefully, because they are doing off-label, one of these dedicated devices. The hope is we'll be here shortly. And so, again, I can't thank you guys enough for doing this early on a Sunday. Hope you can go home and get some more sleep.
Srinivas, a big congratulations, round of applause from the hall.
Thanks to everyone, Molly, Srinivas, Jacob, everybody. Thank you so much.
Thank you so much.
Thank you. Hope you heard those, and we're proud of you, Srinivas. You being from Usmania and now doing great, heading that place and helping us to run this program, this live case here. Thank all the staff also who cooperated with you, came very early, and We thank you enough. And now with Sushil being here, we could modulate it correctly because we do not have that experience of this valve is not in India. Thank you, Sushil, too.
Okay.
I think we can. Any last words you want to say? Okay, thank you.
Thank you. Thank you so much. Bye.
Before we close, I want all of you to just listen to this acute stroke intervention talk. Will be brief. Suresh, are you here? Yep. Thank you. Sushil, Suresh, and thank you very much for sparing time and coming because I want our cardiologists to get into this space because not many people are there around like you who can handle these acute strokes. And please go ahead and deliver the talk.
Can you see the slides, please? Yeah. Much. Okay. So at the outset, I want to thank Dr. Srinivas Kumar for giving me this opportunity to spread the awareness about the stroke interventions. Next slide, please, on this one. So we have got the guidelines actually on the data regarding 2026 where we are. Basically, the guidelines have started in 2015 to 26. So just I want to conclude the guidelines. So in 2018, when the guidelines started, it was only limited up to 6 hours. Later it got extended in few selective cases up to 24 hours. And location is only for anti-circulation. Now in 2026, the guidelines have extended up to 24 hours, pediatric strokes, and even post-circulation got into picture. Only few are left over. So basically, so Sarah asked me to demonstrate the technique. So for the those who are not into stroke intervention, basically we capture the clot. We don't put a stent over there, unlike coronary. So we pass a MEG catheter across the clot and we deploy a stent retriever, which has got a wire attached to it, pusher wire, and it is non-detachable. And we capture it and take it into the guiding catheter. So while doing so, we'll try to inflate the balloon guide. And or you can you can pass a malleable soft catheter, which is an aspiration catheter that goes right into the head of the clot, into the MCE or IC or bacilla. So this is the second kind of device. The first one is the stent retriever. The second one is the aspiration catheter. You can use in combo also. So this is how the simplified schematic representation. So once we pass the guiding and we go the stent retriever deploy, then we pull it out. So the entire assembly of the aspiration catheter and stent retriever basically comes out, and the clot is captured in between them. So most of the lesions are embolic. So this is how the clots are basically draped over the stent retriever and aspiration catheter. So how we do it? So we use 3 coaxial devices. One is the long sheath. The other one is the intermediate catheter. The third one is the micro catheter, which is for the stent retriever. So long sheaths we have got in 8 French. We have got to have 8 French femoral sheath for that. And after that, through the long sheath, we put a coaxial system of 6 French systems, which have got the ID of 470 average. And through that, we'll pass the micro catheter, which is a 421 ID. And we pass stent retrievers of different size, most common being the solitaire or embo trap that we'll place. There are 4 mm and 6 mm diameters. For the ICA, we'll keep 6 mm, whereas for the MCS, we'll keep 4 mm, we'll choose 4 mm ones. So we have to prepare a triaxial system with the flush systems on with the RHVs. So one is for the BGC or the long sheath, and one is for the DAC or the distal access catheter. The third one is for the mic catheter. Once it is done, then through the mic catheter, we'll push the stent retriever across the stent. So this is how once the long sheath is there in the distal proximal ICA, see that the wire is now probing the clot. It is in the supraclavian ICA. So we need to land it in a proper vessel, because we need to land it in the most straighter one and larger one, which is usually the inferior division that you see in both in AP and lateral. Once you land it, then you, this is a diagram representation. In the insular fissure, you land it in the inferior division. And after that, you retrieve it out. So once you land it out, the mic catheter is passed. And after that, through the mic catheter, you deploy the stent retriever. So the megacatheter is being withdrawn to optimally position the stent retriever. You can see the stent retriever markers over there, and stent retriever slowly getting expanded. Basically, it's a self-expandable stent. So it sits across the clot, and you have to position 2/3 distal to the clot and 1/3 across the clot, and then you approximate it to the aspiration catheter if you are doing a combo device. So once you take it out, then the recanalization happens. As you can see here, entire the ICA bifurcation, MCA got recanalized. So this is one more example how to put a stent retriever distally, or distal to the clot. You need to place very distally so that you get the entire clot out. So this is the diagrammatic representation. So when you are taking the clot out, the stent retriever, along with that, you are basically putting the DAC also. The DAC is applied for a suction, and so basically it kind of cogs the clot, entire clot between the stent retriever and the aspiration catheter to get the clot out. So this is how the real video looks like. So you see the aspiration catheter distal end there, and the stent retriever markers are there. So in the proximal end of stent retriever, the aspiration catheter head goes into it. So as a combo, we try to cog there, and after that we try to pull it out. So while pulling it out, we never try to telescope the stent retriever into the aspiration catheter, but as an assembly, we'll try to pull it out. So that is a basic technique. So you see the long sheath being pushed distally for wedging, so that it's kind of acts as a balloon guide catheter, and after that you are trying to pull out the entire assembly. So the long sheath will be staying over there. So this is what you get. Usually the clot will be draped over the stent retriever and cogged between the tip of the aspiration catheter. Part of it is into the aspiration catheter, part it into the stent retriever. So this is how the different clots look like. Usually it can be a red clot or a white clot. White clots are difficult to get out. So this is the ideal positioning. If you are using only stent retriever, 2/3 should be distal to it and 1/3 across it. And if you don't properly push and plough it, you just pull it out, and it may scrape the clot but not capture it, and it may remain so. And the distal occlusion becomes a proximal occlusion because of the clot migration. Or if you are not positioning properly, distal and not distal enough to the clot, then it may only partly capture it, part will remain there. So that also can give rise to still persistent occlusion. And if you are not doing proper aspiration while pulling out the stent retriever, it may give rise to distal embolization. So if you are going only for the aspiration catheter, so it has to basically in axis abort into the head of the clot. So that is a way to get the clot out. Sometimes if you're not in contact with the clot, basically you are under the roadmap, you are touching the clot, you are thinking the proximal margin based on the contrast staining, but the contrast staining may be proximal to the actual head of the clot. So you have to go into the proper head of the clot to get the aspiration, the clot out. Or if it is a long clot, it may get shared. So that's the reason why people add stent retriever to it, so as to get the entire mass of the clot get incorporated into the overall assembly. And if you undersize it, it may just go underneath the clot rather than capturing it. So properly sizing the aspiration catheter according to the vessel size is very important. And axis is very important. If it's distal, you need to properly align across the clot axis. Otherwise, it may just stay there. It may just see it and come back without any actual aspiration. And sometimes if you push too much, it may buckle also, and it may cause basically clot disintegration, clot buckling, and further process will be difficult. So in combined technique, basically the technology of both the aspiration catheter and stent retriever are combined. So this is the ideal position where the stent retriever is placed distal, 2/3 is distal to the clot, and the aspiration catheter is into the head of the clot, and you capture and take it out. Inadequate position across the clot can cause non-capture, and undersizing of the aspiration catheter can cause non-capture. So these are all the technical basically fallacies that you should be avoiding while capturing the clot. And a few two more examples. This is a case of IC and M2 occlusion. You can see the white ones in the MRI are basically infarcted areas, and the spared ones are the green ones. So basically, we are trying to save that particular tissue, which is on the left side, dominant side. It's like a very tortuous carotid. So we did a direct carotid puncture, and after that, place a 6-inch sheath. Through that, we are passing the aspiration catheter. After doing initial aspiration, we could unmask the entire ICA, but there is distal occlusion. So now the beauty is that we have got very distal devices also. We have got a couple of occlusions there, predominantly the anterior ones and posterior ones. So we targeted the posterior one, which is the tissue is spared there, and the red one, red triangle. So you see that the catheter and aspiration catheter assembly, they are going there, probing the clot over there. And after that, we deploy the stent retriever there. And after that, we similarly cock the clot with the aspiration catheter. And you see that this segment is open now. These entire branches which are labeled now, they got open. And on the AP also, you see that extra vessels got opened as compared to before and after. And you see that entire tissue which was spared initially, we could save that. And he's ambulant, he's doing good. This is another case. This is basically ACA, distal ACA occlusion. So this is the site of occlusion. You see that red color, the marking is missing there. So there, this is distal ACA occlusion. You can see that it's missing there. So once we cannulated that cross that particular thing, we deploy the stent retriever, and after that we are passing. You see that the aspiration catheter goes and sits across the clot, just at its head, and to cock it. So once we cock it, then we try to pull the entire assembly to get the clot out. So this is the before and after image. You can see the clot, very small clot sitting over the stent retriever. And this is follow-up MRI and our clinical follow-up. Thank you.
Thank you, Suresh, for sharing. I thought you'll also show your experiences. I think I've never seen having 250 plus cases experience. You generally show that, but he has to his credit, a significant number of patients, I think 250 plus procedures, and where many patients' lives are saved and debility is saved, and nothing great, I feel, then you prevent patients being bedridden with strokes. I congratulate you for great work and proud to be associated with you. I think because cardiologists not exposed, not many questions would be there. We're also running behind. And thanks for joining again. And if there's anything you would like to ask, then well, otherwise close, and then this will have a highlights video and followed by our national anthem. Then we'll close. Is the highlights video ready? Yeah. Yes. I'll also stand that side and see because I have the pleasure of watching it on the main screen. We'll go there, sir. We'll watch. I request all the pharma colleagues and everybody outside to come inside the hall to watch this highlights video. Just give one or 2 minutes time, or you play that intro video first. By then people will come. Then we can play in the highlights video. Highlights video I'm also seeing first time along with you people. I think we can play that intro video followed by highlights video. Is that okay? I think I was very happy that we ended with a very good live demonstration of a first time aortic regurgitation case, very elegantly done. And then initially we were worried about the patient, but God cooperated. I was praying to God that patient should be fine. Again, the patient who had a cardiac arrest also was saved, and that's the intentions are correct, and God will cooperate. Thank you. So let us have that intro video followed by highlights video.
India, a land where tradition inspires innovation. A nation that continues to redefine the future through science, technology, and healthcare. A place where every breakthrough carries the promise of transforming lives. At the heart of this journey stands Hyderabad, a city where heritage meets cutting-edge research, where medicine, education, and innovation come together to shape the future of healthcare. For decades, cardiology has transformed the impossible into reality. From the first coronary interventions to life-saving stents, from advanced imaging to minimally invasive structural heart therapies. Every innovation has brought us closer to one goal: saving more lives. Recognizing that progress demands collaboration, FACS Foundation was created to advance cardiovascular science through education, research, and innovation. Over the years, it has become a platform where knowledge is shared, evidence is strengthened, and future leaders are inspired. Today, its vision extends beyond intervention towards prevention, disease modification, and better outcomes for every patient. As we gather once again, we celebrate not only the milestones we've achieved, but the possibilities that lie ahead. Together, let us inspire new ideas, drive meaningful innovation, and shape the future of cardiovascular care. FACS Foundation, advancing science, inspiring innovation, transforming cardiovascular care. Welcome to ACVS India 2026.
Thank you all. I hope that was a good video. I also liked it, and thanks for the AV team for making this because I watched it first time. Anything seen on the big screen looks great, and the good sound and everything was perfect. And wish we could have covered some of the live cases pictures too in it, but obviously you can't have everything in the highlights. And as all the good things has to come to end, and we are now come to the end of this ACVS India conference for this year. The 17th edition successfully finished. Some of the pleasant things which I noticed this year was extremely good response of all the colleagues across. I think that is because we reintroduced our challenging cases concept, and because so much of response in the first day I had to create, we could second hall, and Brijesh suggested how to do it, and then that's how we created hall B, and which was immediately converted to this big hall on the successive 2 days. And thank you for all the ideas and suggestions, Beaver, Mansi, and Brijesh. And then other thing which was pleasantly happy is, I don't know whether it is good or bad, since last my better half Anita has come. I think we'll play her video highlights next time once my talk is over. This is basically what I feel very happy is all the colleagues across the country also took part, especially my local Telangana state CSI colleagues also were part of it, and many of them contributed very heavily, and in various capacities they participated. That again gives me a lot of happiness. And apart from my Apollo colleagues who were anywhere there, I think Vamshi is sitting here, Sanjeev, Gokul, others who take care of my patients there when I'm here. So I'm extremely thankful to a group of good people. Many people ask how we're able to deliver this. And that is all because of the support of all our team members and cardiology colleagues and Apollo professional colleagues. And then my Fax Foundation, normally people employ some event management companies and all that to do it, which I've been not doing. That's also possible because people are associated with me in foundation from the beginning. Noor Khan communicates, and then Ramakrishna takes care of finances. Pramod is my secretary, takes care of my patient and these other activities too. And sometimes we get irritated and all that, but still they tolerate all this. And then thank you all my team members. And then I also should be thanking all the industry partners. I think many of them are already noted, and if I can project that, it would have been better. But anyway, you've been seeing it there on the right and left. Without that, it was not possible to have this. The support, I think people are standing, can come inside, please, because I would like to thank all of you. So basically, it didn't happen overnight. The process starts, and why I say they're not sponsors alone, because I say it as academic partners. The knowledge partners, what I mentioned there is basically the series of programs which you do throughout the year. Each of those company wants, actually cooperation and respect is also mutual. If the company wants some program, we help it without expecting anything. They also in return own this program and do it. That STEM India program which we do, the other various interventional complications program, the Upgrade You program, each of the company, like Face the Examiner program, with one of these major sponsors outside, we always do the program. And that's how mutual cooperation respect happens. And all this year, another thing we're presently noted, I think, is Sun Pharma, Raghu, and they were telling me that response was immediately good because we released the program early, and seeing the program, most of the doctors liked it to come immediately to the program. And one thing good also happened this year is we had a lot of international doctors too. I think Mittal sir sitting here from Dubai, then Shamlal came from Mauritius, some of the colleagues from African countries, and significant number of colleagues from Russia, Kazakhstan, that looked like India, Russia are good partners to me. And it all happens through industry help. That MSN, I think, coordinated that, and so many other things. And in planning the live cases, the coordination and all, it's a challenge sometimes. You see how it happens means the Abbott colleagues, I think, who's Anil is sitting here, and Abhinav is sitting, but even the Subodh, everybody own this meeting and then be part of the organization. Coordination of activities across to all the centers is not easy, and cardiologists are different nuts to crack across all the country, but still, in spite of all that, we do it. And the international centers too, Srinivas Potluri, he was my junior in Usmania, did a fantastic job in demonstrating. I was very happy how the procedure meticulously done. And then initially we wanted to have a live case starting and ending. That was my thought, to have impetus. And so initially Saibal also mentioned that he likes me so much. Anytime I would do live for you, Srinivas, he was telling. That's all gives happiness to me. Why I struggle all this is whenever I see various colleagues across outside whom I don't know also keep thanking me that, sir, you do great program, we are benefiting. But that gives us satisfaction and impetus to do more such programs. But obviously this cannot happen, that sort of big screens and this thing. I want to keep it standard high, because it should be also live case based program, means it should be seen well on the screen, and suggestion by our team to make this horizontal screen so that you can see it well. All that went through well, and though we had initial small glitches with the internet, though in spite of having secondary backup connections. And Ujjwal, I think, are you there, Ujjwal? JTech? Yeah, he's a silent worker behind, very heavy body personality, but the great work he does. Thank you, Ujjwal, for all the live case, because its conference was basically involving a lot of live cases too. Thank you. Again, when I started this meeting, you were small. Your father was used to take care of it. Now you're making him proud and doing all the work. And congratulations to all the team members too. And then the Trident Hotel team and all these people also worked day and night. And I said, I want to treat my doctors well. I don't want food to be served in some balconies or some dungeon like parking places. They all cooperated and they vacated all their restaurants again and gave it to us. I think all the doctors had pleasant experience in food. And all the pharma colleagues, industry colleagues, I never would like to discriminate the places where food was served and all that. I think most of the days it was okay, but for the first day we had some challenges. I was told because I didn't expect so many people would turn out straight on first day. That worked. And the hotels, both Westin, Trident, had a lot of challenges in arranging rooms. Some of the industry fellow people could not be given rooms here, not out of intention. They were to arrange another 50 rooms in IHS or so that things. And I don't know how happy we feel in the end, because a lot of my family time, personal time is also taken. My better half Anita, she's sitting here. She was also entertaining our other cardiology friends' wives, things like that, and a lot of time. My daughter, everybody is here, and we should also thank them for this. And if anybody missed out in thanking, I think you should excuse me, pardon me, but because it was continuous effort from all of you, like if you have to mention company by company, it takes more time. But basically, I would like to say this, few important people out of the devices industry. The Abbott was main, Medtronic was also there, apart from other companies. And then we have pharma colleagues. Sun Pharma always is a big giant player, and they mobilize a lot. Not only they finances, I'd say, but it's also taking the meeting through the doctors. And then Intas, Lupin, USV, MSN, Reddy's, and all of them. And though we reciprocate in whatever forms they want, but I think all of the help was great. And this concept of inclisiran or Novartis, which they wanted, I personally also feel a lot of doctors could benefit. That's why I wanted them to get promoted. Torrent and Reddy's and Cipla is a new addition this year, because I would like to get associated with companies who have similar ideology and thought process. And there are some, because this meeting is successful now, many of them would come forward. But still, I want to go with companies who have good intentions. Like that's why I was behind Cipla for coming. They also came forward, and Torrent also in the process of getting better and better. I think with this, I think if anybody have forgotten, not out of intention, but thank you all for making this program successful. And anything you would like to be improved in future, probably you can suggest. Every year this meeting happens in last week of July, so they have already projected it as Bangalore, but many of them have said Hyderabad is also good enough. We'll talk to Sushil, Ajay, and all my colleagues across, and then the constant support have been there because I am not too much bothered about the name, but I'm bothered about the faculty. Who the entire core of the thing is you have to participate freely. If I request them anything to do, they're always willing to do out of no egos, nothing. Suddenly some chairperson is not there, I request them to immediately come on. So that sort of good faculty team, that's the strength of the meeting, because content of the program and the faculty should be good, and so industry mobilization also happens easily. That's a concept I work on, and I always feel that whatever little forms we can do, we should continue to do, strive hard, and I would like to put all my efforts in future too to make such meetings more and more. And all my colleagues across the country, cardiology colleagues, and then international colleagues, I'm extremely thankful. With this, I think I'll close, and because that video looked so good, I feel like seeing it once more if it's not objectionable to all of you. So I think closing video, at least we play once. Then finally we'll end up with a Janagana Mana. Okay, we play closing video, and then probably. Achha, she wants one photo of this side where everybody was staying. Can somebody take a picture this side? All of you can remain, and then she take a picture. Then probably. No, let them sit now. Moving all that, it becomes difficult. No, let us be there. You can take picture from this side, then probably you can do that. And meanwhile, you can the highlights video can keep playing. Thank you. think we'll play, I request all of you to stand and we'll end with the national anthem.
जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you.